I don't want to cut the whole pectoralis major, because if we remove the whole pec major, children have a kind of a contour deformity there, and once they grow up, that side of chest development it does not look very symmetrical. So we should try to keep this superficial part of the muscle intact. So I am going on the under surface and dividing the tendinous part. Even some part of the muscle will require to be divided, because co-contractions will go only when the substantial part of the muscle and tendon is removed. But the main aim is to keep some superficial part of the muscle intact, so that you have a decent contour of that anterior axillary fold. And some patients pre-op clinical examination, if does not show that there is too much co-contraction in the pec major, we don't have to do pec major release in all the patients. Especially there will be some patients who have limitation of internal rotation. So any patient who has limitation of internal rotation, for him we need to be very careful when doing the pec major release, because pec major is also an important internal rotator. So those children should not have further decrease in internal rotation, and they should not become handicapped that the hand is not reaching to the belt area. So that's why this part of the muscle we should keep intact. So that finishes our all four components. We further confirm that our release is enough by doing a shoulder abduction and palpate whether there is any other tight structures. So sometimes some facial band or some tendinous tissue, if it is tight, we can further go and release that. Some children, there may be tightness of the pec minor also. So the pec minor can be identified deeper to this pectoralis major right over there. We can see that is the pec minor. So this child does not have tightness of pec minor, but suppose after doing this much, when you do abduction, you feel that pec minor is tight, we can go and release that itself, that also. So that finishes our operation. And one thing again, while closing, we shouldn't just close the skin over like that. The skin generally goes and gets stuck to that released muscle and again forms a nice bad looking dimple over there. So we should make sure that we bring some fat tissue in between here and then do the skin closure.
Someone is asking to see all the steps what you have done.
All the steps, yeah. Okay. So just to again revise the 4 steps of this mod quad operation. So it is actually called as mod quad. Quad, we know that quad means 4. But interestingly, the mod quad does not mean that it is modification of some other quad operation. It is mod quad, it is actually modifiable quad. Modifiable quad means depending on the pre-op examination, you check whether pec major is requiring release, whether there is a need for any external rotation transfer, and whatever component is not required, no need to do that. So here 4 components are, we have done partial release of the pec major, the whole tendinous part we have released, and some lower part of the muscle which was looking tight. That's part 1. And in the posterior axillary fold, we first released, we take one here, so we first released the latissimus dorsi and teres major. They were coming like that over here. So that is the remnant of that. So we released and then we separated the latissimus dorsi and teres major. We got a very long tendon of teres major. Then at the lower border of the long head of triceps, we identified the teres minor muscle. And in this teres minor muscle, we hooked our latissimus dorsi tendon and sutured to that. So this is going to act like a empowerer to the rotator cuff. And once rotator cuff becomes stronger, the deltoid will function more efficiently. And in patients who have external rotation passively, this transfer can also improve the external rotation. It is identified by being posterior to the lateral border of the scapula and we confirm it further by doing an internal rotation and external rotation. You can see on internal rotation it is becoming taut, on external rotation it becomes loose. Anterior to the lateral border of scapula, going in the same direction, will be the subscapularis. We should not get confused with that. The last component is the axillary nerve freeing in that area. So it is not a real neurolysis, it is just like releasing the axillary nerve from the facial tissues all around. That is basically because whenever child does a shoulder abduction, the humeral head comes inferiorly and squeezes this axillary nerve against the tendon of the long head and that LD and teres major. Now LD teres major we have removed, and once the axillary nerve is freed from the facial tissues, it will not get compressed, it will just wobble and move on the side. So that's why indirectly we are improving the deltoid power by doing this freeing of the axillary nerve. So these are the four components: 1, 2 release, 3 transfer, and 4 the axillary nerve. Vicryl.
Thank you, sir. Now we move on to OT2.
Yeah, look, what I was telling her was I split the deltoid to get my area of the bone where I'm going to put this bone anchor. I'm not going to detach it yet. I'm going to leave it as it is. Here, my intention is now to dissect this entire muscle off. So once I've inserted the periosteum here, then I do a subperiosteal dissection, and it's easy to follow the plane because as soon as the last bit of periosteum is cut, you will see the fat. Now that is the fat between the supraspinatus and the trapezius. Similarly here, if you start from here and come in this direction, you will do subperiosteally here. There's a little bit of scarring here. It's tethered. I'm going to release that. If you start doing from this side, the problem is you'll go very deep. So start here, come towards this direction. Start here, come towards this direction. Then you will get the correct plane, and you unnecessarily won't try to take the fat which is under the trapezius or the supraspinatus, which may be atrophic, but give me the monopolar. So now I'm showing you the lateral end of the clavicle. That is here. As I said, the trapezius arises from the posterior border of the lateral third of the clavicle. So those fibers also have to be taken. Yeah. That is the lateral end of the clavicle. That is the posterior border of the clavicle. What? So when you tug on this, if the last bit of the periosteum is removed, the fat keeps coming up. Yeah, that is the fat. You don't need the fat. I have to do a bit of sharp dissection here because the addition of the previous surgery.
Uh, Excuse me, sir. Sir, I am audible. Sir, I am audible.
Yeah.
Yeah. Sir, there is some. Can you just explain us what is the position of the patient? We are actually seeing a zoomed in
I
view.
can't hear. क्या बोल रहे? The position of the patient
Yeah,
is
yes, sir.
lateral,
Yeah, okay.
and as of now, the limb is in an adducted position to ease on my dissection. But the suturing of the tendon graft and the tensioning of the proximal muscle to tendon will be done in the abducted position. But just for the amount of exposure that I need, I've kept him in an
Okay.
limb in an adducted position.
And sir, we should identify the spine flexor nerve for this surgery
No,
right now? No, not.
we are doing this surgery without muscle relaxant, and I'm keeping a conscious look for the anterior border of the trapezius because, like you said, I don't want to damage the nerve, but when I was dissecting here, I found the muscle contracting. My bigger worry is this area because there is some amount of scar there. So unless I release this, this is not going to move.
Okay, sir.
So this surgery is
Thank you,
being
sir.
done without muscle relaxant. I'm just assuming that the upper part of the trapezius has not been dissected, so the nerve won't be scarred.
Hello. There is tea available just outside the auditorium for all the delegates present in the auditorium here. Thank you.
That is the supraclavicular fat. Okay, let's start here now. As long as we go through this fat, it won't bleed and you won't injure the nerve, but we need to be very conscious. जैसे vessels आ रहे हैं ना, yeah.
We have an exciting series of cases being performed across 3 operating theatres by our guest faculty, Dr. Praveen Bharadwaj sir and Dr. Shrikant sir. So in the entire day today, we will have a list of procedures. That is, Dr. Praveen Bharadwaj sir will be operating on a case of birth brachial plexus injury, mod quad procedure, wrist fusion, Botox injection for birth brachial plexus palsy, trapezius transfer, biceps to FDP, and tendon transfer for finger extension. Dr. Shrikant sir will be operating on trapezius transfer using TFL graft, triceps to biceps, tendon transfer for wrist extension, and tendon transfer for finger flexion in an operated case of FFMT for elbow flexion. I will briefly introduce each case as we move on across the operating theatres. The patient is a 2-year-old female child who was born of a non-consanguineous marriage. She had full-term birth via normal vaginal delivery. The baby cried immediately at birth. There was no history of shoulder dystocia, prolonged labor, or instrumental delivery. No history of NICU stay. No associated clavicle or humerus fracture. The developmental milestones have been achieved for age. She presented to us with right birth brachial plexus palsy. Physiotherapy was started at 9 months of age. She's had no primary nerve surgery done. This is a video demonstrating the patient's physical examination. Shoulder abduction was at 90 degrees. Elbow shows flexion of M4. Wrist flexion M3 and extension M3. Fingers flexion extension at M4. The procedure, this is a small video demonstrating the examination by Dr. Praveen Bharadwaj sir. उसका ऑडियो चाहिए था जल्दी जल्दी जल्दी
ऑन हो म्यूट नहीं है लगे ही हाँ क्यों नहीं सिग्नल जा सेटिंग होती है
Move forward, don't go.
सर उसको हेडफोन कीजिए वो आउटपुट को हेडफोन कर दीजिए.
So the procedure planned for this patient is mod quad for birth brachial plexus palsy.
This will be operated in OT1 by Dr. Praveen Bharadwaj. वो बता दो ना कि प्रवीण भारद्वाज सर will be doing it in OT1 mod quad.
So the first case will be operated by Dr. Praveen Bharadwaj sir in OT1. Coming on to the second case, which will be operated by Dr. Shrikant sir. This is a 33-year-old male patient who is a driver by occupation. He had a road traffic accident 4 years ago on the 25th of August 2022, where he sustained injury to the right upper limb and was diagnosed with right BPI. The patient also had fracture of the right wrist, which led to ulnar deviation and volar subluxation of the carpal bones relative to the distal radius. The patient did not undergo any primary nerve surgery. He presented to us 2 years after the injury, where we had planned a free functional muscle transfer for the patient using left gracilis for elbow flexion. The donor nerve used was a spinal accessory nerve. This procedure was performed in July of 2024. This is a video showing his examination. As we can see, the patient has shoulder shrugging present. There is 10 degrees of shoulder abduction. Elbow extension, flexion is M3. He has a malunited wrist with volar subluxation of the carpal bones, which is relative to the distal radius. And finger flexion is M1, extension is M0. So the procedure planned for this patient is a trapezius transfer using TFL graft. Now I'll be handing over the audio to the OT, and we'll begin with the operative procedures shortly.
We are now transmitting live from all the three OTs. Are we audible from the auditorium in all the three OTs?
Hello, OT3?
Yes, OT3?
Yeah, you're audible in OT3.
Yes.
This is OT2. You're audible in OT2.
Thank you. OT1? OT1, are we audible from the auditorium?
Are we audible?
Yes, yes,
From
you're
OT1.
audible OT1. Thank you. OT2, can you please zoom out your camera and switch on the audio so that we are aware of the marking that is happening? And in case sir wants to talk and explain anything regarding the marking.
Yeah.
Please zoom out OT2.
Yeah, good morning. Am I
Yes.
audible?
Good morning, sir. Yes, you're audible in the auditorium, sir.
Yeah, the patient has been put in a lateral position. He's been planned for a trapezius transfer. And so before I infiltrate, I am putting the markings. Now what we need to know is the spine of the scapula, which becomes the acromion. The humeral head is somewhere there. This is the lateral end of the clavicle. And we need to keep in mind the previous exposure incision, which is shown by this dotted line. So I need a long curved incision that comes from the upper third of the arm, skirts the acromion process, goes back. This is a bit variable. My intention is to have a wide exposure, so I can always change it to come like that also, because we need to keep this in mind and we don't want this area to become narrow. So even this is fine for us. So this is the incision that I am going to infiltrate before I go to scrub up, so that the adrenaline has some time. Now am I audible?
Yes, sir,
Am I
you're audible.
audible?
Yes, sir,
Yeah.
you're audible.
See, there are two ways you can do a trapezius transfer. Essentially, we are transferring the upper and the middle portion of the trapezius and not the vertical portion of the trapezius, which is there. Because primarily this is to give some stability to the shoulder joint and also give a superior vector for abduction. Now you can't provide abduction if you use the vertical part of the trapezius, you need to use this. Incidentally, the spinal axillary nerve has been used for a functioning muscle transfer. But our assumption is the lower part of the spinal axillary nerve has been used. So the upper and mid trapezius should still be innervated to give some movement. Now the two ways that you do a trapezius transfer is you can take it along with the bone chip of the acromion and the lateral end of the clavicle, because the trapezius arises from the lateral third of the posterior border of the clavicle also. So that entire bone carrying fragment will serve as the point of insertion by means of a corticocancellous screw with a washer, provided the trapezius is mobilized. Now the more distal that you take it, the better is going to be the action on the shoulder abduction, other than the stability that it provides. But the other way of doing it is, if you don't want to take the bone off, you just detach the insertion of the trapezius from the spine of the scapula, from the clavicle posterior border in its lateral third, mobilize the trapezius muscle proximally, and then you will need something to bridge between that and the deltoid. So that can be done by using a piece of fascial lata. Now, if you don't do a bony insertion, it is probably better that the fascial lata is fixed to the lateral humerus with a bone anchor, and it is weaved into the residual deltoid. Initially, we're going to split the deltoid, but the fascial lata is going to be sutured there, and then keeping the limb in abduction, you're going to weave it like a pulvotaft through the mobilized trapezius muscle, keeping the shoulder in about 90 degrees of abduction. This patient is going to require other secondary surgeries also, because he doesn't have finger movements, and that can only be restored by going in for another functioning muscle transfer, and he needs some work on the deformity in the wrist, which will require some kind of osteotomy correction and a fusion. So Dr. Praveen subsequently is going to show you the method by which you take it along with the bone carrying fragment of the acromion and the clavicle. I am attempting to show by using a fascial lata graft. So now I have decided on my incision as being this. This will give me adequate exposure, and I am going to infiltrate this.
Thank you, sir. We now move to OT1, where Dr. Praveen Bharadwaj, sir, is starting with the birth brachial plexus mod cord procedure.
From OT1?
Yes, OT1, you're audible in the auditorium.
Yeah,
Can you please show us?
good morning, everyone.
Good morning,
Is
sir.
it, am I heard there?
Yes, sir.
Yes, sir.
Okay. So here in this OT, we are going to start the first case, which is the soft tissue release at the shoulder to improve the shoulder abduction. So this patient, yesterday we examined and we took a small video as well. I think we are going to show that video to everyone now. On pre-op examination, this child had a lot of co-contraction of the adductors. Both the muscles on the posterior axillary fold, anterior axillary fold, the LD teres major and pec major were co-contracting whenever the child was doing shoulder abduction. So that's why we planned that we are going to do release of these adductors. Also, we observed that child, although child is only 2.5 years, but still already has a posterior dislocation of the shoulder. So when the shoulder is posteriorly dislocated, the tendon transfer for external rotations will not work that well.
Excuse me, sir. Sorry to interrupt you.
So for this child, our plan will
Praveen,
be to do
sir?
a soft tissue release to improve the shoulder abduction first. And once the child becomes around 6 years of age, then we are going to do an external rotation osteotomy of the humerus to improve the external rotation. Okay, we can show that video yesterday.
Yes, sir. That is the reason.
Keep your phone on silent and keep it with you.
So this is what is being seen there.
Actually, camera will just adjust it. Right?
No, this is
One minute.
The video has been shown in the auditorium. OT1, kindly shift the transmission to the operating table, please. Of course, sir. We'll coordinate it.
Can I, Praveen
Yes,
sir?
thank you.
Praveen sir, can I ask you one question? Sir,
Yes.
Okay, yeah, tell me, what is the question?
Hello, can you hear us from OT1?
yeah, sir, Praveen sir.
Yes, ma'am, you're audible.
Yeah, sir, this child is a 2-year-old child, and we are
Yeah,
planning a mod quad procedure for him.
yeah,
So, in the fourth procedure, as described by Rahul Nath sir, that it is the neurolysis of the axillary nerve.
yeah.
So, at this age, at 2 years, is it okay that it is time-wise? Is the neurolysis going to be effective? And the kid also has got a good shoulder abduction and forward flexion also. So, do we actually need the neurolysis? That is my question, sir.
Yeah. Okay, then neurolysis actually is, this is not a typical neurolysis what we do for a oppressive. This has got some dynamic basis. So when we are doing the axillary neurolysis, I will show why it is done. I think then the question more clear and like what I want to explain.
Thank you,
Once
sir.
we are showing that, I will point out to you.
Thank you, sir.
Is along the lateral border of the scapula and then goes towards the axilla just to make sure that it is not crossing the axillary crease. Then another incision is over the anterior axillary fold within one of the axillary crease like this. Okay, through this incision we are going to do the latissimus dorsi and teres major part, and through the anterior incision we are going to do the pec major part. Bipolar foot switch is there.
We have a mic in the auditorium, and all our delegates, faculties, and residents who would want to ask questions with the faculty and interact with the faculty, they can prompt us and we'll get the mic to you and you can ask your doubts and questions. Thank you.
Yeah, it's okay. Let me.
Your answer.
So when we put an incision or the posterior axillary fold, this is the first view what we will get of the structures over there. These are the intercostal brachial nerves. We try to save them. And down we see this is the tendon of the latissimus dorsi, and under this is the muscle which is the teres major. More proximally it will form what is called as a conjoined tendon. Down here will be the pedicle of the latissimus dorsi. So at this place we will try to go under the latissimus dorsi and teres major, and that we do by finding out the triceps long head tendon here. So we right angle give sister.
Right angle.
So if we dissect medial to the latissimus dorsi and teres major, in the depth you will see this white shining tendon. Yeah, it is seen well there. So this is the tendon of the long head of triceps. This is the first important structure which you would like to identify when you are doing this operation, because this is kind of a lighthouse to all the things what we are going to do. When you identify this, you know that you are in the full depth of the LD and teres major. So this whole thing is the LD and teres major. The muscle being the teres major, the tendon is of the latissimus dorsi. And these are the two which we are going to release. Also, with reference to the long head of triceps, we will be able to reach the quadrangular space. So this is the axillary nerve, just beneath that vessel. And below, at the lower border of the long head of triceps, we will find the teres minor, which is our next target. That is the one where we are going to do the tendon transfer. So that's why once you find the long head of triceps, you are quite comfortable about this area. You know what you are going to do and which place you need to go further. Now as I do the first part of this soft tissue release, that is the release of the latissimus dorsi and teres major, maybe we can go to the other OT and come back over here.
Thank you, sir. OT2, please respond.
Yeah, nothing. I'm just going to reflect the skin flap so as to expose the entire trapezius and the deltoid. And it's always better to use diathermy, even though you have infiltrated. So I'm using a monopolar in the coagulation mode. So we are starting to see the deltoid fibers here, but quite a bit of dissection is required to expose the entire thing. Painful process, but it takes time. Bang in the region of the shoulder, there's only skin, there's no muscle. So you need to stay a bit superficial, which is why it's better to start distally and proximally, where you can clearly make out either the trapezius muscle or the deltoid muscle, and then work your way towards the shoulder joint from the cranial aspect and the caudal aspect. So here I think we are close to the posterior border of the deltoid. She is putting the trapezius muscle at stretch so that my dissection is a bit easier. Yeah. Yeah. So now I am going on to the superior portion. Because the effectiveness of the surgery is going to depend on the amount of trapezius that you can mobilize without putting at risk the innervation. So I had requested the anesthetist not to give relaxant. They had to give one during the induction, but he told me that he shifted to propofol after that. To start your dissection where you've already dissected, that will help you in maintaining the plane. If you maintain a uniform plane throughout, then the chances of bleeding are less. Okay. This area is pretty good in blood supply, so if you're not careful with your hemostasis, possibility of a hematoma is pretty high. Okay. Now someone has to hold this or hold that. One of the two. Yeah. If you stay in the junction between the subcutaneous tissue and the muscle, it is unlikely to bleed. So if I suddenly lose my plane, then the chances of bleeding are more. I think that is common sense for most areas. Let's see. Can you hold that bit? Yeah.
So we have progressed a bit. This is the latissimus dorsi tendon. You would have seen that we retracted all the tissues and went very high up to divide the latissimus dorsi as close to the humerus as possible. The main aim being we want a long tendon length here. And then we divided the teres major and we have removed a little bit of muscle bulk from there because we don't want to attach both LD and teres major to the same target what we aim to attach it. Because as per the principles of the tendon transfer, two muscles with different excursion should not be attached to the same target. If you do so, you will end up having the excursion of only the less excursion muscle. Here the teres major has less excursion. We don't want less excursion muscle. That's why we have debulked that. And now the muscle what I am having here is the latissimus dorsi, and we can see that it has a good tendon length. We mobilize it till the vascular pedicle level. This is the neurovascular bundle to the latissimus dorsi going inside. So we need to preserve that. And you see, with this much mobilization, the LD is quite free. Even if we want to put it to the infraspinatus up there also, we can go there. Now here, since this child does not have a passive external rotation, we don't expect the external rotation to improve from this operation. That has to be improved in a second stage with a bony procedure like an external rotation osteotomy. But still, we are going to attach this latissimus dorsi to one of the rotator cuff muscle, and that is the teres minor. So teres minor is also an external rotator, but since here passive external rotation is not there, our aim is not to improve external rotation, but the aim is to augment the power of the rotator cuff muscles. Now in the depth, this muscle, I am not sure, it is seen there, you retract over here. So this is the long head of triceps. At the lower border, we see this muscle going obliquely upwards. This is the teres minor. And how it is identified? Of course, first we identify based on the anatomical landmark that this is the place where it comes. And then you confirm by palpating the scapula. So teres minor is posterior to the scapula. So this is the border of the scapula. So it will be lying on the posterior to the scapula. The second thing is you do a rotation. So since it is an external rotator, it will become taut when you do internal rotation, and it will relax when you do an external rotation. So we can see this muscle becoming taut when I do internal rotation, and it relaxes when I do external rotation. Now why I am telling so much is because the subscapularis also exactly goes in the same direction, and it will give just the opposite function. So that's why we should be sure that we are attaching to the teres minor. So again to repeat, it will be posterior to the scapula border, subscap will be anterior to that, and when you rotate on internal rotation it will become taut, and on external rotation it will become relaxed. So in this soft tissue release we have 4 components. So one was the latissimus dorsi teres major release, what we have done. Second component is attaching this latissimus dorsi to the teres minor, which we are going to do now. And we go to the third component, and now that is the release of the neurolysis of the axillary nerve. Now, as somebody initially pointed out and asked this question, it is a very common and very kind of a strange thing that you are doing an axillary nerve neurolysis, whether there is any tightness there. Now you see, this is the axillary nerve, and my friends here who are with me in the surgery, I am asking them to put your finger here. So when a child abducts, you are able to feel one bony prominence coming there.
Yes.
That is the humeral head. Okay. So whenever child is doing shoulder abduction, you feel that. And when you do adduction, it is not there. When you do abduction, that is the humeral head. So whenever child abducts, you see the humeral head comes down and compresses the axillary nerve. So when do abduction, this humeral head compresses the axillary nerve against the tendon of the long head of triceps and against the tendon of LD which was going there. And this is the one which we are going to remove. This has been termed as a position-dependent axillary neuropathy. So as such, there is no neuropathy. Even if you do a nerve conduction study, EMG, you will not find anything. But it is a dynamic pressure. So whenever child does abduction, more than 90 degrees abduction, this humeral head will come and squeeze the axillary nerve against the tendon of the triceps, against the tendon of the LD. So in axillary nerve neurolysis, it is not that full-blown neurolysis what we do for many other conditions. So here our aim is that we remove the axillary nerve from the constraining fascias which it has around it. That's all. So we will make it free so that it does not get compressed by these tendons, and whenever the humeral head is going up, it just slips on the side. So we are going to make it free in that space. It is not like a real neurolysis where you are going to do some external neurolysis or internal neurolysis like that. You see what I have done? I have just removed the fascia and I have made it free in that area. That's it. And we will see what effect it does. And this was nicely studied by a person called Edelson. So he did an intraoperative EMGs and found that after this releasing the axillary nerve from the surrounding fascia, intraoperatively they found that the EMG readings of the deltoid became better. Became better. So that means it was not getting that much dynamically compressed after it has been made free in this soft tissue area. So that's it. Now we see that it is free now. So whenever the child does abduction, it is just slipping on the side. It is not getting compressed. And moreover, one boundary we have already removed, so the compression will not happen. So that is the main aim for this axillary nerve neurolysis. So it is basically a dynamic compression, and a nice terminology to remember, it is position dependent compression of the axillary nerve, which is happening in abduction because of compression of the axillary nerve. And once you make it free, then there is no issue at all. And when you are doing this operation, the axillary nerve is actually just right there. It does not take more than 5 minutes to do that. So I generally, even if I myself sometimes get so many questions about it, I feel like we can just do it even if it is doing even a bit of improvement in the shoulder abduction. So that is the axillary part done.
Sir, Praveen sir, how to see and protect the radial nerve, that is also just sitting over there, no?
Yeah, radial nerve is actually much lower down. So it is not over here, it is much lower down. It will come on the more deeper part of it. You are nowhere near to the radial nerve. Radial nerve is quite lower down and deep there. Half the bow. The only thing you need to be careful about is when you are neuralizing this axillary nerve, there are a lot of vessels going around it. And you see, we should not do just a blind slash proximally because there is a big vein which is crossing over here like that. So they will cause a lot of oozing otherwise. So we need to be careful only about these vessels. There is no radial nerve fear in this area at all. So now we will attach the latissimus dorsi to the teres minor, which is the third component of the operation. Other tendon transfers which we do for other conditions, we try to put it in more tension, right? But here we don't want to attach it in more tension. In fact, if you see, I have put the arm in full abduction at the shoulder. Hold it there, dear. So in full abducted position, I am going to attach the latissimus dorsi to teres minor. The aim being, we don't want this teres major to block the shoulder abduction. So if you make it tight, it will just become another tethering effect whenever the child is doing the shoulder abduction. And other effect is, this teres minor is a part of rotator cuff, and once you power the rotator cuff, that indirectly improves the function of the deltoid. Because according to the orthopedic principles, shoulder basically has two components. One is the mover and another one is the stabilizer. The prime mover is the deltoid and the stabilizer is the rotator cuff muscles. So if you are having a better stabilizer, the mover automatically starts working better. So that is the reason why we are attaching it to the teres minor so that you can power the rotator cuff. Not the right angle. So this is the teres minor. So I am taking a bite into that like this. And that is the latissimus dorsi tendon. Taken a bite, just hooked it around the tendon of the teres minor. And again to re-emphasize, it is not a transfer which is done in very tight position. We are keeping the arm in full shoulder abduction. And now I take 2 or 3 bites, holding the latissimus dorsi into the teres minor. Please hold this mosquito, please. Yeah, keep the arm up. And since it is not a very tight tendon transfer, we don't have to aim to get about 3 waves of what we do in other things. It is just holding there, and I'm going to put about 2 or 3 sutures there just to hold it in place. And since the transfer is again not in great tension, we don't have to immobilize it for longer duration. We will generally keep the splint only for about 3 weeks, and then we will start doing the exercise.
I need a periosteal elevator also.
Little bit tight.
Let us start by splitting the deltoid.
For the next case.
Thank you, Praveen sir. We'll shift to OT2. OT1, can you mute yourself? OT2, are we audible?
Yeah. We have exposed the deltoid. We have exposed the trapezius, which is the upper and mid portion. This is the spine of the scapula. This is the acromion. This is the lateral end of the clavicle. Now, this actually arises from here, but because previous surgery has been done, there's some scarring here. And when I was running my diathermy here, I felt the muscle contract. So, essentially, this portion is the one that I'm going to harvest and mobilize proximally. I'm splitting the deltoid because I need to give an insertion into the bone somewhere at this level with the fascia lata, and then I'm going to repair the deltoid on top of it. So let's continue to go down to the bone.
Okay, take a retractor on this side. One retractor here. No, he will take this side. Yeah. So this is just to revise what we have done in this area. And first thing, I was congratulating both my friends who are assisting here that we need to preserve this intercostobrachial, but sometimes the person who is retracting, he will retract so strongly that he will take them off, but they have done very well here. So if you damage them, children very continuously they keep telling that there is some hypersensitivity in the medial part of the arm. So it is good to preserve. And again, these are the three components of operation. We divided the latissimus dorsi and teres major. This was the latissimus dorsi, which later on went to the teres minor, which was lying on the inferior border of the long head of triceps. Now, at the upper border of the triceps, we have the quadrangular space. There we just freed the axillary nerve from the facial tissues. I will not tell it neurolysis. It is just like freeing of the axillary nerve from its normal facial attachments or facial constraints what he has all around. And it improves by making the axillary nerve free to move around in that area so that it does not have the position dependent compression of the axillary nerve. Now we go on to the anterior axillary fold and do a kind of fractional lengthening of the pec major muscle. And by the time we do that, you may go to the other OT and come back.
Thank you, sir. OT2?
Yeah. So the area of the humerus which is going to receive the bone anchor has been exposed here under the deltoid. And when you're splitting the deltoid, you need to be a bit careful because of the blood vessels which run below that. And hemostasis could be a problem. So can I have some light inside? I can't see that. Hi. Yeah. Give me a mosquito forceps. To me. Give me one more mosquito. Okay, give me a clip also. One more clip. Stop. Seems better. Yeah, okay. So this is the area that is going to receive the bone anchor. My bipolar has come off. Okay. Now let's start here. So now I'm going to detach this trapezius from the spine of the scapula here. You can see the fibers here. This is the spine of the scapula. I'm incising right down to the periosteum. Me periosteum is better.
Sir, from OT2, can we move to OT1 while the dissection is underway?
Yep.
We'll be back in some time.
Hold this.
OT1? OT1, are we audible?
Please go ahead.
Hello? Yeah, so we have done the exposure on the anterior aspect here. This is the pec major. That is the deltoid demarcated by the vein there. And here what I am trying to do is I am going to go on the under surface of the pec major, because
ये फैट को जरा पकड़ो. वेसल दिख रहा है, पकड़ो उसको. You can hold it. I'm going to cauterize it. No, hold it away from. ये इसको पकड़ो. इतना भी करो. Fat. Hold the fat. So this portion is a bit tricky because of the blood vessels which go in the supraclavicular fat, subtrapezius fat. But I've got quite a bit of mobilization left yet. ऊपर है. Mosquito. Yeah. No, don't put that side. एक और mosquito. Leave it for the time.
Right.
Okay. So you're in the fat only. This is the supraspinatus muscle. Yeah. Car here. That side. Bob. Hold this. Hold this. Yeah. Bipolar, if you have. Touch. Yeah. Touch. Touch. Yeah. Touch. 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 Okay. So this problem is only because of the scar of previous surgery. Touch. Once they cross the scar, touch. There will be not a problem. Touch. 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 Okay. It's enough there. ये पकड़ो. Mosquito. Mosquito. Patient is bucking. Bipolar. Patient is bucking. Touch. Wait, don't touch. 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 Okay. Touch. Touch. Messy. Touch. 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 Okay. Retract here. If the audience is with us, you can see the supraspinatus muscle there. Retract here. Right.
Hello. Shrikant sir will be shifting to OT3 to check our transmission and will be back with you shortly. Thank you.
Yeah, sure.
OT2, please close your transmission. OT3, are we audible? OT3?
OT3, are we audible?
Silk stitch.
Yes, yes, you're audible.
Is our camera audible?
Yeah, your camera visibility is there in the auditorium.
Okay. We will be starting in a couple of minutes.
All right, thank you. PPT, only auditorium. Take it. Hello. So now, since we have completed the mod cord procedure for the birth brachial plexus in OT1, Praveen sir will now be moving on to OT3 for his next case. Now we have a patient, a 37-year-old male, driver by occupation and right-handed dominance, who sustained polytrauma in August of 2023. The duration since injury now has been 2 years and 4 months. He has left BPI, no comorbidities and no associated injuries. He underwent primary nerve surgery in the form of root exploration along with Oberlin 2 nerve transfer with nerve to pronator quadratus in form of AIN, anterior introitious nerve, to nerve to ECRB on 9th of December 2023. A secondary procedure was done and we have done FFMT of left gracilis for elbow flexion and wrist extension, the donor nerve being a spinal accessory nerve on 29th of July 2025. This is the current status of the patient.
Yeah, some branches.
There's a shoulder abduction of 10 degrees. Patient has flexion M3 at the elbow. There is an evident wrist drop.
Hold. Hold again. Bipolar.
Finger flexion is M4 and no extension of fingers is present.
Don't touch. Touch.
The plan is wrist arthrodesis for this patient.
Okay. You're done?
Just 2 minutes, sir.
Give me a mop. Yeah. Fine. You have to take the bone anchor. Give an Alice or something.
So for this session of wrist arthrodesis, I request Dr. Subrajana sir and Dr. Snehajit Wagh sir to kindly moderate.
Don't have to pull it. Yeah.
The mics will be available to you
5 millimeter ka.
In the auditorium to communicate with our faculty.
मेरे को एक drain दे दो.
The operating surgeon will be Dr. Praveen Bharadwaj sir for wrist arthrodesis.
क्या है?
We now shift to OT2 with Dr. Shrikant sir. OT2, are we audible?
Yeah, I have finished my dissection. So what I've done is, this is the trapezius that I mobilized. And here we are finding that the nerves are entering, so I'm stopping short of that. This was the anterior attachment which was partially scarred on the clavicle. This is the posterior attachment at the spine of the scapula. You can see the supraspinatus here. This bunch of fat contains the nerve. I don't want to go closer than that because we are already committed to putting a graft. But what I need to stress is the trapezius is so stuck to the skin, unless you do a deliberate undermining and mobilization, it is not going to move. And that is the maximum amount of movement we will get. Obviously, it will be facilitated by putting the limb into an abduction. So again, it becomes easier for me to tension if I insert the distal end first with a bone anchor and suturing it also to the deltoid. And the last thing I will do is abduct the arm, do a pulvar tap through this. So that once that is done, the position will not be changed. In fact, I would go and start applying the drains also now so that I save a bit of time. My colleague is just going to finish harvesting the facial graft. And your name is? Ahana. Drain de do. So you could probably go to the other table and come back. That is the upper mid trapezius. If we had taken it with the bone fragment, it is not that we would have gained length. So what gains you length is only the mobilization, because it makes no difference whether you are taking it with this or with the bone. Only thing is, with the bone, you have got a more secure anchorage by the means of a corticocancellous screw and a washer. That we are going to circumvent by using a bone anchor and making sure the entire deltoid is included in the suture. And finally, we'll suture this portion also. So if you want, you can go around and come back.
Thank you, sir.
Are we off?
No, sir, your transmission is still live, sir.
ये कौन है? हाँ, ये 16 है ना? पकड़ो इसको. पास करो माँ. एक और दे दो. Can you make the hole slightly bigger? Just थोड़ा सा pinch करके knife से थोड़ा बड़ा कर दो. ये काटें? Ask her to put one more for this. इसको एक और लगा दो ना. एक बार दिखाओ ना. या स्टार्ट एलिवेटिंग ना. इसको एलिवेट कर दो, बट ड्रेन लगाओ. यू कैन यूज योर मोनोपोलर टू एलिवेट इट. पूरा काट दो. Who is he? Yeah, you had to help me because I'm not used to. I actually work in Nizam's Hyderabad. There, these implants are available in ortho, but now we started doing it ourselves. In fact, this.
Yeah, okay. We keep one folded sheet here so that you teach. Table height can be reduced a bit.
We're now transmitting from OT3. The wrist arthrodesis case has begun.
This screen can come here.
Screen bring it in front of sir, na?
Yeah, please, yeah. Table down, stool up. और नीचे जाएगा थोड़ा? नहीं, this one height is, please see, this is.
OT3, can we adjust the light a bit? There's a glare that is visible. And can we zoom out a bit?
Yeah, height. Stand. और नीचे बस लगाओ.
Okay.
Yes, the zoom is good, sir. Can we adjust the glare? The light is a bit much.
No, this is correct. Yeah, thank you. Okay. I think this 7.5 brown glove showman. That camera person always will tell that don't put white glove when you are doing this, because white glove will give lot of shine and glare onto this field. So your glove size is what? 7.5? 7.5. This is 7, madam? 7.5 required, madam. 7.5.
Can we interact with Dr. Praveen now?
Sir, the OT3 transmission is live. That is Dr. Praveen Bharadwaj, sir, operating on wrist fusion.
Yes.
Dr. Praveen?
Yes, sir.
This is Dr. Subraj Jana.
Hello, sir. Good morning, sir.
Good morning. Very good morning and welcome.
Thank you, sir.
I'll be your, the moderator between you and the house today.
Pleasure, sir. So I can expect less questions now. You will manage there.
No, it's not like that. Probably it is the other way around. You'll be facing more questions. Anyway, you
yes, sir.
left the mod quad. What
yes,
kind
sir.
of post-op immobilization have you in your mind for the patient?
Yes, sir. So post-operatively, we will put the shoulder in 100 degrees of abduction and as much external rotation as possible for 3 weeks. So and after 3 weeks, we start the shoulder abduction and external rotation exercise. Yeah. So actively to begin with, and in 1 week, once the child is comfortable, then passive stretching also we can be started, sir.
So this 4 weeks, you want to put him on a cast or a brace?
Actually, in our hospital, we generally make a brace pre-op itself. But here we are not having a brace, so we are going to put a cast. We are going to put a slab, shoulder spica slab like.
Yeah. So
yes, sir.
Fine, that's good enough.
But if it is good to make a brace, that saves about half an hour of operative time then. For a child, that is also nice, important.
So this cast has to be put when this child is still under anesthesia, right?
Yes, sir. Yes, sir.
Okay.
So this is the second case we are starting now here. That is about wrist fusion. This patient has undergone previously nerve surgeries for wrist extension, for elbow flexion, and later on free functioning for elbow flexion. Elbow flexion is recovered, but it is around grade 2. He is not able to do an anti-gravity elbow flexion. His wrist extension is not recovered, and his finger flexors are not so much strong that they can be used for doing a tendon transfer for the wrist. So that is the reason why we have chosen to do a wrist fusion. In this patient, wrist fusion can have a secondary good effect in the sense that once you fuse the wrist, the finger flexors which originate from the medial epicondyle, which is proximal to the elbow, start acting like a better elbow stabilizer at the elbow, and that allows the elbow flexion to improve. So that's why whenever you are having a patient who is like struggling for elbow flexion, in them doing a procedure at the wrist, either a tendon transfer or either a wrist fusion, both of them secondarily improve the elbow flexion. So he requires something for the shoulder as well, but we have chosen the wrist because that appears to be more beneficial for him. Now when you are doing a wrist fusion, it is a bit of extensile operation only, which we are going to put a plate and fuse the wrist joint. Our incision is centered over the listus tubercle, which is a very easily identifiable landmark over the dorsal aspect of the distal wrist. And from here, we go down along the third metacarpal and proximally along the radius. So we plan to have about 3-4 screws on each side, so it will be around 8 to 10 hold plate. So that will be our incision. So generally people prefer to do the fusion to the third metacarpal and the radius, because third metacarpal is in line with the radius. However, there is a group which recommends that you do a fusion to the second metacarpal, because it is thought that if you do to the second metacarpal, it gives about 7 degrees of ulnar deviation, and it is found that the grip strength is best in 7 degrees of ulnar deviation. So if you are doing for a patient where grip strength increasing is one of your main concern, it is good to put to the second metacarpal itself. But when you are doing for a patient like a brachial plexus patient where all the things are already compromised, their third metacarpal is quite a good thing because it keeps the wrist straight. It is much easier as well. So now let us start the case. So we always try not to put incision directly over the metacarpal, just be in the intermetacarpal area. So this will be the standard exposure to the dorsal aspect of the wrist, what we will do for all the operations around the wrist. So maybe we can have a good go on to all the structures which are present over here. About wrist fusion, there are various techniques, various ways in which people do wrist fusion. Conventionally, yes, everyone would use a bone graft, but these days it is quite very well documented that bone graft is not always required. My stool heighting. Yeah, okay. Yeah, one more person from this side come means it will be nice. आप इधर आ जाओ. Yeah. Now when you are this bipolar, this sister, this bipolar being, yeah, it is not. One person retracts on this side. Cat's back. आप इस तरफ ले लो. Yeah, take this.
एक मेजर
आप भी एक स्टूल ले लो यार, ये हाथ नीचे चला जाए तो अच्छा रहेगा. एक स्टूल ले लो आप भी इधर पे. Bipolar, just check. when we are doing any exposure or the dorsal aspect of the wrist, it is good to go in this adipofacial tissue and raise the whole thing just above the level of the extensor retinaculum. This is the extensor retinaculum. Because in this tissue, many small nerves are there. So in case you damage them, the patients generally will tend to have a neuroma over there. So we can go deep, lift the whole thing up like that so that all the nerves are there in this fatty tissue. ये फोर्सेप्स दूसरा ले लो या तो ये थोड़ा स्लिप कर रहा है ऐसे साइड में.
Praveen sir, we'll be quickly popping into OT2 with Shrikant
Yeah, sure.
sir. We'll be back with you shortly.
Yeah, sure.
OT2, can we have the transmission from OT2? Shrikant sir, we are with you.
Yeah, I got the bipolar. Touch. No, touch. 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 Wait. Touch. 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 Show me the tendon graft. Yeah, I got it. Can you see me?
Yes, sir.
So this was the tendon graft that Dr. Ayana harvested. The distal end, I've used a 2-0 running proline to just give it the look of a tendon. That is going to be now mounted here on the bone anchor. I have the technical staff here with me. Once this is done to the bone, then I'm going to suture because it comes with at least 4 needles. So I'm going to suture it with the residual deltoid also till I get a very snug, insertion. After that, I am going to weave this through the proximal end of the muscle that I've dissected. So let's start off now with this. Yeah, yahan pe karo. Yeah, sometimes the screw of the bone anchor doesn't go easily. That's enough. Enough. So we start off with mount a K-wire on a drill that will help us, guide that. Can I see that? So if you can see this, can you?
Yes,
Can
sir.
anyone? So
Excuse me,
this
sir.
is not very easy to push in directly.
Excuse me, sir. One question was there.
Yeah.
Sir, what is the site of insertion for the on the humerus? Is there any specific point that we are looking
What is
for the site of insertion in the humerus? Is there any specific
as
point or
distally
measurement?
as, see, it is ideal to do at the deltoid tuberosity, but that would mean putting a very long tendon graft. So we are going to sort of compromise, and I have taken it beyond the neck of the humerus as far distally into the shaft as possible. So this is the site that we have chosen. The more distal that you go, the more the chances of having a more effective movement or stability, but at the risk of it giving away. So I have chosen this point here.
Okay, sir. Sir, one more. There is the arm should be internally rotated, no?
No, I have not yet done anything.
Okay.
I have not
That's
yet.
fine. That's fine.
So now that anchor has been screwed into place, it's easy if you drill a small hole. Otherwise, it doesn't. Yeah. Hold the V. Set ho gaya. Should have gone. No, it may not be very. Should now, can you remove it? And give me the needles. Hey, don't unscrew it. Okay. Yeah. ओके ओके, गॉट इट. तो ब्लैक को अंदर जाना. Retractor.
Am I audible there? Dr. Srikanth?
Yeah.
This is Dr. Subrat Jana, your old friend.
Tell me.
The question was, have you ever compared the results of a bony insertion against this tendon bridge graft? Do you do that, the bony insertion of the...
Yes, I have done bony insertion also. But what I find is, maybe I'm not from an orthopedic background, I'm from a plastic background. The lateral end of the clavicle and the acromion that you take will permit you to put a maximum of one screw. If you put two screws, it fragments.
Mhm.
And so ultimately, putting K-bars doesn't really help. So I just started doing this as an alternative and not putting a lot of tension on the proximal muscle, because that is one cause for the whole thing to give way. So I'm using intentionally a facial graft, and it's been described.
Yeah, both are described.
Yeah.
So what is your experience? This works a little better in terms of... does it work better in terms of the range of abduction that you achieve?
The results are nearly the same, but I think these patients have to be splinted for a much longer time. I tell them that they require a nighttime splint for a minimum of 3 months. Maybe if you take it with a bony insertion, you don't have to splint them beyond 8 weeks. But with this, you need to splint for a much longer time. Needle holder. 4 hai na? Okay, now hold this.
And also with TFL graft, you could put the insertion much distal to the joint, which is more effective in terms of the range of abduction. Do you agree?
Yeah.
Dr. Srikanth, if you are free to take a question, just let me know. Huh?
Give me a couple of minutes.
Sure. I said when you are free.
It has to go down. Pull करने से आता है ना?
So we'll be muting the audio in OT2 and we'll be popping into OT3.
Slide होता है.
OT3, take over, please.
Yeah, so here we have progressed a bit about the wrist fusion. You would have seen that after exposing the extensor retinaculum, first we identified the EPL and we opened the extensor retinaculum along the direction of the EPL. So this is a nice important thing to note, that I have cut the retinaculum obliquely along this EPL line, because EPL is very acutely angulating over there. So if you try to cut it straight, you may sometimes damage the EPL. And also if you cut obliquely, you get a differential length of this retinacular flap. Not for the wrist fusion, but other conditions, because of the differential length, you will be able to close it much easily. So you can just do a small transposition flap and use this longer part here and the longer part on the other side. So once it is reflected,
both are loose.
You open the second compartment on the radial side. So that's the ECRL, ECRB tendons. And on the medial side, we expose all the extensor digitorums. And they are retracted on either side, and that gives us the exposure of the wrist joint. So wrist joint will be somewhere here. Take this EPL on your side, please. So that's the listus tubercle. This is the ECRB. And generally it is good to take away the index finger tendons onto the radial side, because remember we are doing the fusion to the third metacarpal. So third metacarpal, if you are doing, this index finger extensors will come in our way. So we can retract them onto the radial side so that we get a good exposure of the third metacarpal. Now this is the radius, our proximal site of attachment, and that's the third metacarpal. Take a cat spa here. Take a cat spa here. Cat spa here. सिस्टर आप ले लो इधर कैट स्पा ऐसे हाँ ये ठीक. So this is the third metacarpal, the metacarpal which corresponds to the middle finger. So that's the third metacarpal and that's the base of the third metacarpal now. Proximally, we will now go and open up the wrist joint which we are going to fuse now. So wrist joint is located by moving the hand up and down. So this is the place where the movement is happening. So I will open up the wrist joint now. And people who are from the orthopedic background do some wrist surgeries, you can note that this is the famous dorsal radiocarpal ligament, the oblique one going like, and then another oblique one going this carpal ligament. So the ligament goes from the radius to the triquetrum here, and from triquetrum to the scaphoid there. So whenever you are doing any wrist surgery, reconstructive surgeries, you don't cut across this ligament. You always go parallel to this ligament and keep a part of this ligament intact. So you would make one cut like that and reflect this flap laterally. So that is famously called as the ligament sparing approach of Perger. But here, since we are fusing the wrist joint, we are not going to require that too much. And since we are fusing the wrist joint, we don't require the ECRB tendon also anymore. And it comes in our way because it is attached onto the third metacarpal there. Now I will open up the wrist joint. So that's the wrist joint and we start seeing the carpal bones now. So the first bone what we see will be the proximal scaphoid and the lunate. So this capsular tissue we can even just excise it, but generally it is good to keep it like a radially based flap. So in case you require some closure on top of the plate, you can use this. So we'll keep it like that. Put one mosquito onto that area.
Dr. Praveen, do you use the same kind of flap if you're doing a PRC?
If doing PRC, then we will take it like a nice distally based flap, because during PRC, sometimes if the capitate head is eroded, this tissue can be used to do a resurfacing of the capitate head and convert it into a interposition PRC. So yes, that is a nice good point, sir. Thank you. So if you are doing a PRC, same way, you take this flap, don't cut it here, keep it a distally based flap. And in case you find that the capitate is not good, the same thing can be used to cover the capitate head. So that is a nice important trick to remember. So now I will expose all the carpal bones. This is the scaphoid, the capitate, the scaphoid, the lunate and the triquetrum. That down there is the capitate. The basic principle is when you are fusing the wrist joint, all the bones which come under your plate should get fused. So now our plate is going to span across the lunate and the proximal part of the scaphoid. So the triquetrum generally we don't require to fuse. So we are aiming fusion in this central part. So that's why this triquetrum can act like a bone graft for us now. So we start now preparing the bones for fusion. So first you see I am going to make one cut in the distal radius and remove that. This is the scaphoid. That's the lunate. That's the capitate. So we are able to see them better now. So I am going to prepare the distal radius that will give us some space, and then we will nibble off the cartilage over here. The basic principle or requirement for any fusion is the cartilage should be removed. Once the cartilage is removed, only the cancellous bone comes in contact and we will get the fusion. Osteotome is there, sister? Nibbler is there? Bone nibbler.
Sir, we'll be going to OT2 audio for about 2 minutes and then we'll be back.
Yeah, sure, yeah, sure.
The video will be on. OT2 audio transmission is on right now.
Yeah. What we have done is, like I said, I used the fiber wire and I have anchored the fascial lata graft to the humerus, and in addition I have used it to anchor it to the deltoid muscle. I'm just adding a few stitches of 2O round body proline from the top. And once this is done, cut. Now my job is to position the limb. And there my assistance has to help.
So Dr. Srikant, how many anchors did you make?
How many?
Anchors. Bony anchors.
I've used only one anchor.
Okay.
But it's snug enough. It's a 5 millimeter anchor. It came with a looped wire, and I was able to use the loop wire to give an overlap with the deltoid for more than an inch. And you can probably keep a gown there and on top of it so that he can rest his hand on the gown. And I'll need an Alice now. उसको एक गाउन दे दो यहाँ पे, तो आपको कंटिन्यूसली ऐसे ही पकड़ना है, बिकॉज आई एम गोइंग टू पुल लाइक दैट. वी आर गोइंग टू डू अ पल्वर टैप. ये पकड़ो माँ. ओके, so this will take a bit of doing. Yeah, keep it there so they can show the position of the limb. Slight forward flexion, but 90 degree of abduction is what I am looking for. Give me an artery forceps. Use a monopolar here.
So as Dr. Srikant was telling, he is not worried about the rotation part, which is important if you are doing an arthrodesis.
Yeah. Please tell me what you were telling.
You are not worried about the rotation part, internal or external. You are putting it in the middle.
No, I'm not very worried about it because it is not reasonable to expect that this patient is going to use the limb to go get the hand to the back of the head. We are looking only for functions in front of the coronal plane. What is more important for me is there should be a slight amount of forward flexion and essentially a 90 degree abduction, because that is what I'm looking for. ये आर्टरी है, आ गया मेरा होल. Yeah. Can someone from there come here also? There?
Shoulder arthritis is
Can ma'am also come here?
shoulder arthritis is operation achi. Shoulder arthritis is.
Shoulder arthritis.
Operation achi. नहीं नहीं.
Come there. इसको पकड़ो. या पकड़ो. या. Okay. Now hold this down as much down as possible. Yeah. Give me the two round body proline first.
Myocardial fusion, Botox, trapezius.
Plastic surgeon mane na.
Sister, take an artery.
ସବୁଠୁ important ହେଲା shoulder arthritis. Secondary posture. So, Dr. Srikanth, can we put a question to you now? Are you free? In mind to take a question now?
But give me that. नहीं पकड़ो.
Dr. Srikanth.
I've got frozen shoulder. No, it's okay. No, I don't need it down. I need it up.
Shrikant sir, are you willing to take up a question?
Yeah, you were asking me something.
Yeah. So the question is, are you going to stitch the transfer trapezius to the deltoid also?
I'm sorry, I'm not able to hear this question. Can someone translate that question to me?
The question is, are you going to suture or stitch up the transferred trapezius to the deltoid muscle as well?
That's what I've done. Yeah, essentially I'm going to suture the trapezius to the deltoid, but because this trapezius is not going to reach far more distally, I've used a graft. So this trapezius, graft and deltoid is going to work together.
So, hello. So for the people here, is there any, all of us are plastic surgeons, or are there any orthopedic surgeons here? Orthopedic surgeons. One orthopedic surgeon, good? Two? Good. So the two of us are orthopedic surgeons here. So I would like to tell that if you like, as Dr. Srikanth is doing, he is making a anchorage onto the proximal part of the humerus. So since this deltoid, which is not working, that is why this trapezius transfer is done, you could also erase the insertion, proximal insertion of the deltoid and suture them onto the trapezius for a tenodizing effect. You understand? So this is a paralyzed muscle there, which is the deltoid. So the deltoid's proximal attachment is erased from the bony attachment, and that is also stitched up to the transfer trapezius. This is something different when we are going for reattaching the bony insertion of the trapezius onto the humerus. You have to elevate the entire deltoid muscle, proximal attachment of the deltoid muscle. And the deltoid muscle comes and sit on the transfer trapezius. So many surgeons do it in a different way. So this is one technique. I have been doing this for a long time before I really decide that whether this is a fit case for arthrodesis, shoulder arthrodesis, vis-a-vis trapezius transfer. I would do the same thing, but I would like to take a piece of bone, and as Dr. Srikanth told, then the period of immobilization is much less. And if you are taking a bone, we don't have to put a screw. The screw might split the bony attachment. The bony attachment is the distal end of clavicle and acromion. So the very fine cancellous bones. So we need to put a stainless steel wire and tighten them up like we do in most orthopedic surgery. So it is there without any screw or even a K-wire. It goes, the SS wire goes through the proximal humerus, through this bone, the distal part of the bone attached to the trapezius, and then are twisted. So the union is faster, the immobilization period is longer, and you could start mobilizing the shoulder much earlier. But with this, with the TFL graft in between, unless there is a solid tenodesis, you probably cannot start any active mobilization of the shoulder.
All these shoulder works,
Mm-hmm.
whichever we are doing, mostly is based on the principles of Dr. A.K. Saha.
Saha, yes. There are Saha's procedure.
His monologue. This is his procedure, and the bone is the Bateson's procedures,
Right.
I feel. So, in the Saha's monologue only, he has described that this is which we are simulating the deltoid, which is a prime mover only.
Mm-hmm.
We are not doing anything with the steerer. We are not. We are taking off one depression, like trapezius. We are removing, and we are simulating only a prime mover. We are not doing anything like the steerer. But Saha originally told, if we are doing this thing, you also have to do something for the supra infraspinatus, like something for the rotator cuff. So most probably he has also told to do something like levator scapulae transfer or some fascial transfer, so that we can simulate something for the steerers. Because what he feels that if we are not doing anything for the steerer, this only won't give anything, because the shoulder will go up and it will be
only
like
abduction, yes. It doesn't give any rotation or
but
anything.
he
That
told
is
what that to keep the shoulder in position, just to press the head in the proper arc, we need something the stabilizer. So if we are not doing that, only doing a trapezius transfer, the shoulder actually goes up in the normal position also, and it hits against the lower part of the acromion and clavicle, and just like a Milwaukee shoulder it happens.
Yeah.
So in your experience, do you
Yeah, let me tell you, trapezius transfer has got, even though it is done as a secondary procedure, this works better if you have some degrees of abduction, like the patient that we saw, 10-15 degrees of abduction. Because then we understand that the abduction is there, but it's not much, it's not adequate. But the stabilizing structures are very much there, otherwise the patient would not have any abduction. Do you understand? So, yes. So, in a case where the person is able to abduct 10 degrees, this will add another 70-80 degrees. But supposing the joint is flail and subluxated, you understand there is nothing to stabilize the shoulder, then probably I would consider shoulder arthrodesis. Yes. Mm-hmm. Mm-hmm. That's what I'm telling. This amount of abduction is by the supraspinatus and infraspinatus and not by the deltoid.
5C6 supplies both.
Yeah, but then supposing you have done in a typical picture, we do a spinal accessory to suprascapular transfer.
Yeah.
You have done it. You got 10 to 15 degrees of abduction only.
Yes.
And then you know that the stabilizing structures are there. The deltoid requires little reinforcement. Then you consider trapezius transfer to. I would think that this is a trapezius transfer to deltoid rather than to, even though there is a bony anchor is provided. You understand? So that case, those cases, they work much better. But supposing there is no abduction, whether you have missed the train, you have not done the nerve transfer in time, or you have done it and you did not get any result, the shoulder gets subluxated, you know that nothing is there anterior and posterior to stabilize the shoulder, and you said it goes up instead of getting abducted. Those are fit cases for
shoulders.
Arthritis.
So this levator scapulae transfer or the fascial transfers, that intercostal something from this have you?
Yeah, Saha initially started this, the sternomastoid transfer and all those things. Pec major, sternomastoid. So he got some results, but later on we saw that there wasn't that clear an understanding about the stabilizing factors of the shoulder. What will just pull what is going to abduct. So it's not just pull which is important, and abduction is required. So therefore, as you correctly pointed out, the shoulder stabilizing structure should be there for these all muscle tendon transfers to work, soft tissue procedures to work.
OT3, Praveen sir, we're with you.
Hello?
OT3?
Am I audible?
Yes, sir.
Okay, I'm not concentrating on the audience, but first thing I would like to admit is I am a plastic surgeon. Second, I know that plastic surgeons don't understand shoulder mechanics as well as an orthopedic surgeon. I agree. Now, there is a procedure that we have published also. It is based on an earlier work of transferring the levator scapulae to the supraspinatus in a patient who has got an intact or partially innervated deltoid. In such a specific situation, we can expect that the patient is going to have good shoulder abduction, at least in the initiation portion. I did not choose to do it. I actually wanted to show a levator scapulae transfer, but I've got a video presentation which I'm going to share tomorrow. But what sir has been telling is, shoulder mechanics is not very simple. Now, in this particular patient, he's already 4 years down the line, and I think he needs a surgery to try and restore finger flexion. So, what I was basically looking for is to give him some kind of a shoulder stability using a trapezius muscle, which is already partly denervated because it was used for a functioning muscle transfer earlier. So, in the limited availability, I thought that I would demonstrate a method of doing a transfer, which is an alternative to the standard technique where you take it with the acromion and the clavicle and the insertion of the muscle. And I'm not sure it's going to work as well, but it's likely to do the job of providing some stability to the shoulder in the coronal plane, is what I thought. I can show the video tomorrow. It was
we are with you, Dr. Srikant, we are very much with you. Is more important is stabilizing the shoulder, and that is exactly what you are doing.
Yeah,
I'm with you. I'm with you.
Levator scapulae transfer, I think, was described both by an orthopedic surgeon, Dr. Saha, and I think it was also described by a plastic surgeon who was into brachial plexus heavily, that is Dr. Narakas. And we published this article about 3-4 years back and have good result in select cases. I won't say it is applicable for every case. So just to keep the suspense, I will share with you further information tomorrow.
can do that. We can do that. Anything which...
Thank you, sir. We'll just quickly pop into OT3. Praveen sir
Yeah,
has
band kar do.
something to say. Praveen sir, we're with you. OT3.
Mute kar do.
OT3.
Welcome, thank you.
Sir.
Okay, that's why he was telling Nibal this, huh?
So...
Yeah, so mic is on, huh? Okay.
Yes, sir.
So what we have done now, you see the principle is all the bones or joints which are under the plate should fuse. Now our triquetrum does not come in that row. So it is just an extra bone lying there. The distal part of the scaphoid does not allow you to compress it nicely. So that also is an extra bone. So we have removed the distal part of the scaphoid. We have removed the triquetrum. So they become our bone graft now. Then I have removed the cartilage from the distal part of the radius, cartilage from the proximal part of the lunate scaphoid, distal part of the scaphoid and lunate, and proximal capitate. So after removing this scaphoid distally, triquetrum, we are able to nicely compress and close this gap now. Now this is the metacarpal in line with the radius and the scaphoid and the lunate bone over there, that is the capitate. So this is the area what we intend to fuse. This already looks like it is approximating quite well if we see in this picture. And these small area gaps what we have, that we are going to fill up with the bone graft now. And once we are putting plate, we will put in compression mode, which is going to push all things inside. We have put one wire, if you observe there, so that is just to hold it in correct straight position. That is a preliminary stabilization wire. Otherwise, when we put plate, it keeps wobbling here and there. So once you put this plate, you know that it is going to go in the correct place. Now we have chosen a 9-hole plate. Usually 8 to 10-hole plate, depending on the size of the hand. The basic aim is there should be minimum of 3 screws in the metacarpal and 3 screws in the radius. And you see that we are fusing the wrist in a straight position. Now when the plate goes like that, you would see 2 bumps on the dorsal aspect. One is the listus tubercle, other one is the base of the first metacarpal. So they will not allow your plate to be sitting there nicely. So that is the reason why we need to shave that off and shave this off. This patient luckily doesn't have much bump here, but this is quite a bump. I will make it flat so that our plate sits nicely. Now the next point of discussion which quite often happens is that what should be the ideal position of fusion of the wrist. So that is a very nice and a good question to debate on. Orthopedically, with all the studies have found that the grip strength of the wrist is maximum in about 22 degrees of wrist extension and 7 degrees of ulnar deviation. So that means when you are fusing the wrist for conditions like trauma, rheumatoid, you should try to fix in 22 degrees of wrist extension, or maybe 20 to 25 and slight ulnar deviation. But the problem with wrist extension in patients with global brachial plexus palsies or patients who have a very weak hand, that if the wrist is fused in extension, patients have difficult to maneuver that hand inside the pocket. In fact, this was one point which was told by many patients to us, and then it led to change of our practice that we went to fusing in the straight position. And just for this point, one of our fellow who presented this paper in a plastic surgery meeting got the best paper prize also. And second thing is, if the wrist is extended, then the finger extensor transfer has to work double hard to get the fingers out. So if you have a patient where finger extension is weak, or you are going to plan to do a tendon transfer for finger extension, don't fuse the wrist in extension, because if the wrist is fused in extension, the tendon transfer has to work doubly hard. So the best position is straight position. So this is the listus tubercle which I am excising. This also becomes our bone graft now. Okay, take it away. Bone graft. So today we are having a lot of luxury. We have an orthopedic friend who is helping us with bone graft also. Thank you, Bhaiya, for coming.
So 2 orthopedic surgeons have to work, right?
Yes.
So about this extension in the wrist, the popular belief is that you need to extend the wrist a bit to catch something, which really doesn't work in paralytic hand because, as you said, the wrist extensors and the are now given up, and the finger extensors are only brought to use.
Yeah.
So we have long since decided that maybe 5 degrees of extension is good enough and not more. So it is almost like no extension.
Yes, sir. Yeah. So plate give Bhaiya. Yeah, drill ready. Yes. Chalo ji. Yeah. Yeah, good. Go in. Yeah, go in. Go in. Take the both cortices. It is gone into both cortex, huh? He's in full orthomedic mode. No, did it go to the both cortices? Forceps kodenge? No, put it will keep moving, man. It will come off. I am going to use it like this one, no? Okay, you take the drill now. We can make one hole also. एक मिनट Yeah, okay. One second. No, there no need to do. There I am going to hold. Can you just once take this wire out, please? Take this out once. So first we fix in the metacarpal, because metacarpal is exactly of the same size as this plate. So even if we are a little bit off, we will be totally out of the metacarpal and screw will not be in the metacarpal at all. So that is the reason why the wrist fusion plates have come. So the special wrist fusion plates have 2.7 screws for the metacarpal areas and 3.5 screws for the radius area. So, but in most of the adults, we can manage with a single 3.5 plate itself. So this is the 3.5 plate, but we should make sure that it is right in the center. Now put it there, come. Okay. So now take the drill. And non-locking simple drill. First one, non-locking screw we will put in this. Yeah. Yeah, see, 1 minute, listen to me. Yeah, this metacarpal is very thin, no? So you just try to be exactly in the center here. That is the main important thing here. Should not slip on the side, huh? Okay. Depth gauge is there. This 16 is too much for this area. See, 16 is little too long for the metacarpal. You measure once more and check. Measure more. नहीं रहे. Take 12 size. Okay, show to me 1 minute. One second. 12. 12, put that 12 one. Okay, we keep like that. That's okay. I think we will require to change that also. We put one locking screw here distally. So first we make sure that we are right in the center of the metacarpal. We are putting 2 screws because radius is quite broad. We can have little bit toggle here and there, but in metacarpal no toggle is possible. So first we'll put that. So we have the locking plate available today. So that is a nice thing because all the patients with brachial have a lot of osteopenia. So if you have a locking plate, then that does help. Okay, yeah. You're not knowing orthopedics, man. Okay, so 1 minute. What was the size there? 14 size we take. This 14, huh? Okay. How you know, man? You measured, huh? Okay. We should measure here because this one comes down, no?
So, Dr. Praveen, there's a lot of help coming you without asking for.
Yeah.
So I was just telling if you can
now,
add...
here, once you stabilize the wire, the distal part, now we press it nicely and put the screw in the proximal part. So I am manually compressing it and also we are going to put the screw in the compression mode.
So may I add one thing that if you would like, if you do not have so many assistants, you could put 2 K-wires through the plate temporarily because there are places for putting K-wires.
No, not this, the compression mode screw here. Here, eccentric.
So there will be...
This drill bit is changed, it is not that one. Yeah. See, 1 minute. Be on the center, this is the margin, here you be, please. Yeah. Okay, depth gauge take.
So, Dr. Praveen, I was just telling
yes, sir,
that you could put 2 K-wires through the holes provided for the K-wires and that would take care of this toggling, moving, slipping out of the plate.
Yeah, if we that is also a good idea, sir. But what I'm thinking is if we put K wires, then it does not allow that compression to happen. So I'm like manually compressing it nicely, and we are going to put this also in compression mode. So that way it helps. Take, I think the plate little slid on the side. Take the hole is there. Yeah.
So for the plastic surgeon colleagues here, this is a compression plate. This is not just a bone plate. This is a compression plate, and as you are putting in the screw, the site of arthrodesis get compressed, which is desirable in these circumstances. So he's putting
I think there is some disparity in the drill size, so that's why it does not compress so much. It's okay, it is doing good. Take that locking screw, bhaiya.
So if you look at the holes in this plate, so they are long holes, oblong holes, and closer to the middle, there are holes which are threaded and they are meant for locking screws. And away from the midline, there are holes which have no threads, but they allow sliding of the screw and therefore make compression possible.
16, 16. Locking, huh? Yeah. And next locking sleeve. Drill.
This is a
18. Here it may be little longer than that also, because the distal radius, 18, yeah. Okay, take this way. Okay, so we will just see this area now how it is. There is one more screw proximally coming. So once we have done this, now after stabilizing 2 screws on either side, we take out this wire now. And we take out that wire. So this is our construct which has come. You can see this was the fusion area, approximated quite well, and this whatever small gaps were there, we have filled it with bone graft. We still have some few more chips available which we are going to pack over there. And we have here actually 4 screws distally and 4 screws proximally. So it is quite a robust stabilization now. And we don't require any much immobilization at all, because global palsy patients or weak hand patients are not going to strain it too much. And once the sutures are removed, wound is healed, we just leave them free to have the hand completely free and even use it for small activities. It should not be any much issue. So as sir was explaining there, this is the locking, yeah. So this is a hybrid plate which has one side locking screws and another side it has a screw in the compression mode. If we see that the screw, the hole is oblique like that. So when we pass a screw in this, because of the obliqueness, the head slips and goes in the center. So when it is going in the center, it will cause some pulling of the plate proximally, in turn causing compression at the fracture site, or in this case the fusion site. The locking screw does not cause any compression. So that's why first we need to put the normal type screw, achieve compression, and then lock the plate in that position with the locking screws. Now we just have to complete our fixation with 2 more screws proximally and distally. Come dear. Yeah, this one we will put. Yeah, locking. A cortical not holding correctly, ma'am. Think there. Yeah.
So since the wrist like an ankle is a place of tissue paucity.
Yeah.
Having put this plates of the high profile and lot of hard there.
पूरा थ्रेड को थ्रेड न लगे तो से चले जो सेरा काट देले हां माने सेटा प्लेट को धर देला ए गाइड बटा स्लीवटा क्रेडेड स्लीवटा टोटली मैकेनिकल
but not as common as ankle, because ankle, I think that edema is the main culprit which causes problem. No, here it will be base, no, it will be bigger. How much is that? 16, take 16. This base screw is bigger. Even 18 is okay. 18 we take. So it is not so much issue. So here what you see, no, what I am going to do, this tissues what we have kept, no, we are going to do partly close that, the cover the plate. That plate cover is not mainly that it will get exposed. That plate cover is mainly to keep the extensor tendons free. Because this patient later on we are going to come and do a tendon transfer for finger extension. And this is the area where all the things get stuck. So this capsule what I have kept, that ECRB tendon which I divided, this retinaculum, all of them I am going to close it underneath so that our tendon remains top and free to glide. Yeah, but that is a very nice question what you asked. No, it's a real disaster if this plate gets exposed. So we need to be very careful, release the tourniquet, achieve perfect hemostasis, and no chance should be taken. Take this also. It will go in the base of the capitate. This is fine, yeah. And one of the things, which is really disastrous, though it looks like it is okay, but what happens is, you see the radial artery is just there. Okay? So sometimes in your orthopedic mode, when you are doing this, the radial artery get damaged. And then in orthopedic style, we close it up like that, then patient will have lot of hematoma. I can tell orthopedic because I am orthopedic, no? Other people will get angry otherwise. What, man? Here again 120 we can put. So this screw went into the base of the capitate. So that is quite a stable construct now. This was holding less, no? Not holding, no? Yeah, we'd remove that and change to this, no? Initially only we want it to press the plate to the bone. So see, suppose this plate is, this we don't put, no, the locking will just hold in whichever position it is. If you put cortical, it will push the plate to the bone. So here first cortical is to push the plate to the bone. There first cortical is to achieve the compression. That is the basic construct.
Duration for both of
20 minutes. But we should put a cast. After that we'll put a cast. So keep 40 minutes, you keep 40 minutes. 14 locking.
Dava katha char charta. Minimum is 3 and 3. But he is put one on the capitate, so he's 3 and 4, maybe 4 and 4. The mic to mute is. Na, bora, mane adolescent. Usually adolescence re kara jai. Pediatric. Birth practice. Obstetrics का कोई ना. Birth practice. BBPI. BBPI and BBPI. हाँ को. हाँ. Actually, we get patients in various age group.
With various combinations. More କରା ଯାଇପାରିବ adult patients ମାନେ adolescent
हाँ 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 ସେମାନଙ୍କୁ ଯାହା ରିକଭରି ହେଲା ସେ ଯେଉଁ ଇଣ୍ଟରନାଲ ରୋଟେସନ୍ ହେଇକି ରହିଯାଉଛି ତାକୁ କରେକ୍ଟ କରିବା କଥା.
Locking screws. The locking screws always should be put with the torque limiting screwdriver. because if you put too much force, especially the orthopedic force, no, the threads will break, and then the screw does not come out.
The head comes out, the thread stays in.
Yeah. So always use the torque limiting screwdriver for this.
Yeah.
So now this is our gap. What we had, small bone graft was there, no? Some little bit. Yeah, give that me. Okay, thank you, Bhaiya. Okay, first I think we release tourniquet. Let us clean it up and then we will put. Okay. Now this part is done, and I think good idea is to release the tourniquet, achieve hemostasis, then pack the remaining graft, and then we do the closure. Pad, give sister. And here you see the pronation supination should not get restricted. So wrist is in a nice straight position. There is no medial ulnar deviation, and though it is a straight plate, but it doesn't look like as if like wrist is too much straight or it is flexed. It just gives a natural about maybe 5 degrees of extension just because of the concavity of the metacarpals itself. Okay, release the tourniquet, please. Yes, please, yeah. Yeah, keep it pressed 10 minutes, we keep like that. Okay, thank you very much, man. Timely help.
So, Dr. Praveen?
Yes, sir.
This particular patient, we saw that the shoulder abduction was almost like negligible.
Yes, sir.
So, why did you think that the hand should be operated fast and not the shoulder?
No, this patient requires trapezius transfer also, and I believe it will be done over here in the next setting. So we can combine the trapezius transfer and wrist arthrodesis and do at the same sitting. That is also very much possible. And in fact, sometimes it may have an advantage that anyway 2 months you are keeping the hand elevated, that allows the wrist to heal nicely. But this patient, since his elbow flexion is just grade 2 and it is not going to grade 3. So such patients, when the elbow is not good, if we do shoulder, the trapezius tend to little bit stretch out. So we are feeling that once we do the wrist, now wrist will additionally power the elbow area, and if his elbow flexion improves in next 6 months, then he get a better result of the trapezius, sir. That was the thought process we had.
Yeah, I understand. The philosophy is good. And are you thinking sometimes this patient may require a Stindler's procedure to augment the elbow flexion?
Yes, sir. So that is another one way by which it can be done. This patient was just little bit better than requiring a Stindler's procedure. So that's why we thought that just we fuse the wrist and see. In case he requires Stindler, then Stindler and trapezius must be done at same time. But I am feeling the way he was able to drag into elbow flexion with a lot of instability at the wrist. Once the wrist is fused, he should be clear, get into the grade 3 elbow flexion, sir.
Right. So we'll leave something for your next visit. Stindler's for the next visit.
Yeah, yes, sir.
To analyzing this patient who had about 10 degrees of shoulder abduction, about grade 2 of elbow flexion, and about grade 3 of finger flexion.
Yes, sir.
The planning is a little difficult. It's an ongoing process. We are not completing the whole thing in one go. I'm talking to my colleagues here, so you might hear, but this is not a question for you. So therefore, we have these three things in mind. So Dr. Praveen says, let me stabilize the shoulder, the wrist, and then let me assess how much of elbow flexion he can get. Because if all the three joints are flail, you do not really get to assess the exact amount of power that a person has across all these three joints, the shoulder, elbow, and the wrist. So one he has fused. Then he's thinking that he will go and assess if the elbow flexion has improved. If he doesn't find any improvement in elbow flexion, he might go for stingless. As you know, proximal migration.
This monopolar is some special variety. Huh? What is this? It is some micro tip come that one. Huh? Collar tip. Huh? Normal is not there with here. Yeah, normal only give next case.
So in the regular
practice, that is good. Yeah, next case we use that one.
To fix the proximal joint.
This one sometimes just goes too fast. Yeah, so that is okay.
So I hope you understand that all these three joints have to be like either stabilized or subtusive procedure done for improvement. So you can have many philosophies, and each patient is different. They are all tailored to the personal requirement of the patient and the amount of recovery that the patient has had after 1 year of the therapy or 1 year of the injury. So this is, and this is particularly important for our scenario when many injuries are missed, and by the time they come to you, the window for nerve transfer is not there. And in those, supposing a patient comes to you at 9 months, you are not able to make sure whether at 9 months should I do a nerve transfer or should I go for procedures that will give you predictable result, like an arthrodesis, like a bony procedure. So I believe all these patients should be discussed. A planning session should be done with the senior surgeons who are doing this regularly or have seen. A person becomes senior when he has seen many complications and many results of his not very good surgeries done in the past. And that is seniority, So they have tried procedures, they have seen the results. So now they understand that this is not working well for our patients. If you tell a patient that I'm going to put the hand in shoulder spica for 3 months, most of them would say, no, I'm better off, I'm using the other limb. So in those cases, we have to think of something which will say that I'm going to immobilize your hand for 6 weeks or 8 weeks. Then they might accept. So especially when it is the left arm which is involved, many people would not go for any surgery which will, bind them down for about 3 months. So this is a detailed planning session, and not the surgeons don't change their mind. The patients make the surgeon change their mind what would work best for those patients. So we need to know all these procedures, and I was just telling that as you have seen, wrist arthrodesis is not a very difficult surgery that the plastic surgeons cannot do. They work on the tendons, they work on the joint capsule, they know this area very well. So therefore, doing an arthrodesis should not be very difficult. Earlier days, it was considered difficult because we used to take a bone graft from the iliac crest to bridge this. Now you got nice contoured plates, low profile plates which doesn't show much on the skin. So therefore, putting it, and I would say that if you do not have a lot of assistance, put the plate in the center, put 2 K-wires, and then go ahead doing this. All you need probably is a power saw or a power saw to denude the articular surfaces, which is difficult to do with manual instruments, and of course drill, that is there everywhere. So you don't need a lot of instruments, but it gives a lot of benefit to the patient. Even if he doesn't get any movement, still a stable wrist gives him a control of the hand better than a flail wrist.
We'll go to OT3 transmission. OT3, are we audible from the auditorium? OT3, are we audible from the auditorium? OT3, please respond.
Are we audible from OT3?
Yes, sir.
Do you want to ask something?
One drain, that negative suction type
Is the
drain.
case in OT3?
Praveen Bharadwaj sir is there, sir. Wrist arthrodesis is just closure is going on.
ये तो हो गया ना finish.
Normal vac is okay, mini not required. Mini vac also okay,
This is
whatever you are
OT3.
having.
Yes, sir.
So you have any questions, audience? You have any questions on wrist arthrodesis? You can ask Dr. Praveen. The tourniquet is released, there is no bleeding.
So now you see, somebody was asking about whether there will be any soft tissue deficit, no? So if you achieve hemostasis well inside, and it will not be usually problem. See, it is not looking tight, right? Yeah, so it should be okay. And good hand elevation is important post-operatively. All the gapings happen just because inside the hematoma had formed, yeah.
But you're going to give a drain, right? Are you putting a drain there, Dr. Praveen?
Sir, what, sir?
Drain.
Drain we are going to put, yes, sir. We are going to put a negative suction drain. Gauze piece, sister. Gauze piece, yeah.
You can take it out with us. Sir, sending the implant, sir.
Yeah, please send, yeah. हाँ हो गया. Botox ready, huh? Come, man. Come, bhaiya. Hey, I saw and he removed it off.
No, sir, it was out, sir. It was out, sir.
Good boy, man.
Sir, drain, should I...
Hello. So now we are moving back to OT1, where Dr. Praveen Bharadwaj sir will be commencing his next case. The patient is a 20-month-old female child with right hand dominance, and the affected side is the left side. The child was born of a non-consanguineous marriage, and at term, the child had a breech delivery via normal vaginal delivery, and there's no history of shoulder dystocia or prolonged labor or instrumental intervention during the delivery. The patient has undergone physiotherapy since since 3 months of age, and there have been no primary nerve surgeries or secondary procedures done for the patient. This is the clinical examination video. We can see that the child has a shoulder abduction of 30 degrees. The elbow has a flexion of M2. The wrist has a flexion of M0. There is no flexion extension at the wrist or at the fingers. The plan for this patient is Botox injection for correction of the birth brachial plexus palsy. Now we shift to OT1, and Dr. Praveen Bharadwaj sir will now explain the procedure.
The biceps from the radius. Should explain and then give injection, no? That is better, no? Okay, so आप उधर रख लो. I will make one. Marking is there. Okay, we can take this. Here it is on, audio.
Audio on, na Girija?
Sir, you are audible in the auditorium.
Okay. So here we have a child who is around 1 year age and having limitation of all the movements. He actually has recovery, but because of the lot of co-contractions, the movements are not complete. And we can clinically also check whenever the child is doing abduction. See this, the pec major. Zoom कर इसको, ऐसे कर दो थोड़ा. Yeah, zoom out a little bit. Yeah, good, yeah. So when we are doing abduction, we can see that the pec major is so tight, and posteriorly the latissimus dorsi and teres major also are very tight. So these two, child is very young. At this stage, we can just give a Botox injection to make them relaxed. Also, if we try to do an external rotation, you see the external rotation is not happening anything beyond neutral. So that means the subscapularis muscle also is tight. So the plan is to give Botox injection to the subscapularis, pec major, teres major, and also to the latissimus dorsi. Now, when we are doing this Botox injection, it actually sometimes look like the muscles are already weak, and you are further weakening the what should be why this Botox has some role in birth palsy. Now, to understand that, very nice few principles are there which we can learn. So, Now we see this is suppose the agonist muscles and this is the antagonist. So normally, when the signal is coming from the brain, it goes to the spinal cord like this, and then the signal comes to the agonist. Also, same time, there is some signal going to the antagonist as well. So this is called as a reciprocal inhibition. So whenever motor cortex is sending signal to the agonist, there is a slight inhibitory influence going to the antagonist. So this reciprocal inhibition makes our movements very smooth. But when the nerves are injured, now suppose there is an injury over there, these nerves get intermixed. So there is a cross innervation. And cross innervation will cause co-contractions. So when co-contraction is happening, suppose this patient is getting 4+ here. Same 4+ is going to the antagonist also. So resultant, there is not much movement at all, but you see that the muscle is contracting. So when you give Botox, you kind of remove this 3+. Now this is only 1+ and this is 4+. So then for 6 months, you repeatedly keep doing exercise for this muscle. This becomes even stronger. It becomes 5+. This muscle over a period of time will recover back, but may not recover to same 4+. It remains 3+. Now this 5 is much more than 3. So it will keep increasing in strength and eventually you have a positive agonist movement. So that is one way which Botox acts. It is called as the peripheral mechanics of action. The second thought is, in the brain, there are centers for the movements. There are no center for the muscles, there are center for the movements. So this is for the, suppose, flexion and this is for the extension. They are very close to each other. So if you have given a Botox to the extensor, 6 months the brain is not having too much extensor activity. So this tends to shrink. And just the next center is the flexion that will expand. So it is thought that the agonist movement get a better cerebral control. So this is the peripheral effect and this is the central effect. That is the reason why it is thought that Botox can give a long-lasting improvement in those cases where they are just not having total paralysis, but because of co-contraction, the child is not having the movement. It works very nicely for elbow flexion. It works decent for external rotation. It does not work that well for abduction because abductors, the muscles are very strong. The latissimus dorsi is such a huge muscle, teres major such a huge muscle. It will not kind of save from surgery, but it makes the surgical procedure much easy. But for the triceps and for the subscapularis, you can even have 50% of the patients who can escape without any surgery itself, so it can be quite effective. Now this patient, we are going to do the injection for the adductors and to the subscapularis. Our main aim is not that this child will get full abduction. Our main aim is that parents should be able to do a good abduction exercise for him so that he does not develop more severe contracture. And more importantly, they should be able to do a good external rotation so that the humeral head does not get dislocated posteriorly. That is the main aim for Botox injection at this stage. A patient whom we are putting Botox, we will talk 2 times more than the patient we are doing an operation because parents will think like after injection everything will become okay. But this injection is only for them to make the physiotherapy easy. So it is just an extension of physiotherapy. It is not a replacement for the surgery. Okay, come painting. One fresh glove to me. मैं आना यहाँ पे कि इधर पकड़ो ये हाथ को. I will prepare the Botox then. Yeah, okay. Yeah, you take, yeah, sorry. A little bit on the under surface also there. So in this 10 ml we will, normal saline, no distilled water, normal saline only.
Hello. We'll shift to OT2, Praveen sir, and we'll get back to you in a minute.
Yeah, sure.
OT2, are we audible?
So this is the one which we are giving. We have 100 units. So when you are talking about units, not started, no other OT? Okay, so we have time then. So when we are talking about units, so many important things to know. First of all, the safe dose, how much we can give. So 10 units per kg body weight is the limit. So we should not give anything more than that. Second thing, what is meant by unit? It is not ml, it is not milligram. And the unit of Botox is got such a fascinating definition. So that question is kept for giving gold medal in the FNB exam. So Botox, unit of Botox is defined as the amount of botulinum toxin which is sufficient to kill a female Swiss Webster mouse when injected intraperitoneally. So all the things should be told correctly. So female Swiss Webster mouse, female that too, not male, and injected intraperitoneally. So that is the definition, what is meant by Botox. Yesterday I asked somebody, you didn't find out, no? Yeah, so I told this. So that is the unit of Botox definition, and safe unit is 100 per kg body weight. Generally it is less than 30 units each muscle to make it sufficiently relaxed. If you want to totally paralyze, then somewhere between 30 to 50. We need not give anything more than 50 for a given muscle. मैं 10 ml लगा दूं?
Hello. In OT2, we are done with the trapezius transfer, and Shrikant sir had put the splint before repositioning the patient into a supine position so that the anesthesia team might take over. Now the moderators for the further sessions will be Dr. Devi Mahapatra sir and Dr. Prithvi Raj Singh sir.
One more, a glove over there. This glove is sterile only? Yes. Yeah. Where we can put this? Okay, thank you.
Just a second.
Birth palsy.
We put it the drips now. Yes, sir. Yeah.
That comes in your domain.
Cervical upper limb dystonias we do, yes. So forearm level we do ultrasound guided. So here anyway not much muscle confusion is there. But whenever doing in the forearm and hand part, then we do ultrasound guided. That makes more precise.
तो trapezius transfer ले लेंगे ना?
Yeah. Lateral position. Yeah. Lateral position, yeah. This needle is sterile only? Change, no? Changed, okay.
Good afternoon, sir. This is Dr. Singh from the audience, sir, from the this side.
Yes. Yes, sir.
Yeah, what's your target, sir? Target muscle for?
Yeah, target muscles are pec major, the teres major, some part of the latissimus dorsi and subscapularis.
Okay. So by this you are going to the internal rotators.
Yeah. So we are doing a shoulder abduction now, and then we will start 10 ml. No, yeah, okay. So first I would like to put to the subscapularis. Now subscapularis, as we know, is on the under surface of the scapula. So there are two ways of putting to the subscap. Some people go from the medial border, but then you have to turn the patient on the lateral side, which again is not so much comfortable. So what we can do is, this is not sterile, no? Just focus from this side. So I am doing a shoulder abduction and pushing the scapula out. You see how much out it has come now. And now whole of the subscap is available for injection. Subscapularis, one very important anatomical fact what we should remember is, subscapularis is thought to have a segmental innervation. So the upper part supplied by C5, the middle part by C6 and the lower part by C7. So it has a very good implication that when you are giving a Botox and aiming to weaken that subscapularis, you should target each of the three segments of the subscap. If you just put in one segment, you will not get a good effect. So first part, I am just going down. You go inside, touch the bone. So that way it is easy to actually give for subscap, and it is not required to always do it under ultrasound guidance. You go inside, you touch the bone, come out and inject. So go in, touch the bone, come out and inject. I'll generally put at around 6 sites. That was for the upper segment, and now going to the no flexion. If we do flexion, no, the scapula becomes more oblique.
Sir, what's the dilution, sir?
Sorry?
Dilution of this Botox composition.
Yeah, so it was 100 units, and we have diluted it into 10 ml. So each 1 ml is 10 units. Okay, keep it pressed over there.
So our target is about, sir, 42.
So 30 units 30 I have units. Given to the subscap now. And now I will maintain pressure with this hand here so that I get the access to the pec major. Yeah, correct, like that. So we keep a pressure there. Now I will put onto the pectoralis. So pectoralis, again, there are different ways we can go and put on the medial aspect also. But what I am doing is I am holding the whole pectoralis in my hand and then trying to go to both the heads, the sternal and the clavicular head. So here again I will inject 30 units. Again at multiple sites.
Sir, one doubt again. So when do you, sir, select for this thing, injection of Botox?
Yeah, Botox is generally effective when given to children at around till 1 year of age. Maximum you can extend till maybe 1.5, but not beyond that. Beyond that, the muscle size becomes so much that they will not have a very effective change in the stretching with the Botox. And also it correctly matches to your surgical planning also, because at 2 years you start considering this patient for muscle release operation. So if the child has so much tightness at 2 years, then you should go and do a surgical subscapulary slide for such patients. So yeah, so till at 1 year is a good age, and now we do it even earlier than that. Think as a routine, whenever this patient is coming, one thing which we must check is the passive external rotation. And passive external rotation, you see many times patients or even physiotherapists, they will be doing like this. So this is the worst way of doing external rotation. It is having no good effect at all. You have to do external rotation in adducted position. Because if you are doing external rotation in abducted position and you are forcing in external rotation, the humeral head just slips and inferiorly and gives you a feel as if external rotation is happening. But there is no stretching of the subscapularis at all. Moreover, there is a ligament called coracohumeral ligament that again does not stretch if you do in abduction. So external rotation must be done in adducted position and then we have to do the external rotation. Something like that. All parents we have to teach this way. So any child in examination coming to the OPD, if having limitation of external rotation in adducted position, he should be immediately sent for ultrasound confirmation whether the head is posteriorly subluxing. If there is any posterior subluxation of the humeral head, even at 6 months we should consider giving Botox and putting a cast. If done at 6 months, the results are even better. So it is not that 1 year is a good age. 1 year is actually end of the good age. So we should try to put it earlier itself.
Okay, sir.
So now I am going to the teres major. Teres major is again quite easy to identify. You hold the scapula and come out. So whatever muscle is you are having on the lateral border of the scapula is the teres major. So I am going to inject 20 into this upper part and 20 in the lower part where it will have some overlap with the latissimus dorsi. Unfortunately, latissimus dorsi, more muscle part is inferior to the scapula. It is not going to have much effect on that part. But teres major, we will get a good effect. And after doing this, anyway, child is under anesthesia. We should make this use of this time to do some capsular and the coracohumeral ligament stretching. And again, this is one thing which everyone should remember, that external rotation is done in adduction, not in abduction. In adduction, you do this external rotation. So the conventional aeroplane splint was actually not a very good thing because it is giving an external rotation in abduction. It will be of not much use. So these days commonly what we use, which is called as a super splint, SUPER. So it is like supination and external rotation. So hand is put in this position and tied to the body. So child sleeps like this. So that nicely stretches the subscap coracohumeral ligament and also takes care of the pronation contracture what these children develop, and also is beneficial for this kind of deformity what this child is developing. Okay.
Done.
Yeah, done. Now we will put the cast.
And sir, so far as the result is concerned, I think, sir, how early do you get the result, sir? And it's again temporary, it seems, no? Botox.
Sorry, somebody asking anything? What is it?
Yeah. So the question is, sir, so how early do you get the result following Botox?
Sorry?
How early do you get? I think it is as early as possible, something like that. And it will continue for 6 months. It's a temporary effect only. Effect of Botox, sir.
What was the question? I didn't understand.
How early do you get the result of Botox and for how long it will be?
What is the time to give?
Sir,
Know the result, okay.
Yeah, sir is asking how
so
early
Botox is a nice 6 to remember. So Botox, the maximum effect is achieved at 6 weeks. And the effect will last for 6 months. So the best result is at 6 weeks.
Praveen sir, are you going to do anything for the elbow flexion contracture?
कोई बात नहीं. और अच्छा है तुम्हारे पास. तो फिर चॉइस क्यों बता रही है? Okay. You are awareing me, huh? Soft roll.
Praveen sir.
Sir, there's a question from the audience.
Yeah.
Praveen sir, are we going to do anything for the elbow flexion contracture?
This baby does not have a very severe elbow flexion contracture. You see the elbow is coming straight only. Elbow flexion contracture gives good result with stretching exercise. Children are big, we can do a stretch casting.
Okay.
So that gives good result. Botox also can be tried, but we should not give Botox to the biceps and brachialis both, because elbow flexion reduction is a big disability. So suppose the child has got lot of tightness, we can give Botox only to the brachialis and then do the stretching exercise. It will work better, but not to give Botox to the biceps.
Okay.
Because there is some study in Melbourne which found that Botox given muscles never come to the same power.
Oh.
So then if the biceps become weak, then we are in a big problem.
Okay.
Keep the elbow flexed only.
So what will be our next step for treating the child, sir?
Yeah, this child, the next stage what he will require once he is crossed 2.5 year age, he will require that muscle release operation to improve the elbow shoulder abduction. His elbow flexion, I think, is going to improve soon. He is almost there. So his main next 3 years program is good rehab and continuous physiotherapy.
But he has got no active movement in the wrist and fingers.
Wrist and fingers, he has wrist extension is there, wrist flexion is not there, and fingers he has this much movement that he is able to hold our fingers. So children who have this much movement at 1 year, they tend to improve till 4 years of age. He will not develop full finger flexion, normal flexion. And a child who has this much finger flexion, actually he is the biggest gray zone in birth palsy, because you cannot cut that nerve because it is working. And if you want to do any nerve surgery, you need to cut and attach a new nerve. But if the finger flexion is there, you are not going to do that. And you also know that this flexion is not going to become normal. So it is a real gray area, and that is the reason why many researchers, many experts feel that at 3 months itself you should do off the operation. Because if at 3 months, when nothing is there, whatever you do and recovery happens, everything is on the positive side. But at 1 year, when you do surgery, for 1 year this child will not have any finger flexion. So what parents will feel that before operation fingers were bending and now it is not bending. So that is a very great decision to take. So that's why most of the people at this stage would actually just wait and watch and expect the finger flexion to become better with time.
So any role for neurolysis, in the supraclavicular region, thinking that the exoplasmic flow will improve, or anything like supercharging nerve transfer?
Yeah, I think it is not having so much role, sir. In our practice, what we keep a reserve is any child who is having this much flexion, and if after 5 years of age it remains very suboptimal, we augment it with an FFMT going on top of the working muscles.
Oh, okay. Okay, thank you.
So that is more reliable than doing a nerve surgery or any nerve augmentation at this stage. Yes, 6 inch है क्या? वो दे दो जरा. POP, it has to be strong. It has to be put in that adduction and external rotation, like that. Yes. आ गया? 6 inch is there?
6 inch.
Actually, the cast when we put, no, it is very impossible to put it in adduction. Because if you put like that, then how you will put the cast? So that's why some abduction is required, but we should try to keep it minimum. Other thought comes is you are not stretching the adductors. But adductors are not going to have very dramatic change. Here our main aim is that this child should not develop an internal rotation contracture and posterior subluxation of the humeral head. We are keeping it for 1 month. So after that we can do the abduction stretching exercise. 1 more minute. Hello, sir. Namaste, sir. Actually, all orthopedic people only know plaster putting only most difficult. So we give operation, we will ask the juniors to do, but plaster we will only put. What, sir?
So yes. Sir, when are you planning in this case, sir? Mod quad or quad procedure, if anything, sir?
Yes, sir.
Which age group, sir, are you planning quad procedure?
Age generally after about 2.5 years of age.
Sir.
Keep it down like that. Yeah, correct. So supination and like this. ऐसे पकड़ लो आप. Yeah, I will take care of this. इसको छोड़ दो. Yeah, this POP is not very nice one. इसको सीधा ही रहना. Just let it be like that for 15 minutes now. No moving at all. Otherwise, no, it will break. Yeah, this one is more better.
Hello, Praveen sir. This side, Dr. Yatin sir. Audience side. Sir, one question more, sir. One more question. Hello.
Okay. And one 6-inch crepe bandage, one 4-inch crepe bandage. Yes.
Hello. Praveen sir, there's a query from the audience, sir. Hello? Praveen sir?
Yes?
There's a query from the audience.
Yeah.
Sir, actually, I wanted to know that this pediatric birth palsy,
Yeah.
here the concept of due to this Botox is co-contraction, and this due
Yeah.
to the regeneration cross connection that causes co-contraction, sir.
Yes.
So this happens only in post-ganglionic type injury, you know, sir. And in pre-ganglionic, if it is there, then there will be no work of Botox, sir. I think. Kindly guide, sir.
You understood, huh? Okay. You ask your friend to tell, no? Yeah. Okay, let it set. So this one we will put here, 4 inch we put there. ठीक है? क्वेश्चन देखते हैं क्या बना.
मैंने बहुत सारे डॉट पूछ लिए सर. नहीं वो तब ये पता नहीं कि प्री गैंग्लियन होता है नहीं है वो प्री गैंग्लियन होता है लेकिन कोई एक्शन होता है.
Madam?
I'm removing the trolley.
Yes, please. Yes, yes. Thank you, madam.
For the next case, sir, instruments required the same like the first one?
Oh, next case here is which one?
The trapezius one.
That they were telling they are putting up there?
Other than that, there is no other case over here.
Yeah, okay. So trapezius transfer require different type of screw. That's 6 mm screw required. Yeah, and one saw required, that's all.
Saw required.
Chalo. Ready. Now anesthesia, we can lift the baby up, please. Backside some leads and all will be there. We will remove all of them. You stabilize the tube. One hand on the buttock, somebody down here. Okay? Okay, sir? Okay, okay. नहीं नहीं इतना काफ़ी है बस. ओके. उधर ECG लीड है तो उसको निकाल दो. हाँ.
पूरा लीड में पूरा.
ओके, सब निकल गया. बैक नथिंग इज देयर. The baby is quite active, huh? Full crying baby, no? She may take it off very quickly. So we have to we arrange one splint for her, 1 month. Need to keep one splint ready. That clip is there? One second.
Clip.
Okay. Yeah. One broad plaster. Yeah, this will get loosened otherwise. Yeah, this is okay. This doesn't look like micropore. Yeah. Okay, chalo ji. Okay, thank you. Thank you. Thank you, madam.
So, Dr. Praveen, if you are free to take any questions, tell us. You want the mic?
On
Dr.
only.
Praveen?
Yes, sir. We are. We are trying to get the question. We didn't understand the question fully. Sorry.
Okay. Someone else is going to ask the question.
Yes, sir.
Hello, Praveen sir. Hello, Praveen sir.
Yes, sir. Tell me.
Sir, I am a student, Prakash. Hey. Praveen sir, I am Prakash. Hello. Hello, Praveen sir, can you hear me?
Yes, we are able to hear, but not understand very clearly. Tell again, please.
Sir, I am Prakash, sir, your student.
Prakash.
Yes, sir.
Yes, very good, very good.
It's
Okay.
always a delightful experience to watch you operate. Yes, sir. My question is, how many days after or months after will you consider repeating Botox injection? What are the criteria for repeating the Botox injection? How will you assess the improvement and then take a call that yes, repeat Botox injection is necessary?
Actually, repeat Botox generally we don't give. So in case at 6 months child is again developing contracture, then we will take him for muscle release operation itself.
Okay.
So repeat Botox not so much effective. Yeah. Welcome, Prakash.
Thank you, sir.
बंद कर दे.
Praveen, will you consider using a thermoplastic material for instead of gypsum?
Thermoplastic material or any other material?
Yes, sir. Actually, this first 1 month we put a cast, sir, because we have manipulated the shoulder. Now we want it to be in that much external rotation. After 1 month, we will give a thermoplastic splint. So 2 months, baby will be complete immobilization. And after 2 months, child is kept on that same thermoplastic splint during the night time. Daytime it is free, and night time he will be using that thermoplastic splint. So some kind of splinting is required for almost 6 months to get the good effect.
Who was asking a question about
Praveen sir, can you hear us?
Hello. I think the transmission is currently paused, and because we are going to now show the case capsule for Dr. Shrikant's case. He'll be taking the next case in OT2. So, we have a 54-year-old female, driver by occupation and right-handed dominance. She sustained polytrauma in March of 2024. The duration passed since injury is 2 years 5 months, and the affected side is the right side. She has associated injuries for which open reduction internal fixation with tibial plates and open reduction and internal fixation with K-wire fixation for hand and right distal radial fracture was done. She is a known hypertensive on medications. No primary nerve surgery or secondary procedures were done. This is the current condition of the patient on clinical examination. There is no shoulder abduction. Elbow flexion is not present while extension is M5. Wrist flexion is M4 while extension is M5, and finger flexion is at M4 and extension is at M5. The procedure planned for this patient is a triceps to biceps transfer. Biceps.
Scoliosis develop गोटेटा पूरा पैरालाइज लिम्ब ना सेटाକୁ ଟିକେ abduction କରିବାକୁ ଚେଷ୍ଟା କରିକି ଏମିତି ତାର ଆର୍ମ ପିଟ୍ଟା କ୍ଲିୟର ହେଉନି ସେଥିପାଇଁ ସୋଲ୍ଡରଟାକୁ ବହୁତ ଆଗେ କରିବାକୁ ପଡ଼ିବ ନହେଲେ ସେ ବହୁତ ଅସୁବିଧା ଏଇ କେସରେ ଫଟାଫଟାକା ସୋଲ୍ଡର ଯଦି 1 year ଚାଲିଗଲାଣି ତାହେଲେ ସେ ପେସେଣ୍ଟ ଖୁସି ହେଇଯିବ ସବୁବେଳେ ଏମିତି ଯାଇଥିବ ଆଚ୍ଛା प्लास्टिक को केतरा ऑपरेशन थिएटर देछि रंजी
तीनटा दीटा रेगुलर आ गोटे मझरे मझरे दीटा फिक्स आमे चारिटा सर दीटा प्लास्टिक रे दीटा बोन्स
बोन दीटा प्लास्टिक के सेट करछ बोन सेट करछ
OT2 are we audible
सब सेपटे बोन कॉन्ट्रैक्चर
OT2
एक्यूट क्रॉनिक सब सेपटे
पूरा बर्न प्लास्टिक शब्द गंगा कर देला ना
हां नहीं नहीं सेमती एटा बर उसले बेटर
मेन दु भारी रोगवा
Srikant sir, good afternoon. Hello, can you hear us, sir?
Hello, this is from OT2. Are we audible?
Yes, you're audible.
You're audible from the auditorium.
All right, there are some questions for Dr. Srikant sir.
Yeah, just give me a second. Yes.
This is upper trunk injury, sir. Hello, sir. Srikant sir, good afternoon.
Hello. This is Dr. Srikant. Am I audible?
Yes, sir. Yes, sir. So I'm Dr. Singh. Yeah, my question is, sir, this is upper trunk injury, and both the shoulder and elbow functions are lost. So your priority you have given to elbow flexion by transferring triceps. So next plan will same, sir, for shoulder. You will be going for the trapezius transfer. What you shown.
Boss piece or something.
Okay, sir. Please explain that incision line, sir, markings.
Decision making
Available muscle and easier for this to simulate the function of elbow flexion. Only 2.5 years or even faster.
Sir, you need a 14 section. Number 14 section.
Yeah.
Not 6.
No,
are you doing anything for the shoulder? What is your plan for the shoulder?
Yeah. Sir, what is the next plan? Are you planning anything for shoulder, sir? This is what you are doing for elbow, and you will be taking tricep. And what about the how often the shoulder? I mean, the elbow joint becomes unstable, or what? Following prime extensor being removed and elbow flexion will be simulated, sir. Following this procedure.
OT2, are we audible?
Yeah, can you hear me?
Yes, sir. Yes, sir.
Audience, can you hear me?
Yeah, but you are very, very slow, very soft.
Audience are not visible.
Hello, sir, you're audible here.
Surgeon's mic को थोड़ा सा और बढ़ाइए.
Am I audible?
अच्छा अच्छा.
Okay, okay.
अंदर डाल दो.
Sir, patient. थोड़ा इस तरफ लेना.
नहीं, we are not audible over there.
Yeah.
Audience are not audible.
Yeah, you can start painting all this.
Are we audible, sir?
सुनाई नहीं दे रहा उनको?
Now you are audible, sir. We are audible, sir.
Yeah, can you hear me now?
Yes, sir. Yes, sir. But
So this patient essentially has come after 2.5 years with no primary surgery. And when we examined him yesterday, we found that he does not have any elbow flexion at all. He does not have shoulder abduction. The hand is essentially normal. And considering this, obviously the only way forward is muscle transfers and tendon transfers. Now, because I wanted to demonstrate what is it that I would do for elbow flexion, I am going to demonstrate a transfer of the long head of the triceps to the biceps. Obviously, this needs to be followed at a subsequent date for a transfer for the shoulder abduction. Preferable not to combine two tendon transfers, especially when you are working at a proximal joint like the shoulder and the elbow. Both immobilization and therapy become very difficult. The position is supine, but during the harvest of the muscle, we'll be putting the arm across the chest. And initially, you don't need a hand trolley, but subsequently, when we are going to transfer and suture it to the distal biceps, you do need a hand trolley. I've already given tentative markings and I've infiltrated the wound. It's not possible to put a tourniquet, and infiltration suffices. So I'm going to scrub up now. If you have any questions about the approach. Okay, I'll go and scrub.
Hello? Hello, Srikanth sir?
Hello, OT2? Hello? Are we audible from the auditorium in OT2?
AIIMS sir ସେମିତି ନାହିଁ AIIMS ରେ କଣ୍ଟ୍ରାକ୍ଚୁଆଲ୍ ମାନେ ବି ସେ ପୋଷ୍ଟ ଫିଲ୍ ଅପ୍ ହେଲା ପର୍ଯ୍ୟନ୍ତ କରିବେ ଆଉ ଜଣେ ରେଗୁଲାର ପୋଷ୍ଟିଂ
ସେମାନେ ଷ୍ଟପ୍ ଗ୍ୟାପ୍ରେ
ଷ୍ଟପ୍ ଗ୍ୟାପ୍ କିନ୍ତୁ ଗୋଟେ ଗୁଡ଼ାଏ ଦିନ ରହିଲେଣି ସେମାନେ ତାଙ୍କ ଷ୍ଟୁଡେଣ୍ଟ ସେ
ଭଲ ନା ତାଙ୍କ ଭିତରେ ଡିସିସନ୍ ନେଇନେଲେ ଏଠି ଡାଇରେକ୍ଟର ଲଟ୍ ଅଫ୍ ସେଥିପାଇଁ ତାର ଆଡମିନିଷ୍ଟ୍ରେସନ୍ ଟିକେ ସିମ୍ପଲ୍ ଆମର ଗଭର୍ଣ୍ଣମେଣ୍ଟ ସହିତ ଅଟୋନମସ୍ କରିବେ ବୋଲି କେତେ ଲୋକ ଲାଗିଲେ ପ୍ରଥମ ଗୋଟେ ଏସ୍ସିବିଟାକୁ ଅଟୋନମସ୍ କରିକି ଦେଖ କମ୍ ସେ କମ୍ ପहले एससीबी को ऑटोनोमस करवा
OT2, are we audible now?
अथॉरिटी दिए नहीं है ना पावर नहीं दी है they have not been given the administrative power there is a director here calls this job because he cannot become there is a governing body there is a governing body also so whatever they action is taken the governing body and the minister is a governing body so politically free nahi hai but they can act immediately it's like you see there were 10-20 states 33 हो गया 35 हो गया 38 हो like also in Odisha कितने थे 13 जिले थे now it is 30 plus because of administrative requirement it is faster administration अब उसको अगर हमेशा दिल्ली से आएगा
Hello. Hello, Srikant sir.
Hello, this is from OT2. Are we audible from OT2?
Yes, you're audible, ma'am. Thank you. We have a question from the audience for Srikant sir.
Hello, Srikant sir.
Yeah.
Yeah.
Can you hear me?
Yeah, sir.
Yeah, tell me.
Sir, for achieving elbow flexion, there are pec major transfer, or LD transfer, or a triceps to biceps transfer, a Stendler's, or a FFMT. So here in this case, totally there was no elbow flexion, so Stendler is ruled out. But this patient, I think, has a pec measure, active pec measure, or LD, or FFMT. Why
Yeah.
did you choose
See,
actually the triceps to biceps? Are you not going to
yeah,
lose that
I
extension of the
understand
elbow?
your point.
Okay.
What you're trying to say is, why did I choose upon this technique?
Yes, sir.
Yeah, it's actually part of my presentation tomorrow when I'm talking about the procedures that can be used for secondary correction of elbow flexion. Now, as you say, it's a matter of personal choice of whether you're going to use the bipolar pedicle LD transfer or you're going to use the triceps transfer. The triceps transfer seems to be contradictory, but believe me, in our hands it has worked well. And when you take the long head of the triceps, it's quite possible that it is a bit independent from the rest of the triceps. And you would get a reasonable amount of flexion without having to do a pedicle LD transfer. Now, what we need to do is, so that is the back of the arm, and we put an incision running through the center of it up to the junction of the proximal third and the middle third. And you can very clearly see this is the long head of the triceps because it arises from the infraglenoid tubercle of the scapula. The lateral head comes from here and they begin to join somewhere here. So if you start your dissection here, in the act of separating the triceps, then it becomes easier to delineate. So I'm going to open this up, reflect the flaps till I see the entire triceps. Once I see the entire triceps, I'm going to look at the gap between the long head and the lateral head. The other thing is, I will intentionally isolate the ulnar which lies somewhere like this so that there's no risk of damaging it. Once all this is done, we are going to detach the distal half of the tendon, which is the long head. Subsequently, we are going to put the hand in a hand trolley because the dissection here, that is for identifying the biceps tendon and the tunneling has to be done. So we have already infiltrated with adrenaline saline. Yeah. Who else is coming here? Who? Shall I start? I'm going to start. long head and the lateral head, and this is the long. The medial one is the long head. So you develop the plane a bit till it starts fusing, then you can stop, because it's only to get an idea of where the long head is. Leave it for the time being. So come down here, knife. Correct. Hold it. Hold on.
OT2, it's not audible. Can you unmute it from that side?
Hold on. Yeah, 1 minute.
Okay, sir. Okay.
So having done that, I am now going here down to trace the ulnar nerve, because when I'm harvesting the triceps long head, I want to make sure I don't injure it. Okay, put a retractor. Hold on. Do one thing. Leave it for the time being. Put a retractor.
Shrikant sir, we're just going to pop into OT3.
Yeah.
The case is starting there and we'll be back with you shortly.
Yeah, I'll expose the ulnar nerve and then you can come back.
Yes, sir.
दो लगाओ. Lift it like that, yeah. It's difficult.
Dr. Praveen Bharadwaj sir will be starting a case in OT3. This is a 29-year-old male patient who is a machine operator. He is right-handed. He had a history of polytrauma in the month of November of 2024. It's been 1 year, 9 months since his injury. He had associated soft tissue injuries to the face, but no bony fractures. He didn't undergo any primary nerve surgery. However, we've done an FFMT for elbow flexion, finger and wrist extension, which was done in October of 25. Donor nerve was the spinal accessory nerve. However, the gracilis muscle, the FFMT didn't survive. So we had done a debridement and we had taken out the gracilis 3 days after the procedure, 3 to 5 days after the procedure. This is the video showing his examination.
Touch. 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 Touch.
So as we can see, the patient has 10 degrees of shoulder abduction. Elbow flexion is M2. Wrist flexion and extension is M0. Finger extension, finger flexion is M0.
Touch.
The operative plan for this patient is a trapezius transfer, and this case will be done by Dr. Praveen Bharadwaj, sir. So can we move on to OT3?
Touch. 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 Go the other one now. Can you give me a tilt?
The transmission from OT3 is live.
From here, ROT.
Are we audible in OT3?
Hello, am I audible? This is OT3.
Yes.
OT3, are we audible?
Yes, sir.
Okay, coming. ये पकड़ो. Okay, put a retractor. दिखाओ मेरे कालना नव दिखाओ. Is it? Give me a rubber band. Give me a 200 clip. Can you gently hold this? Retractor उसको दे दो. No, don't retract so hard. Bipolar. Light. Touch. 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 Touch.
OT3, are we audible?
Yeah, we are ready here and we are doing a trapezius transfer, this time using the acromion as a bone. And we just have seen one trapezius transfer already by Shrikant sir. He did using fasciolata graft. This one we are doing the almost conventional Saha type technique in which the acromion bone will be taken and it will be acromion bone we take and we fix to the proximal humerus. We have not heard the discussion what everyone had with Shrikant sir. So that's why for me also it is a little bit difficult to know what all questions were asked. So maybe there is anything very different type of question or some real comparison between the two techniques. Somebody has any doubt means we'll be happy to talk about that.
Touch.
Some more, sister?
Touch. Touch.
Needle is there here. Yeah, inject nicely man everywhere here. Some more is there? Take.
Don't pull so hard. The purpose of not putting an artery is so that you don't pull hard. Not necessary to pull at all. Rubber band. $200 clip.
If something remaining we can take.
छोड़ दो इसको छोड़ touch yeah touch
okay
touch
chalo take
touch.
So we have done a very liberal infiltration of adrenaline. That's very important because this area, of course, we cannot put a tourniquet, and since it is a very heavy muscle area, there will be a lot of ooze all around. So it is always good to do this infiltration and then do the surgery. So these are the incisions. Give one marking or something. This is the incision what we have marked. First we marked the acromion process.
Touch.
So it is kind of a U-type incision with the apex being at the acromion, and then it goes around the clavicle, and posteriorly it goes along the spine of the scapula, right almost till the midline. And some infiltration is there, put here also please. And then in the center we go on to the arm area. Now this patient has previously undergone free functioning muscle transfer. He has some elbow flexion And shoulder abduction was not there at all, so that is the plan. That's why we thought that we are going to do a shoulder abduction for him. He also recovered some spontaneous wrist extension, so he is not requiring any wrist arthrodesis. So this is the only thing what is planned for him. And if we talk about whether the fascia is better or this is better, I think both are okay. This one gives little more stability to the shoulder. So if you see a patient who has more inferior subluxation, there are no muscles working around, then this is better.
Give me 100 clip.
And if you think about the advancement of the trapezius transfer surgery historically, initially it was like a soft tissue thing, and later on Bateman was the one who told that if you put bone, then it will be more stronger. And then Saha came with a little bit more sturdy fixation and more proximal mobilization. So the advantage is once you get a good bony union, you will have a real good stability. So patients also, when we are counseling, think this is one very important thing to express to the patient, because for a patient, suppose you tell we are doing an operation for hand lifting, he will think that he is going to lift 180 degrees and touch the roof. This operation does not work that well. This operation is mainly for providing stability to the shoulder, and most of the patients will get a shoulder abduction of around 45 degrees. 45 degrees for a patient who is looking for my hand should lift up is nothing. So that's why our discussion should mainly emphasize on the fact that we are doing the surgery mainly for stability. And he gets a better control on the hand. And in bargain, he also gets a good control over the shoulder abduction. I overheard a discussion between the shoulder stabilizer and mover and with the Saha's principle. So those things are very perfectly okay. And that is the reason why trapezius transfer physiologically cannot work that great, because you are doing it in a situation where no shoulder stabilizer is working. None of the muscles around the shoulder are working. So if you put a trapezius to replace to the deltoid, it is only going to cause a superior migration of the humeral head. It is not going to cause abduction. So that is the reason why the aim is stability. However, if patient has biceps working or triceps working or some of the shoulder stabilizers are working, then you can expect a shoulder abduction of even 90 degrees. So here there are no other muscles functioning, so the aim would be to provide a shoulder stability. This is the incision, and this is for harvesting the trapezius. This is to expose the proximal humerus for fixation. In this operation, one other important thing to remember is, since you are doing a closure in 90 degrees of shoulder abduction, at that point, the landmarks would change. You will have a lot of difficulty in approximating the skin. So always have some marking incisions made first itself, so that your closure becomes easy. And we also see when we are closing that how practically important this point is.
Touch. 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 Touch.
The first point is to be able to identify the trapezius and raise this flap to a correct level thickness. So sometimes if you are very careful, you go very superficial and raise up a very thin flap. And sometimes if you are aggressive, you may cause damage to the trapezius itself. So that is the first important practical step in this.
I have bad ergonomics. I bend any way that I want without any concern.
Okay. Bipolar and monopolar also will be required then?
Touch.
Okay, yeah, thank you.
यहाँ कोई branch नहीं होता है. It's very unusual to have a nerve branch of the ulnar to the triceps. Touch. Highly unlikely. Touch.
Table overall height can be reduced, just ask once.
टेबल डाउन कीजिए. टेबल डाउन.
Yes, please. Yeah, that is good. Yeah, thank you. Okay, scissor forceps, please.
Sir, we'll be moving on to OT2 and we'll be back with you shortly.
Yeah, sure.
OT2?
Yeah, I have finished exposing the ulnar nerve here.
Yes, sir.
Because we are going to lift up this entire thing. And in a plexus injury who's got a functioning ulnar nerve, I assume I'm being extra careful, but it's always better to be careful that in the process of dividing this, you don't damage the ulnar nerve. So that ulnar nerve here, which keeps hugging and maybe sometimes even goes through a part of the triceps, is separated right up till here. Up till here. So now I don't have any fear because this is the portion that I'm going to mobilize. I probably won't go proximal to this. So once that is out of the way, I get back to trying my finding my cleft between the long head and the lateral head to develop it further. Usko nikal do. Yeah. Now extend the elbow. Extending the elbow relaxes this area. So it's the difficult job of the assistants to take care of it. Shoulder retractor. Put through retractor. Yeah. See, this is the one that we want. Hold the, yeah, long head and hold this. Touch. In between. So this is what I want. When you do a triceps to axillary, you're again looking at this groove. Put a retractor. That is the place. And I'm going to open this up further. Open this. It has already started fusing. And just cutting the deep fascia on top of that. But not the muscle yet. Give me marking ink. So I can show which portion am I going to take. So this is the head that we are going to take. The muscle is going right up till here. So assuming that this is the junction, this is the portion that I am going to take. This will come and join here. Need to go a bit more distally so that the mobilized muscle will reach. And this entire triceps is taken. Okay, ऐसे रखो. Yeah. So this entire triceps is going to be taken. Some fibers are probably joining here from the medial intermuscular septum. I'm not clear what that is, but it's probably not required. So we are going to take this. Uh, so can you have to hold. एक minute. थोड़ा. Yeah, yeah. Give me that. So it has already started fusing here. What I can do is take it here and show them here. Yeah. So I'm going to slit the tendon here. This is the line in which I'm going to cut it so that it meets the gap between the two. Okay. यहाँ पे रखो. There's the other now. It's very far away. I'm now cutting the end of the long head of the tricep, but we need to remember that the deep head is also present below and there is no plane between the two. So you have to create an arbitrary plane. The deep head and the long head. I've already cut the end of the tendon. Move the ulnar nerve. No, a little bit, not much. Yeah. Ulnar nerve is away. So this is the deep head that I was talking about, because the tendon forms on the superficial surface and the fusion of the deep head and the long or lateral head happens on the undersurface. Substantial reduction of the muscle is required before you transfer this to the biceps tendon, but I'll do that later. I'm not making the posterior surface of the humerus bare, so I just keep following this. I had already given the distinction, but it implies that, yeah, again I have to cut through the muscle fibers. There is no plane. That is why I said, I am taking part of the muscle fibers here and I'll trim it off because I want a tendon to tendon. Most anatomy textbooks describe the long head, lateral head and medial head. RJLAS describes the medial head as the deep head and the lateral head as the superficial head. I think that is more logical. If you see the anatomy of the... Don't pull that anymore. Quite a lot of triceps here. Because of the deep head. Can you give me a AIIMS or something? Isko nikal do. You can remove all this. Just cut this. Just cut it. Cut that also. Not a good practice to keep these things. Now give me an AIIMS. Keep it stretched on this side. So here you can't make any distinction. You have to cut through the muscle fibers. Yeah, that answer will come tomorrow during my presentation. I think cortical plasticity has got something to do with it. And children and young adults do much better than adults, aged patients, especially if there's an underlying element of head injury as some of these patients have. Some more to go. We'll go till that place where it becomes a cleft head and the lateral head. But I need to give it some excursion. Touch. 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 Touch.
Sir, we'll be switching over to OT3 to Praveen sir. Thank you, sir. OT3.
Yeah. Yes, welcome. So you would have seen in the display that we have progressed a bit in this process of trapezius transfer. Yes. Just we will update of what we have done till now. Now, and I was just talking first, when we put an incision, that time itself we have put a nice markings so that we don't have difficulty in closing the wound, because remember that we are going to do a closure in 90-degree shoulder abduction, so all the landmarks would get distorted. And then we have raised the skin flaps. You see, quite extensively we have raised them, because if you do with some minimal elevation of these flaps, you will surely be able to complete the surgery. But when you start closing these wounds, the skin flaps don't fall nicely. It will look very odd and you will have difficulty in doing the closure. So with a good elevation of the flaps on either side of the deltoid and proximally onto the trapezius, then you start the process of harvesting the trapezius as such. We have plan of taking the acromion. So this is the acromion, and the trapezius is attached on top of the acromion. So it is a relatively easy landmark to find, because that is the most prominent part of the
the scapula. We cut on the anterior part of the trapezius and separate out the deltoid from it. So now I am onto the margin of the acromion. And if I cut on the under surface, I would actually reach onto this is the whole acromion. But I am not in a hurry to go over there now. First we will identify the lateral boundary of this trapezius. So lateral, or maybe the posterior boundary, the better word is. So this is the posterior boundary and it is continuing as the spine of the scapula. Now here we can, according to Saha, he would take the whole thing and even the spine of the scapula for fixation. But in patients of brachial plexus who don't have any shoulder stabilizer, if we take the whole thing, what happens is there is no superior support for the humeral head. So humeral head with the trapezius tends to get into superior migration only. So that's why what we do is we always leave a small bit of this acromion over there so that it acts like a support to the humeral head, and the humeral head does not have too much of superior migration. Okay. So this, we don't require a very huge size of acromion. We just want it sufficient to actually hold one screw. So we will just leave a small bit of it intact over here, like that something. And from there I follow the spine of the scapula and reach to the most posterior part of the acromion, the trapezius, and raise it like this. Okay. At this point, we need to differentiate the trapezius from the supraspinatus. So supraspinatus is deeper to this, of course, and then the difference between the two, the interval is marked by a thin fibrofatty tissue. So once you are in that fibrous fatty tissue, you know that it is a trapezius lower border and you are not going very deep into the supraspinatus muscle. Because if you have harvested the supraspinatus muscle, you will not be able to mobilize it that well. So that's why it is important to not go deep to the supraspinatus. So this is the plane. Not very clearly seen there, but yeah. Yes, please, yeah. Yeah, I think that is good, yeah. Yeah, that is the fatty tissue seen there. That's the plane. Monopolar again. Big artery give, sister. And give that saw also. There will be lot of bleeders in that area. That is the subacromial plexus of vessels. So whenever we do this, we need to be prepared for that and just hook them all. Telling to this, like suppose humeral head is there, no sir? So in case this whole thing is removed and there are no shoulder stabilizers, that this trapezius only pulls it up. So we'll just leave this posterior margin intact so it does not have a free flow there. So that way it helps. Saw, madam? Irrigation, please. take. So now we are on to the under surface. Take this, sister. This also take. Scale also take. The under surface is the area which is going to go and fuse onto the humerus. So that we have to totally denude of all the cartilage. Here itself we will start, and later on also we will remove all the cartilage whatever is there. Okay, and that only, yeah.
Light.
Anteriorly, we will take acromion right from the acromioclavicular joint. So once the joint comes, I will disarticulate from there. Now we switch our attention to the anterior side. So we are able to see that is the anterior margin of the muscle. And on top of the clavicle, we start cutting it. So main aim is that we are going to elevate the whole trapezius up there.
This is just a small announcement. The lunch counter is open for all the delegates. So the transmission will be going on, but you all can go and have some refreshments.
Okay, now we see there are no bleeders here.
Give me a knife.
Clean, sister. Monopolar.
Light.
Straight scissors.
Praveen sir will be back with you shortly. We'll be moving to OT2 for 5 to 10 minutes.
Yeah, sure.
Shrikant sir, we are with you.
That mic was here only. I thought it is not there.
Just a second. Yeah, can you see us? So I have detached the long head of the triceps and dissected it right up to the gap between the long head and the lateral head. I don't really need to do it more. The ulnar nerve is completely safe. The distal end, I put a couple of sutures in the residual tendon, keeping the arm in extension. And this is the kind of excursion that you have from this position to about 3 centimeters or so. Now this is going to be tunneled from here subcutaneously onto that aspect. So we will finish that with a hand trolley, come back and close this wound, and then do the final insert. So I need a hand trolley now. You can put a mop or something.
While we reposition the hand, we'll switch to OT3. OT3, Praveen sir, are we audible?
Nerve graft repair. Yes, yeah. So we have progressed quite a bit in this trapezius transfer. You can see over there we were discussing few important things which we will repeat again. So that's how it was. So we cut the distal part, distal attachment first, and then we put one artery inside as you would have seen and retained some bit of this spine of scapula intact so that we have something supporting the humeral head superiorly. Then we disarticulated the acromion from the acromioclavicular joint, and then it was easy. Just you lift it up and then start proximally mobilizing. And remember, I was telling the adipofacial tissue, which is the demarcation between the trapezius and the supraspinatus. This is the tissue. That down underneath is the supraspinatus muscle, and what we are elevating is the trapezius. When you are elevating trapezius, more proximal you go, the better. In fact, the trapezius transfer, most of the things were already there in practice before Saha described the famous Saha modification. One of the things which he emphasized was more proximal mobilization of the muscle. And that was a very nice thing because more proximal mobilization if you do, you are able to go more distally. So you are able to generate a better vector for the shoulder abduction. So our mobilization is looking okay, but it is still, I think, not sufficient. We will go right till the base of it. And there is not so much fear about the injury to the spinal accessory nerve if you are in this plane. Because spinal accessory nerve is in the facial tissue on the undersurface of the trapezius, and we are more deeper to that. So that means we are not like at great risk of damaging that nerve. He has undergone one surgery in this same area. I think that's why the fibrosis is a little bit more. But yeah. When fibrosis is more, the mobilization also has to be more. So one thing what I was just telling is, suppose you have done any nerve transfer using the spinal accessory, for example, spinal accessory to musculocutaneous transfer, then the spinal accessory transfer would be, the repair will be somewhere there. So if you do the trapezius transfer in this manner, you may damage that nerve. So that is a disaster. So the best idea is you don't harvest the most anterior part of the trapezius. So we'll make one cut here and use only that middle and the posterior part, leave this anterior part intact. So if we do like that, you make sure that you are not risking your previous nerve repair site. And it really does not make too much difference to the outcome because the power comes from the proximal part of the muscle, which is anyway the same what you will otherwise do. So now I have reached almost to the medial border of the scapula. So that is the level of mobilization what is required to have a more easy shift of this acromion to the humerus without much struggle. Take this.
So we're getting a transmission from OT2. We'll be back with you in about 2 minutes, sir.
Okay.
OT2?
Yeah?
Yes, sir.
Yeah, I'm now trying to expose the biceps insertion, having put it on a hand trolley. because once I finish finding the biceps tendon, then I can, yeah, what? I can do the subcutaneous tunneling. This vein will come in the way, then I have to take it out. Scissors. Scissors. 200 clips. So the biceps muscle and the tendon are going to be exposed now, keeping the limb in slight flexion makes the dissection easier. It's better to cut off the bicipital aponeurosis which goes and inserts into the ulna, because the more wide the distal insertion, the greater the chances of adhesion. So I am nearly going towards the undersurface of the biceps now. It's good to separate it over a length. That is the bicipital aponeurosis. So back this side. I need to go around the biceps now. You can do end to end or you can do end to side. If there is no function in the biceps, you could probably do end to end. If there is some function in the biceps, leave it. Give me an artery. I need a retractor here because we still can't see the tendon. You can see the musculo-tendinous junction here. The retractor there. So that is the bicipital aponeurosis extension, I think. Yeah. Give me a mosquito. Hold this mosquito like that. I still can't see the tendon. Yeah, now we can see the tendon. The biceps tendon is here. A little bit more separation there. That's the bicipital aponeurosis that I've cut, because that is the main tendon. This can be easily cut. Brachial artery is close by. Yeah. So that is the tendon. That is the biceps tendon. Flexi elbow. That is the biceps tendon, and we are going to suture it to that. As you can see, still a little bit of this tethering is there. Cut it with monopolar close to the biceps. We don't want this. Yeah. Yeah, we are done. So we need to get it here. Now we have to connect these two. So here the problem is going to be that was subfacial. But if you go subfacial, you will go behind the brachial artery. So you have to change the plane to a subcutaneous dissection. So can I come that side? So we need to create a largish tunnel from here to there. As I said, if you stay subfacial, you'll go behind the artery. We just can choose to do a subcutaneous tunnel here so that it comes correctly there. Okay. Show me the monopolar. I can see the junction between the subcutaneous fat and the deep fascia here. Take that up. Yeah, forceps. Another one here. So once I identify that junction between the deep fascia and the subcutaneous fat proximally, the tunnel has to be wider proximally because it has to accommodate this muscle. The distal portion is not the problem. If it gets stuck, it will get stuck in the proximal portion. So I'll ask my assistant to hold it up vertically up and try to create a plane there. Can you show me some light? This can't be seen, only I can see this. इस तरह Can you give me an artery? No, the medial, it will be superficial to that because I don't want to injure the brachial vessels. So I'll do my dissection from both sides to remove this. This is going to take a bit of time, so if you want to go to the other OT and come back, please do. Then I'll show you the tunnel. ऐसे उठाओ, दो लगाओ. I want to. So they can go to the other table and come back once the tunnel is ready.
Yes, sir. We'll be back with you, sir. OT3, Praveen sir,
Yes,
we are
madam.
with you.
Giving attendance like. Yeah, we are here, almost there. So this is the deltoid which we have split and retracted on either side. And the trapezius is mobilized fully till the very proximal part of it. And we have confirmed that we are very comfortably reaching to the site where we want to go.
Sorry.
And now the next thing what we are doing is we are preparing the insertion site. So insertion site should be distal to the humeral head. So at same point you will have the axillary nerve coming. Hold like that. Yeah. Take one retractor there. Put one LP. So one this side also.
One more.
Okay, so this is the humeral head, and we can see this is the part of the humerus which I have prepared for attaching our trapezius. So this should be beyond the head. It cannot be in the head. If it is in the head, then it will just act like a tightener of the humeral head. It will not improve any abduction. We need not go too much far also because there are no stabilizers. It is not going to make very great difference. In fact, if you go more down, the operation is more difficult and the result is actually the same. So this is an ideal place just beyond the humeral head. And also advantage is you will get a good cortical bone here which you can fix your screw more comfortably. And the bone in this humeral head area sometimes is very osteopenic and will not have any hold of the screws at all. About the attachment, I think there was some discussion about external rotation, whether we do anything. So in this, you put one hand here. Which hand you will put there? Yeah, correct. So here what we do is we give the attachment little anteriorly. So if you give the attachment little anterior, when the trapezius contract, it automatically gives some amount of external rotation. It is debatable how beautiful external rotation it will give, but for sure you should never attach to the posterior part. If you attach posteriorly, then so much internal rotation comes because that is the natural position of turning of the humerus when it is falling down. So the point is either lateral or more anterior, never posterior. Monopolar? So that's our area what we want to fix. Okay? इसको ऐसे करके खींचना पड़ेगा आपको अच्छे से, like this. Okay? And like this. बाद में when I'm doing no, that time I will ask you. Okay? This one. You saw दे दो sisters, saw दीजिए, saw. So what we will do now is we will roughen the bone there. So it is called fish scaling in orthopedics. So because we want that bone to become raw so that it unites to our acromion. So again you observe that I am not going posteriorly, I am not remaining mid-lateral also, I am little bit moving on to the anterior side. And as an orthopedic surgeon, you cannot be satisfied that one screw is enough. We always feel like more screws we should put. But the profile of the humerus is roundish. You see, it is so much round. So since it is round, we cannot have too many screws here. So that's why we always put only one screw. But we assure that at that point there is a good amount of contact, and we have had good union of this bone always. There was one technique described by Dr. Kotwal from AIIMS, Delhi. So they will just take this acromion and do a green stick fracture on the dorsal side and make it roundish and then put 3 screws. So, but that looks quite scary. If there was some high rate of non-union, maybe those cases it is worth. But I think it is just the fear of the orthopedic heart that drives that multiple screws. 2 months when we are keeping the hand elevated in that position, it should surely heal. So there is no problem in that. Okay, so that much rawness is sufficient. Now we prepare our acromion. Take a mosquito, dear.
Hello, Praveen sir.
Yes.
Sir, for orientation, can you ask the cameraman to zoom out a little bit?
Yeah, a little bit zoom out kar do yaar. No, this tissue what I am elevating, no, you just keep removing that. Is it zoomed out?
A little bit.
water retractor.
In the earlier discussion, there was some apprehension in the house that while driving the screw in that bone piece,
Yeah.
there might be fracture or the fragment might get shattered. So is there any tips how to avoid that?
Yeah. The number one tip is we have to pray every day. Jai Jagannath we have to do. Yeah, that's enough. So I think after we fix it only, I will tell what trick is there. I should not break it today, okay?
Okay. No, Ali. Is it?
Dr. Praveen?
Yes, sir.
How about putting a stainless ware? Do you ever use it? SS ware to fix it?
Yes, sir. If the screw is we are not able to put, or there is some complication like breakage of this bone piece, in those cases, tension bend is a good escape out.
Yeah, so you always keep it handy. In case
Yes,
there is
sir.
any
Yes, sir.
split,
True, sir.
put in it.
Yeah. So all the soft tissue on the under surface of the acromion has to be removed, and also we are making sure that we get some amount of good bone there, which will allow our union to happen. All the cartilage has to go off.
Put an alley.
We need not remove too much of bone because then it becomes very weak and then it can break. So I'm just doing some scaling, and also some areas if the bone is thicker we need to remove that, because if at one point bone is big, then what happens is this point come in contact with the bone and this area will not get fused. So it has to be really flat.
And pull the muscle. It's okay. Okay. इसको काटो सूचस को. Cut here. I'll play safe and put 2 drains. I didn't do very good hemostasis. अच्छा previous
Can we move to the Srikant sir shooting?
बोले एक बार drain पूरा empty करने के लिए syringe लगा के. Yeah,
Sir?
I have finished the tunneling. Can you hear me?
Yes, sir.
I just show it to them. I have finished the tunneling and I've just put couple of drains here. If you can see, this is the tunnel. He's going to pull the muscle. So that is the muscle that has gone anteriorly. Ulnar is here, biceps. And when we turn, we'll show that the tunnel is at least 5 fingers wide, so that adhesions don't form. A problem of this is because it's a musculo-tendinous transfer, chances of adhesions are pretty high. So there also I have a trick, I'll tell you about it tomorrow. So we need to close this first, then only we can go there. Silk. इसको काटो. Get your closure ready. Triomonocryl and trioethylon. Is the audience still with me?
Yes, sir. Yes, sir.
So, ठीक है. So once we finish this closure, we have to turn the hand again onto the hand trolley and then trim the distal portion of the muscle and then give an inset to the biceps. I don't think I saw any pre-op biceps action in this patient because he had not been operated and I don't think there was any spontaneous recovery. So it makes sense to do an end-to-end rather than an end-to-side. ये मेरा नीडल होल्डर है. प्रीवियस पेशेंट मतलब वो क्लॉट हो जाता ना, सिरिंज से एम्प्टी करना जैसा. Okay, start the closure from above. I'll fix the drain. Which patient? No, drain na. Yeah, I just want to know if the drain has been emptied. Syringe लगा के एक बार empty करके लगाने से ना hematoma नहीं होगा.
While the closure is underway, we'll just go into OT3 and we'll be back with you, sir. OT3?
Yeah, okay, yes.
Yes, sir.
Water, please.
Water.
वो बड़ी ड्रिल दे दो जी जरा. एक बार स्क्रू दिखा दो पहले एक बार. Yes, sir. 6.5 screw will not go in this, no? No, this one only I want to put. Which drill will be suitable for 3.2? It will go. That drill what you gave is what size? 3.2 give to me. This is 4 mm.
Cut. You start above, I'll start below.
Okay. Okay, take now. थोड़ा मोटा लग रहा है वैसे. सारे वैसे ही आज टूटने की बात कर रहे हैं. Okay, give the wire also then. Anyway, we are putting cannulated. नहीं उससे मत पकड़ो. That is another reason how it breaks. Guide wire you gave, no? Put that and let us do with that. So that it should not wobble, no? Hold it for me 1 minute. Yeah. No need to hold. I am holding it. No. छोड़ दो. Take now. Okay. So now we have this Homens. I don't know, that is orthopedic style instrument, but do we have here? Homens? Okay. Give the retractor, sister. Now very important time. Both of you have to help nicely with all the stability. Give the Ellie's sister first. Ellie is here, Ellie is there. Okay. Now broader retractor is there, sister. You turn like this and hold. So your one hand, you put one finger here and stabilize the forearm like that. One hand here, yeah. Okay. So in this, no, this is the most critical step, because that whole whichever direction is there, no, there only we should go. Otherwise, we'll keep struggling then. And take the retractor and keep it more than 90 degrees upwards. Now I will need that stool when I ask, no? Okay. So suppose our length is not good, no? At this point it actually then will hurt. So then you will not have, you will have difficulty in reaching on to that target.
Super cutter. डॉक्टर अनीशा, मेरा कितना केस बाकी है? 2. उसमें कौन सा क्या है?
Okay. Yeah, give that guide wire, bhaiya. This you can leave this. I am more now worried about the rotation. That should not change. No? Like that. Yeah, that is very good position now. Little more abduction is nicer. Yeah, come bhaiya, the guide wire de do jara. Yeah, thank you.
Irrigation.
So again we have been in that same spot, more anterior to the lateral line and beyond the humeral head.
Irrigation.
You are drilling it with the 6.5 mm cannulated screwdriver?
Yes, sir. Yeah, 4 mm. 6 mm. Sorry. 6.5 mm screw we are going to put. इसको थोड़ा ऐसे करके दो. Keep it like that, honey. One interesting orthopedic problem which can happen is this drill. The guide wire is stuck inside. The guide wire may come out from that side. So we should be careful of that. Take minute. ये क्या भैया? ओके हाँ हो गया चलो ले. वो डेप्थ गेज एक दे दो भैया. Depth gauge. So usually it will be like 45-50. So depth gauge is there. Okay, give the wire then.
Sir, here do we need to identify the axillary nerve and protect it?
No, sir. Yeah. Actually, what has happened is we have elevated the whole thing with the axillary nerve in that. There is no need to do because axillary nerve is not working. That is the reason why we are doing trapezius transfer, right? So it is not required to do. So it is 30, 45, yeah. So 50 is safe, I think. Come, is 50. Washer is there. Washer is there. Washer, yeah. Give it the washer. 30 is come here. 10 will be the. This will come 10. 35, 45. 45 is okay, I think. 45, okay. 45. Whatever is there, sir. Actually, I like half partial threaded so that we can partial thread better. Partial thread better, so that we can little bit toggle here and there. Yeah. Oh yeah, today this is a good luxury only actually. If this guide wire is there means it become easier, right? हाँ जी, लिस्टली लगा के कर देंगे. इधर तो दिख ही रहा है anyway. Scale give sister. जस्ट उतना ही आ रहा है. ओके ठीक ही है. गाइड वायर दे दीजिए भैया. ऊपर करा. या बट गाइड वायर के अंदर कैसे डालेंगे? गाइड वायर कैन नॉट. गुड मैन, यू आर वेरी इंटेलिजेंट बॉय. वेल डन. ओके, ये स्क्रू ड्राइवर मैं लगा देता हूँ. ओके, 1 minute. आई विल टेक देयर. या ओके, उसको ऊपर भी मत खींचना, अदरवाइज इट गेट्स डिस्ट्रैक्टेड ना. या okay, 1 minute. One more, this small retractor type. Okay, take this beer. What happened? What you are telling? Something? Okay. No, we will. This is a very important step. We will prepare and. No, this soft tissue was there in between. This L is slipped off. We will do it again. Take like this. Actually, one nice omen comes on both sides, no? That makes it little more comfortable. Okay, we keep like that. कहाँ गया भाई? गाइड वायर किधर है? दिखा दो जरा. Up there like that. Yeah. ये आइडिया अच्छा है आपका. ये ले लो भैया. So now we require orthopedic surgeons to hold, okay? So you transform into orthopedic surgeon, okay? Take now. We can leave all the things. This is the most important here, like that. Okay. So, so that is the opposition you can get. You put your finger there inside and have a feel. Put inside your finger and have a feel. So that's how we should get it like that. And that contact, if it heals, it is not going to slide off anyway. In fact, if you try to put 2 screws, no, this will go like that and that will wobble and come up like that. So you cannot get a contact. So on a rounded surface, it is not possible to have 2 screws going and holding that bone like that. And if you really want, then we have to do the technique that make on green stick fracture, turn it around and put like that. So this is the opposition what we get, and it nicely fits over there. Now the next part of the technique. Anything? Sorry? Yeah. Please. So this was all the Saha style procedure what we did. There is one more new thing which has come, published by a person named Rahman. So what he says is he was combining the same principle what Shrikant sir was doing, that you need to have a distal action point. So this is the deltoid now. So what he does is he will take the deltoid and pull it and suture it on top of the trapezius as proximal as possible. So with that now 2 things will happen. You get the stability what you wanted from the bone, and through this deltoid, now the trapezius first acts through the deltoid till the deltoid insertion. So you are increasing the vector arm. So very simple thing, but if in his study they found there was a 12 degrees increase in abduction. 12 degree doesn't sound like too much, but when total is coming 40, then 52 looks like there is a lot of change. OS needle number 1 Vicryl is there? If not there, then normal 10 Vicryl also is okay. That needle is generally is nice. So Prakash, you asked about how to not break that piece, no?
Yes, sir.
So how to not break the piece is, you would have seen in between, one thing is not let somebody hold that piece with the Ellis forceps. That is a common helping attitude, that immediately hold with the Ellis because it can get crushed. And if one area small crack is there, then your hole is at great risk. That is the first thing. Yes. The second thing is when you are fish scaling or removing the saw, not to remove the whole one layer. So you are only making small serrations there, not to remove the whole thing.
Yes.
The third thing is when you are making the hole, make sure that you are there right in the center. If you are in the periphery somewhere, then you had it.
Yeah. And while drilling, use a guide wire.
The guide wire actually we never use. This is, we had one, this is the AIIMS BHUBANESWAR technique. So, but I felt it was nice. Yeah, one only, yeah. It was nice, especially that it made that screw putting comfortable in the humerus. Otherwise, we have to go free hand, no, all the time. So this guide wire was nice only. So I am going to use this technique now. Guide wire technique.
And may I add one more thing? Don't use an oversized screw. If your screw is a little oversized, more than like 6.5, that also increases the chance of breaking the bone.
Yes, sir, true.
Praveen sir, we'll quickly go back to OT2 and come back here, sir.
That yeah, okay, we can go, we can keep seeing. I just want to show how it is pulled proximally in that modification, and after that this is done, this is over. Okay, so that is the last stitch there. So now what I do is I pull it up as much as possible and take a nice bite in the trapezius.
Extra tube drain चाहिए.
Okay.
Not like with the
And
dabba.
we tie like that.
You can just put a
Hold.
drain and put a syringe.
Now you can go.
Needle for suction.
Thank you, sir.
Yeah, Rahman.
Coming to OT2.
Yeah, you're with us?
Yes, sir.
So, when I put this artery and retract, this is the medial arm. So you can see the drain right at the bottom. I put two drains posteriorly, and this is the subcutaneous tunnel. These are the brachial vessels in the median nerve, and this is coming on top. Now this has to be sutured to the biceps. Now I'm pretty sure that after 2.5 years, the patient has got no useful function, so I'm going to cut the biceps completely and take this biceps through the end of this, because this is much wider and thicker. So that is going to be taken through this and sutured end to end. Doing end to side, there are two problems. One is the amount of strength that is required to get the elbow flexion to happen is likely to be more. Second thing is there will be a confusion because I'm using an antagonist. If I do it to the biceps end to side, there may be a confusion in affecting that movement. So end to end is better and it will match also like a pulvar tap. So now I'm going to cut this. I'm going to suture it. I'll keep the elbow in about 100-degree flexion. He does not have any pronosupination, otherwise I would have kept it supinated. There is a loss of active supination and passive supination in this patient. So we are going to keep it in this position and close the show. So, give me the monopolar. I'm going to cut this. It is from length.
So we are back to OT3. Huh. OT3, kindly unmute yourself.
Hello.
Hello? OT3, is it?
Yeah, this is OT3. Praveen sir has just left. So we are closing the incision lines in 2 layers. We're planning to put a drain posteriorly, a negative suction drain posteriorly. And we are going to give an abduction splint, which is going to stay for 8 weeks, 2 months.
Okay, sir. We'll switch to OT2, sir. Thank you.
Nothing, I'm just putting the final touches to this tendon coaptation. This is probably the last stage. Let me see. Yeah, we are fine. Adding just one more for safety. Yeah. Okay. We are going to take our closure and take an extra tube for drainage. Can you hold the knot?
Hello. Sir, am I audible?
OT2, kindly unmute.
What did you do? क्या किया था? अच्छा उसका बाकी है हाँ मैंने सोचा कुछ किंग
Hello, yeah, this is from OT2. We are closing the wound over the cubital fossa and we are going to give a dorsal POP with the elbow in 100-degree flexion. Extend this across the wrist onto the fingers. So that's all from OT2 for now. Shrikant sir is just scrubbed out. Thank you.
You guys can have lunch right now, as sirs have gone for lunch. The next case will be started after post lunch. Whoever has not taken lunch can have their lunch now.
This is a 24-year-old patient who is a shopkeeper by occupation, who is right hand dominance. He had sustained an injury in February 2024. Post-injury, he has multiple body trauma. Post-injury, there was improvement, and in 2025 August, patient has undergone wrist arthritis. This is the video. Here we can see shoulder of 80-degree abduction, elbow flexion M4 with wrist arthrodized at 10 degrees, and finger has zero flexion extension. So in this patient, we have planned for biceps to FDP using TFL grafts. Moving to OT1. OT1, kindly unmute. Can we get the focus on OT table? Thank you for patience waiting. After a short break, we'll now move on to our third case in OT1. This is a 24-year-old male who is a right-hand dominance who is a shopkeeper by occupation. He sustained injury in February 2024. Post-injury, in August 2025, that is exactly last year, he underwent a wrist arthrodesis. This is a partial lower trunk brachial plexus injury. He also had multiple injuries with distal, with the forearm both bone fracture and the lower limb both bone fracture, for which plating was done. Here we can see the shoulder, less than 90-degree abduction with the elbow, M4 flexion. Wrist was, as I told you, arthrodized last year at 10-degree dorsiflexion, and finger 0, that is flexion and extension M0. So he's been planned for biceps to FDP using TFL graft. We are back to OT1. Kindly unmute.
है ना बेटा? और ये
Good afternoon, sir.
Sorry, ma. What
We
is
are
that?
back to OT1.
Yeah. Table little more low down, please. Sorry, tourniquet we can raise the table to go down. Yeah, that is okay. Correct. Thank you.
टूर्निकेट रेस कर दो प्लीज.
On है tourniquet.
सौभाग्य.
टेबल और थोड़ा नीचे कर दे यार. कम. हाँ इतना ठीक है, करेक्ट है. We can start the mic and all. Is okay.
Yes, sir.
Marking na. Is it started there?
Yes, sir. It is.
उधर
It is
start हुआ
started.
क्या?
Yes, sir.
Sir, we're watching you, sir.
Sir, can we zoom out a bit, sir?
किधर है बाइपोलर? रेडी हाँ? ओके. ओके. हो जाए? स्टार्ट है? ओके. So the case what we are doing now is a patient who has spontaneously recovered his shoulder and elbow function. Later he has undergone a wrist fusion. The biceps is grade 4, so quite a nice biceps. So our plan is to use that biceps to improve his finger flexion. So it will be a biceps to FDP transfer using the fascia lata as the intervening graft. We will expose the FDPs in the distal part of the forearm like that. And here for identifying biceps, our standard approach for any biceps exposure is a Z-type incision like that. But if you do a Z-type incision, then the biceps is right at the incision site, and sometimes it may be irritating onto the scar, and 2 patients we had a dehiscence of that suture site. So that is the reason why we don't put any incision in this area now, and we will go from the side and lift it like a flap so that the biceps gliding area remains free of any kind of scar tissue there. Okay. Sorry, this patient, one other problem he has is there is a tightness of the finger extensors. When we flex the fingers like that, we can check that the MCPs are flexing nicely, but after this position, there is no finger flexion possible at all. So that means the extensor tendons are somewhere stuck near to the plate. Also, they may be too tight as well. So we will open up, do a extensor tenolysis and then confirm. Knife. Sorry ji? Yeah. Take sister.
So, sister 20 Vicryl, sister, take one.
That patient is shifted out, sir. Printage is.
But, okay, good, thank you. Caesar, man. Give one mosquito and then 20 Vicryl, please. So for restoring finger flexion in patients with global brachial plexus palsy, there are quite a few options which are described and have been used. The most obvious one is using a free functioning muscle transfer, in which you can use the intercostal nerves to innervate your gracilis and get some finger flexion. Another described one is the brachialis to finger flexor by Bartelli. And this biceps to finger flexor is described by Oberlin, the same guy who the famous Oberlin transfer. The main concern what used to be with biceps to finger flexor is that this biceps is going to give bowstringing. And that is the reason biceps was not preferred by many authors. But Oberlin in their paper found that if you are tunneling the biceps deep to the flexor pronator mass, then you don't have that kind of bowstringing. And that is the real important point in this technique, how to prevent that bowstringing. Okay. And when it comes to the result, what kind of result you get, actually it works quite well. And in our institute, now it is largely replaced the FFMT for finger flexion because gracilis restores decent amount of finger flexion, but the power is less. So if the power is less, then patients are not able to use it for a lot of activities. But this biceps to finger really makes the fingers quite tight and powerful, so patients use it more. Okay, keep it flexed like that. So that's the biceps tendon there. And okay, we can take one stitch there. ये पूरा गया नहीं यार, थोड़ा और लगा. टेक इट मोर फार्दर. या कट करके टेक इट मोर आउट. That's the biceps tendon we have. We want a better length of it, so we will dig little deeper. Take one right angle here. Okay, this one is first right angle also, sister, to me. Okay, somebody take this.
That's perfect.
Okay, so that is fine. Now we will divide it once one more person is there to help us. So that is fine. Now we go on to the finger flexors. Okay. So that's the 1 minute we'll show this one. That is the biceps tendon. And we have gone very low down to identify the very distal part of it because we want a good length. And this is the laceratus fibrosus. We have left that intact. We'll discuss when we are doing tunneling what is the importance of keeping this. Now we go on to identify all the flexor digitorum tendons. Knife, sister. Scissor man. So when we expose the volar aspect of the forearm, the first thing we start seeing is the palmaris longus. And then in the depth we will have the FDS. And here we want the FDPs, so that will be deeper to the FDS. We put one retractor here. So these are all the FDS tendons, and then the deeper would be the FDP. This is the ulnar neurovascular bundle here. These are all the FDP's tendon. We know from the anatomy this is the FDP of the index finger, which will be a separate tendon slip, and these are the FDP of all the other three fingers which are almost like conjoint tendons. So this is our FDP, that is our biceps. So our now remaining job is that we make one tunnel, go deep to the FDS and connect the two. When you are making this tunnel, very important thing is to be deep to the flexor pronator arch. Tendon tunneler, sister? So that is the way Oberlin popularized it, because if bowstringing is happening, then this transfer is not a good transfer. You imagine whenever we are doing any tendon transfer, we try to be in the subcutaneous fatty plane. So if we go here, this is going to lift up so badly that it will look very odd. And biceps, if you are doing the transfer without dividing, it does not have good excursion. And if you divide, you will have a lot of bowstringing. So the way, some technique for preventing the bowstringing was required, and that was the one which Oberlin described. So you go to in the plane between the FDS and FDP. So if we go in this plane, then you will be under the flexor pronator mass under the FDS arch. So then bowstringing will not happen. So you win the game then. Okay, take sister. So here I am trying to be as deep as possible. No, you keep like that, only that. Okay, I'm almost there. No, I'm okay. Okay. So I am at the spot. Once we divide the biceps tendon, then we will get into there. Now we will do this extensor tenolysis first, because with so much of tightness, our flexor tendon will not flex. Take up like that. Knife, sister. So this is seen here. So see, the nice difference is, it is not that MCP joints are tight. MCP joint are flexing quite well. So it is the extensor tendon which is tight and stuck somewhere. A little smaller scissor is there, sister. Yeah, and one morning you gave, no, nice one. Anna is enjoying that, huh? No, you finish and then give it, is okay. What is Anna using then now? Give one different one, huh? That's better. Now let us see how it is. Yeah. See here the extensor tendons are too taut. So even after release of the adhesion, we can see that the finger flexion is not happening. Okay. So in such cases, especially in patients like global palsy, here if you do a tendon transfer for finger flexion, it is surely not going to work because these extensors are not going to let it move. It is just like a contracture there. So that this extensor tendons required to be lengthened at least. Okay. But a non-functional tendon, lengthening is not so much necessary. So we are going to divide these tendons now. Okay, but whenever you are dividing, divide it at a point where in future, suppose you want to do some reconstruction, you are still able to carry out. So don't divide over the metacarpal area, because then if later on if you want to do some tendon transfer for this, you will not have anything to attach, or you will require such a huge length of the graft. Now we cut it and we leave it here. Okay. So in case he requires some tendon transfer later on for finger extension, it will be fine. And now we see that the finger flexion is quite free. And now we can expect this, our transfer should work very well. Okay. So dividing extensors is not any issue at all. But we should have that small possibility that later on, in case anything required, you have a good length of it available. Okay. So now put one skin suture there just to hold it in place.
Good afternoon, sir. Hello.
Somebody talking there, some sound
Yes,
is coming. What is that?
Sir, the question is anything can be done to prevent such kind of tendon adhesions post arthrodesis?
Sorry?
Sir, any specific protocol you follow to prevent tenodesis following wrist arthrodesis?
For wrist arthrodesis. Yeah.
To prevent
you hold like that,
tenodesis.
ऐसे पकड़ो जरा. For wrist arthrodesis, the protocol is that we immobilize till the wound is healed, and in 2 weeks we leave him free. See here in this finger, even after the extensor tendons are released, we can see some snapping happening. Okay, 1 minute. Finger is there, okay. That is fine. Mosquito give, sister. Okay. One vicryl, sister. Yeah, two, just one suture to retain it there, that's it.
Praveen, will you like to remove the plate?
No, sir, we are not removing the plate now. Removing plate as such doesn't have much advantage, especially after some time, because there is a nice film of the tissue which will form on the plate. and we can just leave it there inside forever. And after dividing these tendons, now since we are going to move the fingers immediately, they will not get stuck again. So that's why we are not thinking that we will remove the plate. Ahana, what stage there? You are okay? Yeah, take your time. Want a nice graft. And this one is there, tray, like we made meshing tray, we tell, no? Like that is there. So, mosquito sister, hold it up.
Praveen sir.
Yes.
Can we do the thumb CMC fusion and FPL also? Can we attach to the same graft?
Attaching the FPL.
FPL also. So the transfer, can we include the FPL also in the transfer? With that, the thumb CMC fusion in the functional position.
Yes, yeah. No, that is a good thought, and every time even patients also will keep asking whether why the thumb also not coming like that. But this is a very important point to understand, that when you are having this FPL along, you see, imagine we take the FPL on this along with the FDPs. So whenever you pull, the thumb flexes first. Okay? And if the thumb flexes first, it comes inside the palm. And if thumb is inside the palm, a person cannot hold anything. So that's why, as a rule, the transfer which is going to the fingers must not go to the thumb. It should always have a different motor. Even if no motor is there, it is okay, because here this thumb is going to act like a stable post. This patient would anyway require other hand to open up the fingers. So he will open up like that, open the thumb and place the object in between and hold. So attaching to FPL is not advantage, rather it is a problem if you attach to the FPL. It will not be nice to do.
And what about thumb fusion, sir? Thumb CMC fusion in the functional position?
Yeah, so that is also one option, but what is there is, because every patient is different and his thought of what he wants, what is good, what is bad is so much variable that same protocol cannot go to everyone. So we used to very routinely fuse the CMC joint up like that. But after that we saw that some patients are coming and telling that this thumb is all the time standing up there, it looks so odd. That is one group. Other group, what happens is this web is always so much contracted, so we are not able to get really up. And once you fuse, they will have some subluxation at the MCP joint, and again it will look as if it is falling down. So if you want to fuse, means you have to fuse the CMC and fuse the MCP then. These days, if somebody is really wanting that thumb has to come up, you want to grasp things like that, what we do is we put one bone graft between the first and the second metacarpal. That thing works well. But again, since the thumb is all the time going to stand up like that, some people may not like it at all. So if they are really very keen, then we can plan. In fact, some patients who are very fussy type, those people we will first put one wire and leave him like that for 1 week and let him see whether he likes that new position. Because fusion is one thing which we cannot reverse. If it is fused, means it is fused forever. So you put a wire inside, let them have a feel of how they will feel if the thumb is up, and then we can go and do the formal fusion.
Sure, sir. Thank you, sir.
Okay, now take this retractor here. Turn here. And one retractor on this side. Sister, you come this side, it will be nice. Yeah, okay, this is good. Forceps. So I'm trying to go in the depth so that we have a good length of the biceps. But in the same area you have all brachial artery, brachial vein and all. So we need to be very careful at this stage. One minute, sister. Pull nicely, bhaiya. Okay, knife, sister. Knife, madam. Mosquito, sister. So that is a decent length. So around 5 centimeter of it should be present. And you see we have left this laceratus fibrosus intact, and this is one way of decreasing the chance of bowstringing. And second is that we are going to go deep to the flexor pronator arch. So after we divide this, we have little more space inside. So now we should be able to pass our tendon tunneler. Tendon tunneler, sister. So again, we retract the FDS tendons. So these are the FDS. See, we retract upwards, no? Then we get a correct space between the two. Yeah, correct, perfect. And then I am going deep to this. And which side is this up pointing? Yahoo, Yahoo, Yahoo. Okay. That's our tunnel. Now you see, अभी इसको छोड़ दो. Yeah. See, it is having a real sturdy tunnel. There is no bowstringing at all. I am lifting the whole hand with this tendon tunneler, and we cannot see it becoming prominent. So that means it is perfectly okay there. So that is the tunnel what we are going to use for our fasciolata. So 2-3 times we wobble this up and down so that the tunnel is of good size, and then the fasciolata can easily go through this. Keep it like that. This gauze piece, any bigger size is there than lengthier than this? No. Okay, then keep it like that. We'll go with the fasciolata only directly. No, I wanted something big to pull out, but this is very thin, Nore. This is thinner than fasciolata, something bigger than that. So usually we'll take gauze piece and move it up and down 2-3 times. But this looks smaller. This also will be small only, no, sister? It's small only. Diagonally cut? Yeah. Okay. Try. Okay, give one more suture to me, sister. Vicryl suture again. Not so big also, man. Chalo, okay. Yeah. If thread निकलेगा में, it will look dirty there. Let us do the facial atta itself. Well done, Anna. Thank you so much. देख लो, एक बार दिखाना. Facial atta किया? No, we will prepare the facial atta on this. Facial atta देते हैं ना.
Praveen sir, is it okay if we now shift
What is
over
this?
to OT2 and the case capsule for
Huh?
OT2?
Micro instruments. Huh? Yeah, please. Perfect. Four centimeter only I told no re itna. It's good. Bada is okay only. Okay, scissor. Sir, just now they told we are going to other OT like that?
I'm going.
Yes, sir. Okay.
Just आपको देखने आया.
Yes, sir. हो गया, sir.
ये आपका tunneling वहाँ कहाँ से किया आपने?
Yes, sir. This one only, sir. This is the FDA.
That's okay, but you got deep to the PT.
We move on to the next case in OT2. This is a female patient who has right-handed dominance, who had a road traffic accident in June of 2024 and had a partial injury to the brachial plexus, along with a right clavicular fracture, which was conservatively managed. She underwent a root exploration with spinal accessory nerve to suprascapular nerve, oberlin, which was a monofascicular median nerve to biceps transfer in December 2024. Her shoulders only have a 10-degree abduction. Elbow flexion is M3, wrist flexion is M5 with no extension, and finger flexion is M4 with no extension. She is now planned for a tendon transfer for wrist extension. OT1, we are back with you.
Okay, one new blade required, madam.
Am I audible?
Yes, sir.
This
Yes, sir.
is
You're
from
audible.
table 3. Yeah, we have 43. 42. So we have this patient here in which we had planned a tendon transfer to activate the wrist. She theoretically needs one for the extension of the fingers also, but she has got a poor passive range of motion. Index finger is reasonably alright, but middle and ring are pretty stiff. So it would not be fair to do
Okay,
a
so
tendon transfer
then
for
you
finger
go
extension
around
in
like
such a
that.
case when you don't have a
Even 2
passive
turns,
range of
3 turns
motion.
also is okay.
In addition, she probably
Yeah.
has a weak or
So
absent
you
extension
keep
of the
like this.
EPL, and
Take like that. Yeah, that's good idea.
preoperatively we did find that she has an PL. And because it's a setting of plexus injury, we are pretty sure the pronator teres won't be there. And she had a strong FDS for the middle and the ring finger. We thought we'd use the FDS to the middle to transfer it to the wrist extensor. And we'll also give an incision here and here to correctly redirect the FDS tendon so that it comes here. In the process, we'll also check for the FPL. It is present preoperatively. And if we have to transfer it to the EPL, then the EPL needs to be identified here at this level. Sometimes you need to go here because you need a length, because that EPL has to be redirected and reach somewhere in this position, because the thumb would be kept in this position and the EPL is sutured. It will be sutured like this. So technically it should come somewhere there. But well, we'll start with this knife. You can give 15 now, temporarily. Is it?
Shrikant sir, we'll go switch over to OT1 for now.
I can't.
Yeah, okay. Mic is here on now. Okay. So see how we first initially put in the inside sutures, then we turned around, then put again few sutures, and now I am converting it to a single tube. So the basic idea is all the 7 proline sutures which we have put inside, the knot is not there outside. So all knots are buried in. Because this tendon complex, when it is going to glide, it should not cause some crackling feeling for the patient. And also sometimes if the proline is very prominent, they will have pain also. Not a global palsy patient, but when you are doing for other indications, those patients will tell that they are having a lot of pain. So, but if you have kept most of the proline knots inside, then the pain and that crackling feeling is much lesser. So that was the basic idea in doing that. Eventually, there are some sutures which are going to come up, but they are very less in number.
No, we don't need that. Just check.
So other thing, if you notice, I am making all the efforts to have less number of knots in the distal part, because that is the part which is going to go in the tunnel. So I have started this continuous suture proximally and then making it like a cross and again coming back, and finally knot will be in the proximal part. That proximal part can be of any bulk, because that area we have lot of space, that is not a tunnel there. But this tendon this repair has to be very strong, because patient, especially a global palsy patient, doesn't have much proprioception. They will contract the biceps quite strongly. So, and if this ruptures, then that is a disaster, because the elbow flexion also will go off then. There is always a concern and thought whether detaching the biceps is going to weaken the elbow flexion. But in over 70 patients around what we have done, we have not noticed any decrease in flexion power at all. So that means it does not reduce, and there is a definite reason for why it would not reduce. Because it is thought that once you are taking this biceps and suturing onto the finger flexors, you are making the insertion more distal, and you are kind of increasing the lever arm, because initially it is only attaching here, now it is going more anterior to the joint line. So it would rather become more efficient elbow flexor. So there is no worry that it is going to weaken the elbow flexion, but not very short, little longer is okay. Yeah. But only we have to make sure that it does not rupture. And that's why that much concern, and that's why that many sutures. Take that off. Take this also. Take that also. Yeah. Now hold it like this, please. Now finally few sutures in this area. And post-operatively also, when we are training the patient, they should not do a hyperextension of the fingers. So this much is short is okay. They will pull the fingers into full extension passively and then flex, but no hyperextension. So that's why we are going to put a slab which is on the dorsal aspect, keeps the finger protected from hyperextension. Too much hyperextension again can stress this repair site. Sister, one more 30 proline we require. Yeah, very good, sister. And later only we have still. Yeah, so you see, we put almost 7 sutures down. If you put everything, so many knots will be lying on top, no? And this knot is the one which will give that crackling feeling. Proline is very stiff, no? So in case you are putting more sutures here, then we should use the PDS. Sorry, this Ethibond. Especially when we do this transfer for patient with lower plexus palsy who have some sensation here, no? suture. For first 1 week, you really require so much motivation for them to move, because whenever they move, they feel that this tendon is abrading inside and it causes pain. But if you have less number of sutures on the superior part, then they are okay. देखना कुछ knot ना आए. Hold like that. Hold this here tendon. In the very beginning only, I don't want one knot. Let us do it again. Last time also one knot came, na? So in the intervening part, we can put few sutures so that it does not remain splayed out. Yeah, okay, sister. So now we are ready for our tunneling. Put some saline, sister, here. Let it be nice wet. Yes, so that is our tendon which has come down. Take one mosquito, sister. Okay, we have to pull it nicely, and the test that the tunnel is sufficient is when you flex, you should not feel that it is getting stuck. Okay, there will be, now you put your hand here and feel that crackling, what is happening. No? So that is only when the 5 knots are there. Suppose all around knots are there, no, it will be too much. But initially it will be there. After that, once a slight fibrous tissue forms on top, then that goes off. So now we go to our tension adjustment. Okay. Keep the fingers, who is holding, keep the fingers fully flexed nicely like that. Okay. Okay, one person who is sitting can actually hold it better. Okay, so we should hold in such way that other people can see, because in between you start relaxing means we can find out then. Okay? Yeah, correct, like that. That's why you are holding like that, so that nobody can see. Cat's paw that side. Okay, little bigger one is there, retractor there. You take with one hand, you take another hand, other work is going to come. One more retractor of this size, sister. Keep like that. You are okay? All fingers are flexed nicely? Okay, proline, sister. Hey, what man? These are knots are totally after us today. Not this time. Mosquito. We should understand why this knotting happens. We can put like that only then, and it never comes off. Our applied knot may loosen, but this never loosens. So this is a kind of, I am side itching all the tendons so that they work as a single unit. Cut Manan. Usually 2 or 3 sutures should be sufficient. Not that big, sister, smaller. Make it small. Yeah, get. Okay, so, okay, let us see how the fingers stay once you are leaving. You only pull. So see, the tension is less in the index finger, correct? Mosquito, sister? Take tear. No, now we leave like that, yeah. Let us see. Stitch, man.
Beverages and refreshments are available outside the auditorium if anybody wishes to avail the service.
When we are tying all this, one other thing we should be little careful is make sure that you are not reaching too far. Because if it reaches carpal tunnel, again it will start getting stuck there. No? So we should not have very long one also. So this is the FDS. Now let us see. Only pulling that brings it up. Yeah, that is good now. Yeah. Okay, that's fine. Okay. So now we attach our tendon to this. Okay, now we can leave that. Mosquito. Now anything we hold and pull should be bringing the same effect. Right, because all are joined together. Take this, dear. Okay, we should not lift up. Keep it like that. We lift up now, the tension becomes more. Okay, that looks decent. Okay, sister, braider we don't have, no? Here. Braider is a nice instrument there. Okay. Okay, on proline, sister.
Sir, what will be the position of the elbow while doing these things?
Yeah, so elbow is straight only. Elbow is in full extension and fingers are in full flexion. We have not yet adjusted the tension, we have pulled up. So now you see this is the fingers in full flexion and the tendon is not lifted up. This is pulled distally, fingers full proximally, and the elbow is in full extension. Now we take one bite in this. So one part of adjusting tension is this, that you keep it in full extension and the tendons pulled aside completely. The second part is when you flex the elbow to 90 degrees, you should be able to fully straighten the fingers. So if you are able to fully straighten, that means tension is correct. If you are not able to fully straighten, that means the tension is too much. Then you have to reduce the tension. So this is the two-step check. So positioning is by full elbow extension, fingers fully flexed. Wrist is already fused, so no need to worry about the wrist position. But if wrist is not fused and you are doing for some other condition, then neutral wrist and fingers in full flexion. So now after taking 2 bites, now we confirm whether our tension is right or no. Leave now, leave. So when we flex the elbow to 90 degrees, we can see our fingers are going into full extension. I will show here. Yeah, okay. So that is 90 degrees flexed. We can see a fingers going full extension. And when we extend the elbow, our fingers should go in nice flexion like this. See the kind of nice cascade we have got, increasing flexion from the index to the little finger. That is the kind of position you require. And this middle finger will always be little bit lagging behind. Now I cannot say that this is a perfect cascade, but we should not try to do too much on this because middle finger, third metacarpal has been used for wrist fusion. So whenever you fuse that, you get a little bit of extension of the metacarpal which gives this appearance. So if we try to do more tensioning of this and bring here, then you will note that the patient is not having extension of the finger at all. So after wrist fusion has been done, this cascade is the correct tension for all the fingers. So again, when you flex the elbow to 90 degrees, we should be able to fully extend the fingers. And once you leave it straight down, the fingers should go in almost complete flexion. In mid flexion, you should be able to straighten the fingers with mild tension. If it is like that, that means our tension is fine, and then the procedure is now to just complete 2 more weaves. So it is really quite a simple operation, and since it so much closely gives the result what we were getting with the FFMT, so in our hospital FFMT is reduced so much now for finger flexion, and everything is almost replaced by this transfer only. So now if any questions, any doubts are there, I'll be happy to tell, because these are the critical steps. So again, to summarize, the most critical step is that take the good length of the biceps tendon. The second critical step is get the full passive flexion of the finger. If the fingers are not passively flexing fully, you will not get good result. Then tunnel has to be very perfect. It has to go deep to the flexor pronator arch so that there is no bowstringing. The fourth critical point is tension adjustment. So attachment is done with fingers fully flexed, elbow in full extension. After 2 sutures, you confirm that the tension is correct by flexing the elbow to 90 degrees, and we should be able to fully extend the fingers. So if you follow these, you are assured of good result in this case. And it is one of the most interesting cases for a brachial plexus patient, because
Dr. Praveen, hello? Disconnect. So the question I was going to ask is, now that the flexor tendons are powered, okay, but there are no extensions, no extensor tendon, how do you think the patient is going to extend the finger so that he is able to flex something, hold something? So what is the answer, do you think? Anyone from the audience? Now his fingers are flexed and it remains flexed. How does he extend the finger so that he can? Yes, so it has to be always with the other hand that he extends. So once something is, provided in the palm, no, not, but he can go using the dynamic extension plane. So the last time, as Dr. Prithviraj was telling, the same question was asked to Hari. Dr. Hari Venkatram. And he says, with the left hand, the fingers are made open, and then he puts these two hands in a namaskar asana. That is all he is able to do. So this is definitely not a very popular surgery, because if you do not have any extension of the finger, having flexion is not something that our patients would ordinarily ask for. So therefore, sometimes what patients ask, like in all paralytic hand for any other reason, they go for MP flexion, MP arthrodesis. I'll talk about that tomorrow. So there is a big scope of MP arthrodesis in this position, so that from that point it remains open like this, and then he is able to hold something with the right hand. So, yeah, sure.
Still you think only? Am I audible there, sir?
Dr.
Doesn't
Praveen?
look like.
Dr. Praveen, am I audible to you?
Yes, sir. We heard your comment, sir. That is actually perfectly correct what you are telling. And it is the biggest challenge we have when we are doing this procedure or dealing with all these brachial plexus patients. We have tried many things, sir, but till now none of those things have worked. And truly, finger extension is not there, then the hand cannot be used for any independent activities. So that has to be very clearly and loudly and many times explained to patient, because a patient cannot believe that finger is bending but not straightening. How is that possible? He cannot understand. So the finger will always remain flexed. Patient has to open with other hand, and then only it is going to bend. So our recent study where we are asking the patient after 2 years of all the protocol is complete, that eventually what he is able to do with that hand. So there are two things which all the patients told that they are doing. One is driving a cycle or a two-wheeler. So they open with other hand and put on the handle, stabilize it and drive. Second thing all of them doing is they are able to hold one bag, because this provides a hook grip. So they are able to hook onto a bag. So these two things everyone does. After that, if some motivated person is there, they do little more. Little more is in the sense there was one person who is telling, for me this finger flexion is very useful, because whenever I do puja, I have to use this right hand for holding the agarbatti, and puja I am doing that. So like that, there is no limit of what a positive thinking person can do. But as you correctly pointed out, sir, if the finger extension is not there, we cannot proudly tell that the hand has become independently functional. It has to be all the time dependent on the other hand to open up the fingers.
And that is a very important thing to tell to the patient. Even about this, how much tension to set also, there is a little bit of points to ponder. Some patients don't like that the finger is all the time flexed. So then we started suturing in slight less tension. But when less tension comes, they tell that now I am not having good hold on the bike. So both ways it is a kind of a challenge only. But even then whenever you are deciding, it is better to decide on little bit more tension, because at least you can tell that, see, you are able to grasp something, you are able to hold 2 kg weight rather than it being remaining floppy. So when this patient stands, his fingers will always going to be in this much flexion. This much flexion they will remain. And he will open up with other hand and then hold. So that is the kind of movement he will get. It is basically a hook grip. So that finishes our procedure here. Now we will release the tourniquet. One thing to very specifically look is we must release tourniquet because our tunnel goes very close to the brachial vessels. So on some bad day you may puncture the brachial vein and come out. The artery will not get punctured, but vein can get. Okay, so tourniquet release. One more mop here. Don't forget to close the back wound. Huh? Yeah, please deflate. And immobilization in 90 degrees elbow flexion. The splint coming here on the posterior side, so that he can extend the finger still here and then he will flex. So when we are explaining to the patient very correctly the way to tell, no, when he is straightening the finger, he should not tighten the biceps. Okay? And then he will tighten the biceps and then not keep holding them tightly. He has to let it flex. Okay? And since they don't have sensation, it is really difficult to make them understand. 4 or 5 times we have to teach them that this is how. So when you are extending, the biceps will be loose. So we can put one hand on the biceps and keep teaching him. So then it is loose, and then when he tightens the biceps, we let it flex and not hold it up there. No? Once he is doing, and immediately on day 1 itself, we will start it. And if 1 month he is doing, then the track sets in and then it will be all okay. Just we see there is no fountain here. Okay, now it is fine. Chal, come. Okay, boys, anything? Pad? Anything I forgot to tell or you want to know? Pad kudange? Give one pad, sorry. I'm kudange, man. You should tell at least, give at least. So I told in Tamil, this fellow also not responding. Take like that. Okay, we'll go for the next case. We hold for 10 minutes. Huh? Above elbow, but in the MCP joint, 30 degrees flexed, slab comes like this. So this much space will be there for him to bend. Na? Ahana, idhar aana.
Hello, Praveen sir. Audible sir? Praveen sir.
Yes, tell me.
Sir, around I think in 2018-19 I have attended the conference in Ganga. They have explained about this magnetic globe for the power flexion of this wrist and fingers. What about the magnetic globes now people are using or not, sir? Magnetic globe.
Praveen sir, we are shifting to OT2. OT2, are we audible? Shrikant sir?
Yeah, I've already harvested the FDS and the palmaris longus. I have isolated the insertion of the ECRB. I'm just having a bit of a problem trying to get the proximal end of the EPL to gain length because I need it to go and meet the PL tendon. So once I'm through with that, so you can show. This is the EPL tendon. This is the ECRB. The FDS is going to be inserted here. I am trying to get a little bit of length in the EPL so that the EPL can be redirected to the palmaris longus. एक right angle दे दो. Keep this stretched. Keep this like this. Give me a scissor. यहाँ दिखाओ. Relax it. So this is the one. So I got it here. Yeah. Can you cut this? We are going to cut the EPL proximally. Pull it. Pull. Okay. This is the one. Cut it. Yeah. Pull it. Yeah. So we are done there. So I gave an incision on the metacarpal because I was not very sure whether I'm going to insert it to the ECRB or to the metacarpal bone. But when I pull this, leave it, the wrist is moving up. In patients who have not been splintered and it has been present for a very long time with a severe volar deformity, pulling this may not give the wrist movement. In that case, it is safer to insert it around the metacarpal bones here. But here we'll accept that we are going to suture it direct to the ECRB. And now this one has to be retrieved onto an incision on that side where it's going to meet the palmaris longus. So that is likely to be here at this point. Knife. Down here. More here. Let's get the incision here. Is it? Give me the tunneler. Yeah, that's fine. Oh, it's big. Give me this. Give me a mosquito. Okay, leave this. Now we need to go from the, I'll come that side. Tunneler. No, not this side. Sorry. Tendon retriever. Sister is more intelligent than me. The instrument is actually called a tendon retriever. It's not a tendon tunneler. But force of habit makes us say it's a tunneler. This is a bit Like in Telugu we say Banda instrument. Yeah. Get the EPL. No. Hmm. Give me a mosquito. Okay. This we do second. Okay. I need to go back there again because I want to get this.
Srikant sir. Srikant sir, am I audible?
Yeah.
For the this FDS to ECRB transfer, why we are not
Translate.
doing this proximal to the extensor retinaculum?
मेरे को समझ में नहीं आ रहा क्या बोल रहे हैं.
For FDS to the ECRB transfer, why we are not doing the transfer, or why we are not putting the sutures proximal to the extensor retinaculum?
Can you the more distally that we put for the ECRB, the better it's likely to work. In a standard radial nerve, tendon transfers are pretty straightforward, the results are pretty straightforward, but when you do it in brachial plexus, I want to make sure that it's going to work, and the closer to the joint that you put, the better will be the result. In fact, I had initially thought I should take it round the bone, but because I got a good excursion, I'm going to settle for fixing it to the tendon. But I would not like to do it here, if that's what you mean. The more distally that I put, I'll get a stronger action on the wrist. With a radial nerve, it probably may not matter. Future that.
Okay, sir. Thank you. Thank you.
कोई मैडम को दे दो. Put like a mattress.
Shrikant sir, maybe shift to OT3 to introduce the case which sir is starting.
What?
So maybe shift to OT3 for 2 minutes.
Yeah, please.
Yeah, thank you, sir.
Today.
Am I audible from OT3?
Doesn't matter. What they lose, you gain. Yes,
hello.
Audible, sir?
Yeah.
Now we'll go to the next patient in our OT1. This is a 28-year-old male who is a glassmaker by occupation. He sustained an injury in 2024 June. He also underwent SAN to SSN, Oberlin 1 and 2, SOMSAC in 2024 September. And the patient has gained shoulder abduction, overhead abduction is present, elbow flexion 4/5, extension 4/5, pronation 4/5 with no supination, wrist flexion 5/5 with extension with no extension, and finger flexion 5/5 with no finger extension. So in this patient, he is planned for tendon transfer for finger extension. We are now in OT1. OT3, kindly unmute.
Okay, 250 is okay then. The mic is here, huh? Okay. Yeah, so this patient, the history was, sorry? Yeah, put it on. Yeah, 250, yeah. So, I think everyone has heard the history and the profile of this patient. Inflate, Turnike? All these patients who have an extended plexus palsy and have weakness of the wrist and finger extension, they need to be examined very carefully before we take them for any tendon transfer, because the motor profile may vary significantly. One consistent thing is the FCR will be not there, because FCR is truly a C7 muscle. My stool height increase, somebody? So FCR will not be functioning. The second thing is the pronator teres, which again is a C7 muscle and will not be functioning. So pronator teres and FCR, these are the two important donors whenever we do a tendon transfer for wrist and finger extension. And all our radial nerve tendon transfers are actually based on pronator teres and FCR. So that is the reason why these patients become a very unique set of cases in which these two are not there, but still you have to correct the deficit what radial nerve gives. So then we have to then go to the fingers. Even fingers we have to examine very carefully, because some people the FDS may not be working, some people the FDP may be strong. And if we take out FDS and FDP is not strong, then the finger flexion goes off. So this patient, the profile what he has is, his FCU is working, palmaris longus is working, and they are working quite well. FDS of the middle finger is good, but FDS of the ring finger not that good, not very strong. And if we see carefully, he has some stiffness of the DIP joint here, of the ring finger. So that's why his DIP joint also was actually not feeling very strong. So the donors which we have here are the FDS of the middle finger, the FCU, palmaris longus. And at the wrist, on the volar side, we should try to keep at least one wrist flexor here. Normally, if you go by the rules, if FCR is not working, we should not take FCU at all. But when you do some cheating, at least you need to leave the palmaris longus there. So that's why this patient, we will not take the palmaris longus, we take only the FCU. And we use one of the FDS. FDS we can go to the wrist, and FCU can go to the fingers and also to the thumb. So that will be the plan in this case. Marking. ये स्टूल थोड़ा नीचे कर दो यार. Marking. FCU, one important thing is to have a good proximal mobilization of the FCU, because if the FCU is not mobilized well, it will not have a good excursion. Yeah, correct. Thank you. So this is the pisiform, and from here our FCU incision. We should go till the proximal third, middle third junction, so somewhere till here. The same incision we can use for harvesting the FDS, because FDS is only has to go to the ECRB. We don't require a big length and cutting over there. Knife. So incision need not be right on the FCU. It can be little bit more medial, more central, so that we have access to all the flexor tendons and FDS can be easily harvested. scissor. No?
Can I go to the next OT for audio?
Yes. So once we reach over here, you will see this is the FCU tendon. And FCU is identified by being a tendon till the muscle till its insertion. So the first look itself, you will know that this is the FCU tendon. The ulnar nerve would be lying deep and more central in a separate sheath. So it is not so much of risk that when you are taking FCU whether the ulnar nerve will get damaged. So you need to be really creative to do any damage to the ulnar nerve. It is quite far, it is in different sheath itself totally. Okay. Now cat's paw on this side, cat's paw side, yeah. Okay, so now we want a good length of this FCU because it has to go to all fingers and also it has to go to the EPL in this case. So we try to go as distal as possible. We can reach almost till the PC form and then cut it. Okay, take care, madam. Okay, knife, yeah.
Hello, Praveen sir.
Yes.
15% of the people do not have the palmaris longus.
Yeah.
And in those subset of patient in whom the FCR is not working, and in them, what will you do? FCU?
Yeah. So if palmaris longus is not there, then we should not take the FCU. So in those patients, what we will do is we will use 2 FDS. So one FDS will go to the wrist and other FDS will go to the finger extensors. But we should not take the FCU then because such patients will not have a volar stability at the wrist and eventually end up having a poor result of the tendon transfer.
Correct.
Thank you, Praveen sir.
Yeah, am I
we'll
audible?
quickly shift to OT2. Yes, sir. Yes, sir, you're
Nothing.
audible.
We have closed all the incisions and now it just remains to finish the FDS to ECRB transfer and the PL to rerouted EPL. I initially thought I'm going to put it around this ECRB, but because my assistant is a very good person, I'm going to tell her how to put it around the metacarpal. So here I've already subperiously dissected the metacarpal. I'm just waiting for the correct size of right angle because I had to put it under the metacarpal this way and retrieve the tendon and suture it back to itself. This is even more stable compared to suturing it to the tendon insertion. I have right angle here, but it's too fine, so I'm waiting for one more to come. And once I, get it around the metacarpal this way and suture it back to itself, it's going to be extremely tight. And wrist extension is just assured. So once we finish that, we'll go back and do the PL to rerouted EPL. Let us try. May be able to do. Let us see. Forceps. No.
Srikant sir, Dr. Singh over here. So I want to suggest one thing, sir. If you can take one, if you allow me, I would suggest rather.
Yeah.
So one infant feeding tube, and then.
Yeah, I know. That is how we did in the video that I'm going to show tomorrow.
Okay, sir. Okay.
But, it's a problem of old age. I'm obstinate. I want to do it only my way.
Okay. Thank you, sir. Please.
Because the right angle is actually a pretty good instrument for these difficult situations. Let me try it once. If not, we will follow your method. As our American friends would say, voila. So now, give me a 11 blade. Can someone take a photo in my phone? I want to go back home and show off. Give me an artery. आर्टरी है okay. मेरा फ़ोन वहाँ कहीं होगा Okay, leave it. Now this is what I'm telling you. This kind of a snugness you will never get if you suture it proximal to the wrist. So I can make it really, really tight, and thus I'll ensure that the patient gets wrist dorsiflexion. Yeah. Also suggested when you have a less than grade MRC5 motor, you make it up by making the insertion as tight as possible. You've taken? Take once again. So give me 2 round body proline now. मेरा फोन है ना? ओके ठीक, इसको निकाल दे. 2 round body proline. So you don't even have to hold it. Leave it. Just hold it here. So now be sutured. Yeah. And when we transfer the FDS to ECRB, like Praveen said, you don't have to go to the fingers. Sometimes you don't even have to go to the palm, provided you give a wrist piece incision, and when you cut the tendon, you cut far more distally carefully. As you can see, we have so much of excess tendon, nearly an inch. But it is better to play safe and harvest the tendon in the palm. Because the tendon is passed around the bone through itself, the tensioning also becomes very easy.
Okay.
I hope what I say is right.
Yes, sir. Yes. Okay, sir.
Yeah, come. So here I am suturing now. No, 1 minute. Yeah. अरे यार बात नहीं सुन रही है. This is my needle holder. No, sir. अभी पकड़ लो इसको. अभी ले लो.
Yeah, so quickly you made life. Okay. So this is the FDS of the middle finger. So moment you open the forearm, you will see this kind of appearance. The first will be the palmaris longus, and then we will see the FDS. They are arranged in like this manner. The middle and the ring are the superficial, and deeper one is the index and the little. So the first one we see is the FDS of the middle finger. So we don't have to go in the palm, as
we were discussing earlier. But we require a good length, so we will pull it and then cut it so that it reaches to the ECRB quite comfortably. Take like that, somebody.
Bone, na, without doing this.
Okay, आप इसको पकड़ के you take this and pull this
If you have taken it a
proximally.
bit
Yeah,
yesterday,
good.
then that whole thing will slip. If you take it through the bone, it won't slip. But when you take it round the bone, it will slip unless you do this. Can I make a point to the audience?
Yes, sir.
Can I?
Please, sir. Please.
See, this tendon transfers nowadays we do mostly for nerve injuries, and we don't mind, transferring the tendon to the tendon. But if you if you really have observed the old timers, they were doing a lot of tendon transfers for leprosy, and it was always recommended that it is better to do to a bone rather than to the tendon wherever possible. The reason is all those patients don't have sensation, and just by the usage of the hand, it is possible that the tendon to tendon juncture may stretch over time. So it is at least good practice to do a tendon transfer by inserting into bone wherever it is feasible.
Well taken, sir.
So just दिखाओ.
FDS of middle finger, base of the
बेटा, which sufficient is good enough. You can cut the excess blade. Yeah. Now you hold it like this. Suture, mattress, proline. Whatever, proline or ethylone, whatever you have. No problem, not लग गया.
So that's the EPL. And now we go to the ECRL, ECRB. Yeah, okay. So we have identified the extensor tendons, our recipient tendons. This is the second compartment, the ECRB. And that's the ECRL. And when I pull the ECRB, we can see that there is extension of the wrist there nicely. Okay. And that's the ECRL, which is more radial. So transfer is always done to the ECRB because it is the more central wrist extensors. Okay, so now we bring our donor tendons here. And we were discussing just now, mic is on, no? Yeah. We were discussing that when you are selecting the finger extensors as recipient, you take the digitorum, pull and see. If, just focus it there. Yeah, so we can see the fingers are coming up, but the little finger does not come up that well. So that means this patient, the digitorum slip to the little finger is not that great. For such patients, we should take this EDM and side hitch to that complex. We should not take EDM as such in this complex because EDM vector is different, and if you take that, the EDM is the first one to act and will act too much. In the finger cascade, we want the least extension in the little finger, and it will be opposite of that. So that's why we attach to the digitorum, and then you take the EDM and just hook onto that complex. This is our EPL. We are going to attach the EPL also to the same FCU complex. Okay, this is the ECRL, ECRB. And these are the first extensor compartment muscles. So, see here. So that's the abductor pollicis longus. And this is the EPB. Okay, let us see. So what I am seeing is some people now, I think sir was also telling about rerouting of the EPL. No? So that is also a very interesting phenomena to understand. So why do we do rerouting? So this patient doesn't have a good EPB. So this is all APL. This EPB is so thin and not a very good EPB where we can do anything. Now, did sir explain that rerouting and all why we do like that he was telling, or should I tell like that? Okay, we'll tell. Give one marking. So, see the EPL is coming here. This is the CMC joint, that is the MCP joint. So EPL comes like this. So since the EPL is more ulnar to the axis of the CMC joint and axis of the MCP joint, it is a natural adductor. So it causes extension and adduction. It does not cause that radial abduction what you desire when you have the radial nerve palsy. So that is the reason why we do rerouting of the EPL. You bring it on the radial side and attach. But when you are attaching the FCU to EPL, there is no choice of rerouting available, because when you are attaching to the EPL, the FCU is coming from here. You cannot do any rerouting. So in those cases, okay. So in those cases, what we found is you can just look and find how is the EPB. EPB in 1/3 of the normal population has an anatomical variation where it extends the IP joint. If luckily you are having that kind of anatomical variation, you can take and attach your transfer to the EPB. EPB is in the same line as metacarpal. It will act like a perfect radial deviator. So this is one small paper we published in IJPS some time back. So that is also one option whenever the rerouting is not possible. But here the EPB is not that good, so we will attach to the EPL itself, but we will not be able to do rerouting. But it is not so much big loss, because clinically when you see these patients, because the abductor pollicis brevis is working, it will be able to bring the thumb. Abductor pollicis brevis will move it this way. EPL will move this way. So central vector movement will often come. So it is not so much of a big problem. Now we bring our tendons onto the dorsal side. So you can choose to bring from any side. There is no specific rule as such. But here what we will do is we will bring the FDS from the radial side, because anyway our recipient tendon also is there on the radial side. So we will bring the FDS and put it onto the ECRL from the radial side. Take one artery. Or tendon tunneler itself was there, no? Nice one I saw some time back. Yeah, that mistake sometimes happen. That is the FCU, no? Yeah, so that's why. Sometimes it happens suddenly, and then people standing behind will tell that it has gone the other side, no? So we need to be very careful there. Oh, no.
Praveen sir, we'll quickly switch over to OT2 and then come back to you, please.
Yeah, sure, please.
OT2, am I audible?
Yeah, you are.
Yes, sir.
So we have finished And as you can see, the rerouted EPL is sutured in such a way that the thumb IP joint is extended, MP joint is extended, and it is exactly in line with the radius. This is the radius. So it is kept in this position. Praveen also had been talking to you about the concept of rerouted APL, but this is how it is. Hold this. So now we are going to deflate the tourniquet, dress it and put a POP. So we have completed, we are going to deflate the tourniquet, the wrist FDS to ECRB has been done. You can leave this. The PL to rerouted EPL has been done at this level. Both the donor tendons have been harvested up to the distal third of the forearm. And there is one extra incision because I was not able to retrieve the EPL through this, so I had to give this. That would have given me the length so that it would have gone and met the PL here. So we just apply a POP in this position. The MPs can be kept flexed, whatever is possible because the joints are stiff. But I think that's about it. Done. Thank you.
Thank you, sir. We'll now move back to OT1. Praveen, sir, am I audible?
So FCU, as we were discussing, it is always having a very distal muscle attachment there. So muscle should not be inside the area where you put sutures, because what happens is all the muscle part will get necrosed once the sutures are put all around. And not that the power reduces, but the sutures become loose because a necrosed muscle will be much thinner. So whatever area is going to go in the tendons, we will remove the muscle from that area. So now we are all set. We are going to put this FCU to all the finger extensors and the FDS to the wrist. Okay, so check the come Baba. You now position is very important for this. So now you require a stool. So wrist has to be in 30 degrees extension, MCP in full extension, and IP in full flexion. Okay, you see how I am holding? Exactly like that only we have to hold. Not like this, not like this, not squeezing. So it has to be like that. It should be seen also so that we are make sure that everything is going correct. Okay, because the outcome will depend only at the correctness of the position what you have held. All yours comes on. Okay. So now you see, if you hold like that, no, see this, it is like an opposite cascade. It is not like how I was holding, no. So that's why you sit and you use the same hand what I was holding, no. Come on my side. Come on my side. This is very critical point. See, we need to hold in that type of cascade also. If we hold like that, then it is opposite. It has to be exactly like that. Come, take. See, skin also should not wrinkle. Yeah, otherwise we'll get a false tension. Now you go to the wrist down. Perfect. 40 pulling, please. Yeah, that is perfect. It has to remain like this only, okay? Yeah. No, not correct. Okay, mosquito. Small mosquito, 11 number blade and 40 proline. So these are the 4 tendon slips where we want to do the attachment. Okay, आप इसको ले लो. Come, take this. And not lift up, just keep it down and then pull it like that. And nicely pull so much that we feel that this tendon is lifted up like that, no? Okay, forceps. Tips is it? This is the FCU. FCU will go to the fingers and FDS will go to the wrist. So when we are deciding where to put what, that time we should think of the synergism. Okay. So now finger flexors and wrist extensors are synergistic. Okay. Wrist extensor. Because synergism, how it is decided is, there are muscles which act in the gripping phase, muscles which act in the release phase. So when we grip, our wrist goes in extension. So they are the muscles which are synergistic. When we open the fingers, wrist flexes. So that is the synergism. So now what you are doing is you are taking FDS finger and putting to the wrist. Very synergistic. You are taking the FCU and putting to the finger extension. Very synergistic. So they perfectly match. Other option could be we can put FDS to this and FCU there. That is not good. Because FCU putting to wrist extension is you are asking it to do an opposite work. It was a wrist flexor and now you are making it wrist extensor. So it is not, brain-wise, it is not a nice combo. So since they are synergistic, it is better to attach it to the finger. FCU go to the finger and this goes to the wrist. Okay, come little bit on my side so that we have a straight line of pull onto that. Okay. Okay, one thin artery was there, no? Give that one. Okay, now one person to hold like that in the same direction exactly. Yes, that is good. You are okay with that? Yeah, okay. Fingers keep like that. Okay. Suture bhaiya. So here 40 suture only better because 30 needle is much bigger. So sometimes it may just rupture off that extensor slip of the finger and make the procedure very complicated. So 40 is the suture to use. The first and the last attachment only is the critical. Intervening ones, no problem. So that's why in the first and last one you put one extra tag.
So not on the outer side is better than the underside, sir?
Actually, if it comes on underside, it is good because patient will not feel. Okay, but underside always is like little bit more tough. So it takes little more time, no? So all the time there. So then the other way is when you are closing, no, you close in two layers. So the fat layer will come, so it is negated. Previously I used to make it like a very serious point that knot should come underneath. But it takes 10 minutes more, not so much difference. It is only like we feel that it may be like that. But yeah, we give one layer of this fat, it is the same then. So if you see some old videos from our hospital, it will come as if doing like that. Then some people will come and tell previously you are doing like that, now you are not doing like this. But we also improve now with time. Knife. So here you see I am going in a very oblique manner like that. We should not go transversely like that. If you go transversely, what will happen? All the tension will go to the first tendon and other tendons will not receive so much of tension. So if you want to have equal tension in all the slips, then we have to go in an oblique direction. Yeah, correct. Okay. And the first one should not become loose. If it is becoming loose means we are pulling it more than what we require to. Or because the wrist extension has increased. Okay. So now you see that become loose, previous one. So that means our tension is more in that. Tension should not be more. Because if tension is more, then it will act only on that tendon. All slips should have equal tension. Then only we are going to have a good movement. Okay, there should not be any lag after I leave. See, lag is happening. Pull little more. Yeah, good girl. Like that. This is not Johnson Johnson and these sutures. Yeah, because in this, no, all things are different, man. Dimensions of.
Praveen sir, maybe display the details of the next case.
Here, let us have the mic for some time. We will show now the suturing is over, no?
Yes, sir.
We
Sure,
are
sir.
going to show the tension adjustment, whether it was right or no.
Sure,
It has
sir.
to be right only because we have finished it. Yeah. But since our friend was holding it so nicely, I think it will be correct tension. So if somebody is not holding properly, then it is better to check after one or two sutures. So, but since we are very attentively holding it, I think it is nice. So it all depends on position only. If we are holding correctly, pulling correctly, no tension has to come fine. Okay. Okay. Knife, please. Knife. 15 number is there. Take this 40 suture is here extra. So 30, one last bite. Okay, now let us check. Very difficult to hold, no man. See, your position became 90 degrees. See, wrist. It is very difficult to hold, I know. Okay, leave now. But till the important point, it was okay. So that's why it didn't disturb you. So see, it is nice, perfect. Well done. So the little finger requires little augmentation, otherwise it is good. Take, please. So this little finger, I will just tie to that mass there. I'm not planning to put it very tight or anything, just holding it upwards. So always the last one, no? I feel like we should have little extra stitches onto the last one. Today is the day of knotting, huh? Keep it up on the finger. Okay, so now we go to the wrist. So that it is always a nice controversy and a debate question whether you do the finger first or the wrist first. So, but theoretically, if we are telling in exams, no, it is always good to tell that I do the finger first. Because if you have done the finger first, you can flex the wrist and you can see the tension. But if you have done the wrist first, then you cannot flex the wrist. So you cannot check whether the tension is okay or no. Okay. So theoretically, yes. But practically, people do it either way. And you can get good result with both the things. Keep the wrist 30 degrees up now. So that's our ECRB. So we should touch to the bone and lift. Only that much lifting we should do, not more than that. Wrist only 30 degrees, not more. This is a big tendon, so here the usually attachment is not so much of challenge. Here problem is you will have the muscle coming inside some cases. So remove. So if muscle is coming inside, then we have to remove that part of the muscle also. Otherwise, this is quite a straightforward thing only. So imagine if we had gone to the FDS in the palm and all, how long it will be. It is not required to be long at all. This much only we require. Okay. Not pulling too much, no? Chodo jana. Yeah, this is correct. Yeah. Okay. Okay. ठीक है भैया. Here we should put 2 sutures and then check whether it is fine, because suppose it is not okay means we should make it tighter. Wrist and all the extensor transfers, as a general rule, we should not have more tension in them, because one of the principle of reconstructive surgery is flexion should not be compromised for extension. Because functional thing is mainly flexion. So if we make the transfer very tight, especially the finger extensor transfer, if it is very tight, no, patients will have lot of functional disability. So in fact, it is very commonly told that suppose tension is more in the finger extensors, no, if you pick some small thing, they will pick like this. Because moment they flex the wrist, the fingers open up. So the good result of tendon transfer is not this. Good result of tendon transfer is this. So you should be able to pick up something in neutral position of the wrist. That means your tension is good. So after putting 2 sutures, we check. It should remain, it should not fall into full flexion. It should remain in neutral to 10 degrees extension. If it is more than 10 degrees, that means it is more and we should revise it. This one is maybe, okay, this looks little more, no? It is okay, I think. I think it is okay, it is just fine. This patient, if we see, no, that's what I was asking whether he has ligament laxity. He has little bit of volar concavity. So this is typical of patient to have VC deformity at the lunate. So the lunate is flexed like that. So he has kind of wavy appearance. But if we see this, this is good. This is fine, I think. Chalo. So once the tension is fine, then we just complete this with 1 or 2 more weaves. Knife. Put inside here. Take it. Okay, take like that. So our tension is just right, so I don't want it to become tighter, so that's why I'm pulling on my side and then taking the suture bite. Okay. Now you relax this one, not too much tight. Yeah. So here again, it is very, so suppose you are not biomechanically thinking, it is very difficult to leave the ECRL. Everyone thinks like, there are a lot of people who will tell, no, we attach to both. God has given two means, why to leave one intact like that? So like that some thoughts will be there till you biomechanically think. If you think biomechanically, not that whether we can attach or no, we must not attach to ECRL. Okay? Because what happens is, ECRL has got the larger momentum. Okay? So if we attach to ECRL, then ECRL will act before ECRB. And if ECRL is acting before ECRB, then patient will have radial deviation. He will not have much extension. So we should not attach to the ECRB. So there is a very nice biomechanical explanation diagram by Brand in one of his book chapters. So I will draw that diagram one. So that will give a very nice explanation of why we should not do to both. So that seals our transfer here. Take one marking pen, brother. Okay, cut this please. This scissor is very interesting. I have never seen this type of scissor. So in the other OT, I was telling something, I have never seen this. Then person assisting, no, he was telling to sister, one pack for sir. So don't think everything I am telling to pack for me, man. Okay? Okay. So now you see Brand, no, very nicely describes in one diagram that we can think like ECRL and ECRB are two wheels which have a single rotation point, but a different momentum. And this is the rope attached to the wheel. Okay? So if you pull both of them together, which is going to move? No, if we pull one, which will we move? Inner one? This is bigger, this is smaller. So which will move first?
Bigger one will move, man. Yeah. This is having less length, no? So when you pull, first tension goes in this. So they are like this. So even if you don't remember which will move first, they will not move together. No? So they are of different momentum, and if you attach to the same thing, they will not move together. If you put more tension in ECRL, only that will move. If you don't put more tension in ECRL, then why to put also? So that's why we must attach only to the B. Okay, big B. So this finishes our operation. Now everything is over. We release the tourniquet. We put subcuticular sutures. Okay. Our slab will be wrist in 30 degrees extension, MCP is in 30 degrees flexion, IP joint in full extension, like that. Yeah. And thumb in palmar abduction, like this. Palmar abduction in such way that it is in line with the outer border of the index finger, like that. Okay? Chalo ji.
Thank you, sir.
It's very painful, man.
Sir, may we show the details of the next case now? With this, we come to the last. So this is a live operative session of FFMT done prior, transferred to the FDP. So it's a 27-year-old male who had a history of RTA in June 2022. So currently it is 4 years and 2 months post-injury. He suffered a partial brachial plexus injury involving the lower trunk. Initially, he has not gone any primary nerve surgery. However, he underwent a secondary procedure that was a free functioning muscle transfer using the gracilis on 8th of December 2023. Currently, here are his movements. Shoulder is showing a active abduction of 110 degrees and overhead abduction with support. Elbow is flexion of M5. Wrist shows 20 to 30 degrees extension, and there are no finger movements. The plan for this case is FFMT to FDP transfer using a TFL graft. OT1, are we audible?
Yeah. Are we audible from OT1?
Yes, you are audible.
Yeah. Praveen sir will be joining in OT1 shortly.
Hello, Praveen sir. Are we audible?
Hello, yes, am I audible there now?
Yes, sir. Yes, sir. You're audible.
Yes, okay, good. Then we are now starting the last case of the day. This is just to convey one more concept that when you are having the elbow flexion restoration done by free functioning muscle transfer, in those cases we don't divide the biceps tendon as we did in the last case. So here what we will do is we will attach in continuity. Foot switch, sweep. Here, there. Okay, I got it. Yes. So here FFMT is working very well. It is giving a good amount of elbow flexion. So we are thinking whether the same can be transferred to the finger. So that's what is the plan. See this foot switch, something happens in between. It doesn't make sound, huh? Oh. Her bipolar making more sound. Take 120 Vicryl. Clip is there, huh? Oh yeah, then give the Liga clip. Yeah, that is good. The white one, bigger one is there? Yeah. One more. Okay, now give the smaller one. Number is there in that, 100. Ours is all color coded only.
Red and white.
Okay, yeah, that one ours is like white, blue.
Another one is just 64.
Okay.
This lower, lesser than this. This is 200 and that is now sensory.
Yeah. Yeah. Keep the elbow little flexed now. Yeah, so this is our. So the my mic is on here, huh? Okay. So this is the the biceps tendon, and we can see some sutures here. So that is the attachment of the gracilis which have been done here like that. And because of that kind of attachment over there, no, it is not very easy, or maybe I should say it is little risky to actually cut it totally. So that's sorry. This is the tendon of the biceps. So we will hook onto this tendon our fasciolata graft and attach it to the FTPs distally. So that will be the plan. Only a little bit of difference and the challenge in this is, since the tendon is already there, making a tunnel becomes difficult. So tunnel comes exactly at the place where the tendon is coming. So if tendon we have cut away, then we have lot of space. If tendon is not cut, then the space is less. So that is the difference. Otherwise, we will go deep. No, deep to the flexor pronator arch. So attachment of the tendon is to the radial head there. So that is much lower down, even 1 more inch lower down. When we are coming out, if we are coming deep to the flexor pronator arch, we actually often become deep to this tendon. If we come deep, it is good. So if it is coming superficial, then we are not in the correct plane. So if we are deep, it is always nice. No? Tendon tunneler is there, that same long one. Yeah. So here I am making more proximal incision just to decrease that length of tunneling. Scissor.
Praveen sir, would you please tell us one more time that why we are not dividing the insertion of the biceps?
Yeah. So here, removing the insertion of the biceps, we are not doing because this is not the renervated biceps, it is the free functioning gracilis which is attached to the biceps tendon. So in that we are having a small fear that that free functioning gracilis may not function better, or it may become loose because it is set in that proper tension. So that's why we are not detaching. It is not a proved thing that sometimes any problem has happened, but that is just like a fear that it may lose its symmetry. So that is the reason what I am telling. And also once you have attached the gracilis, you generally will be winding around that area. So even if you have detached, you are not going to get a tendon like what you get when you are doing a normal biceps you are cutting. It is not going to have that kind of glide because muscle will be coming almost till here. So maybe you will not have the advantage even after cutting. It will be moving almost the same what it moves otherwise.
Sir,
that's what I'm telling.
Sir, one query. There is, in this case, there is a free functioning gracilis that is there, and you will transfer that. So,
yeah.
You had previously it was done for elbow flexion. Now, after the transfer is done, this time when what will be the
30.
elbow flexion? मतलब वो कैसे होगा? वो elbow flexion? मतलब gracilis तो आप transfer कर दे रहे हो, तो मतलब elbow flexion के लिए क्या रहेगा?
No, the transfer is done for elbow flexion. So elbow flexion we don't want to disturb. We are just putting in continuity that to the finger flexors. So now it will continue to do elbow flexion, but it will create a stiffness to the fingers. And that same power which goes to elbow is going to flex the fingers also. It actually, I should not say that it causes very great finger flexion. It only makes the finger flexors stiff. So that stiffness only patient uses like a hook grip. Hold like that.
Okay, thank you.
I think it is a secondary salvage type of operation, and it is good only if no other option is there. I must say that also.
What
30 proline, side itching all the flexor tendon.
You have put that one.
No, little fingers it was going into more flexion. So,
Side to side tenodesis.
yeah, just to make sure that they are in the same tension. Okay, we leave that. Let us see now. Yeah.
Sir, Ramaswamy is from Salem only.
Yeah, I know. He's
Near to Coimbatore.
yeah.
It's a bigger
So the little finger, even after doing that, no, is looking like more flexed than other fingers. So
You want only hooking,
hooking, but symmetrical hooking. Should not be like little is pulled so much that and others are not pulling so much. That also doesn't look nice, no? Yeah. No, knee it is. Okay.
Now he is pulling index and middle finger.
Index and middle finger. So that means this patient has so much of interconnection between these tendons that even with pulling two, everything is coming down. Cut me. We'll put. That is decent, yeah, that's better. Take now.
What is your other hand? Is it omelette? Cutting. Only for cutting.
Okay, so that is fine, I think. Yeah, okay. And tendon tunneler.
So you are putting your finger at the level of FDP.
I am deep to the FDPs, like superficial to the between the FDS and FDP. And I am almost palpating the pronotoris. So I am under the flexor pronator mass. Okay, now leave this hand down. Little bit flex. Yeah. Put your hand here. Yeah. Wrist any position, like it comes in the way otherwise. So this bend is facing upwards like that. Not too much bend, little bend only.
Will be radial to biceps or ulnar to biceps?
Radial. One cat spa. Take this one. Mosquito.
Addition, sir.
No, if the biceps is not cut, no, the space is less. That is the fish.
Now you are ulnar.
Yeah. Okay, so that is our tendon and there it is going to go. No, gauze piece is our length is less here. So last time we did straight. So we are okay. Sorry. Facial atta आया क्या?
हाँ. Hey, facial atta हो गया?
Yeah, okay. Yeah, take your time. It is okay.
Single.
इसमें से this cotton is like more flimsy. इसमें से cotton निकल जाता है. It's not looking like Salem cotton. Salem is famous for the cotton and all, no man? Tirupur, but yeah, we can drag there also. Tirupur is famous, but all rich people having cotton business are in Salem.
And this Manchester, no sir?
Yeah. Manchester, South India. Okay. Chala, so this is here, then that is there.
Wow. Sir.
वाओ, ये थोड़ा छोटा लग रहा है मैडम. Length is less, looks like. Sorry. Okay, let us see.
Sir, the reason for keeping the lacertus fibrosus intact, you told last time, I will tell.
Sorry?
The reason for keeping the lacertus intact.
Yeah. No, laceratus is intact is one other way of preventing the bowstringing if you are dividing the tendon fully.
Okay, so that is the second restraint other than the flexor pronator mass.
True, correct, yes. Yes, right. Okay, give a knife.
Sir, I have board.
Board is there. Give board also. This is looking like vegetable cutting board. No, don't pull, otherwise that tension. This arranged by you, so that your microsurgery set can escape. Okay. This is perfect actually. Okay, 30 proling.
Stabilize, Amrish, stabilize the graft.
Like this, threads come out of that, man. Very dangerous, that one. Okay, just hold. Okay. So, take this, sister. Okay. Okay, put some water. It should not slip off in between. Okay, having good hold. Water, 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 water. Yes. Okay, mosquito. Okay. Hmm. Just, okay. Take this elbow like that. Deeper retractor, one more, sister. Yeah, deeper retractor. One more deeper retractor, sister. Hmm. Hmm. Yeah, come take like that. Yeah. Okay. Yeah. Knife to me, sister. Eleven number blade, madam. The tendon visibility should be better. You can flex the elbow a little bit. Yeah, that's good. Yeah. Did you all measure and cut? Yes. It was 27, huh? Yeah. More than that, huh? Oh, I don't want to measure then. Good. Okay. Okay, 1 second. Okay, 11 number blade. Hmm.
Sylvia, hold this retractor.
Only this much, huh? Because we don't have too much length. Yeah, okay.
30.
Cut one.
Filaments are separating.
Yeah. Which one you are using then?
All the filaments are separating. Oh, I thought he came here. That's why I went outside. So you have pierced once, no?
Which one?
This one?
Yeah, one's pierced, one overlap area I am suturing now. It came out from the same tunnel, no? Now two piercing minimum, but it is, since it is around, I think
Hello.
piercing and all also not
I
so
urge
much.
all
It
the
is going to
people in
be
the audience
all
over
around
here in
only.
the
So
auditorium to kindly
knife.
stay back, for we have something more planned as in form of arts and entertainment. So please stay back. Thank you.
Okay, you leave this artery. Leave that. Yeah. LB is the new word I learnt, man, here. Yeah. Suture. So orthopedic oriented theaters, they very commonly use terminologies.
Sir.
Like very correct names and all.
It is connected.
Yes.
Sir, any important procedures to be told to the audiences?
What is that?
Any important procedure left to sir tell about this procedure?
Important step.
In this?
In this, sir. Any?
Yeah, this procedure, I think the only important step is to get into the correct tunnel. When you are creating a tunnel for the graft, it has to be deep to the flexor pronator arch.
And that is the first important thing. Second thing is the tension, which we will see now.
Yes.
Sir, if you will allow, then we will switch to the cultural program.
Sorry, what is that?
Sir, we want to start cultural program in the auditorium.
Yeah.
If you allow, then
Yeah, I think we can start because it is almost the same we did know in the previous case.
Yes, sir.
Only difference is here we have not divided the biceps tendon.
Yes.
It can be started.
Yes, sir. Thank you, sir. And I think we should have a big clap for both the faculties. We have almost completed 10 cases. So, Srikant sir has done 3 cases and sir has done 7 cases without any interruption. I think he has taken 5 to 10 minutes of lunch only. So, big claps for sir. Thank you, sir.
Thank you, dear.